we had the first conference, I invited a bunch of people to Toronto in January. And people said, why would you want to come to Toronto in January? Isn't there a nicer place? Michael Reardon from Houston is one of those speakers, was one of those speakers back then as well. And I thought maybe I should do it in Houston. But when I looked the other day, Houston had more snow than Toronto. They had 6 inches of snow. That might be Mike Reardon trying to get the work there. But it's cold everywhere. Our co speakers are in places that are cold right now, but it's in Toronto, and fortunately, it's all warm because we're all online, and we have been for a few years now. Before we start this conference, I'd like to have a land acknowledgement. It's a very important thing these days, not only in North America, but really around the world. And it just shows a unique and endearing relationship that exists between Indigenous peoples and their traditional territories. And how we all have to be careful to recognize that we all are on borrowed land, and we have to respect those who were there before, and to continue to respect each other in all the areas of the world. As I said, this is the 10th conference on cardiac tumors, and it's an ongoing free online resource with previous speakings and full lectures given by world leaders. I've been really fortunate to be able to ask world leaders to speak on their topics, and they've all said yes. So they're all recorded and all on the website, and they're all in previous years on both malignant and benign tumors. It truly is a living textbook on cardiac tumors. If you look on the website, just look up, I want to say Google, but you can use whichever means you want. Look up the Toronto Cardiac Tumor Conference, and in the top corner there, you'll see past presentations. And that's where you'll be able to find the lectures of previous years. You'll be able to, if you have a patient with a particular tumor type that's been discussed, you'll be able to see what's best known in that particular year by the world's experts. And it's still quite up to date. I look at it from time to time, and I do send people who have tumors who want to learn more onto that resource. It is webcast. Right now we're on Zoom right now, and we're on YouTube. And because we're on Zoom, speakers can discuss with each other, and attendees can ask questions online, and I can send those questions to the speakers as required. We must give thanks to those people who helped us to make this possible. I work at the Peter Monk Cardiac Center here in Toronto. Ontario Health is the overseer for cancer care in my province, and the Society of Thoracic Surgeons have given us the nod for the whole 10 years we've been here. I have to thank especially our co-chairs and the planning committee who've all worked very hard to put this together, as well as the speakers, who without which we would not be able to have this conference. There is no conference without attendees, and to thank all the attendees who are here today, and for all the people who will join the website in the future to look up different things. And special thanks has to go out to my assistant, Edith Dingle, who's worked very hard. She's stuck on a train right now, but she's works very hard at all times. Henry and Barbara Bank have given me the financial support in order to do what I have been doing with the Toronto Cardiac Tumor Fund. And I like to call it the Henry and Barbara Bank Fund, but they won't allow me to, but I want to thank them here today. So what's the problem? The big problem with cardiac tumors of the heart or tumors of the heart is that they're very rare. And where do physicians go when they have a patient? You know, recently I was called by somebody who had a patient who had a cardiac tumor, and they had no idea where to go, how to do things. I had a little conference with them. They got together with the people in their group. It was down in Brazil, and they didn't know how to actually start with this particular patient, what to do. So where do physicians go when they have a patient? Where do the surgeons go when they have a patient? Again, I've talked to a lot of surgeons around the world and helped them to decipher what to do next and how to approach this particular kind of tumor. Most importantly, though, where does a patient turn when diagnosed? Like all of us online today, all of the speakers and co-chairs, we've all been emailed by somebody from some part of the world who's had a problem, and they've gone onto the website, found us all, and asked us for help. And sometimes we can direct them someplace. Sometimes we have no idea where to direct them because of their location and our lack of understanding who is the expert in that particular place. So the vision of the Toronto Cardiac Tumor Conference and my efforts in the cardiac care for cardiac tumors is to improve the care of people with cardiac tumors around the world. That's the vision that I have. And my mission is to develop a subspecialty of cardiac tumor care. Every year we get more and more people interested in this, and there's more and more traffic to the website. And I'm hoping that slowly it's going to develop a subspecialty of cardiac tumor care. It's very rare. but it is required. If you have that problem, you need somebody who's a specialist in it. It's also to develop a global network of centers of excellence in the diagnosis, treatment, and care of patients with cardiac tumors. As I've said, sometimes we get an email from somebody, we don't know where to send them. In that respect, we've been working for the past few years, and some of our co-chairs and speakers are part of that initiative, is to develop something that somebody coined the Interact project, which is called the International Registry to Assess Cardiac Tumors. So that's one of the ways to get people around the world together with this respect. I'll talk a little bit about that in a little while. So we will use real live cases in this conference as we have in the previous conferences. Some of the details may be changed a tiny bit in order to get the point across in some of the instances, not necessarily all of them, but they are real life cases with real life problems and problems to deal. They will illustrate the difficulties in diagnosis, especially in planning and treatment as well. That's what this conference this year is about, the treatment. We have an illustrious panel that we always have, and we do today, to illustrate the collaborative effort involved with these very difficult cases. And it will demonstrate the advantage of an international collaboration in cardiac tumors. And finally, we're going to demonstrate with this conference the reasoning behind the Interact project, why it's important to have an international and global network of individuals who have a light mind about these sorts of things. So the goals in 2025 are to learn about immunotherapy for cardiac tumors, including the use of vaccines and viruses. I've been thinking about this for a few years, and I'm a little bit embarrassed to always ask people, do you think it's worthwhile to talk about this? But Vino Ravi and I were talking about this a little while ago, and I said, what do you think? This is my idea. He said, oh, it's a great idea to do that. So I'm glad that we decided to do that topic today. And also one of the goals is just to know about the progress in the International Registry, the Interact project. It's not very much, but at least it's some progress. The objectives in 2025 are to explain the role of checkpoint inhibitors in sarcomas, both as targeted and in combination therapy, describe CAR T therapy, explain the uses of cellular and vaccine therapies in cancer therapy, and again, to describe the Interact project for those people who don't know about it and its benefits. We have a large faculty in 2025. In the past, I did not put our fellows and trainees in here, but I thought it's important to include them as well because it's a big team project and a big team endeavor. And you can read through these. You can see they're from many different parts, but you can go onto the website under participants and you can see them as well as their photographs on that website. So you can learn a little bit about each one of them because each one of them is associated with a biography. So this year is the immuno-oncologic applications in cardiac sarcomas. I think it's a very topical topic, and I think it's a very interesting one and one that I don't know much about, so I'm really looking forward to learning about this. But first, we're going to talk about the Interact project, the International Registry to Assess Cardiac Tumors, just to give you an idea what this project is, and also to give you a brief update about what's happening in it. There have been, up until recently, there were very few papers in the literature about cardiac tumors. The biggest one was a French registry that had a very few number of patients discovered in France. More recently, in the past, say 3 or 4 or 5 years, there have been some bigger papers, and I just chose one of these papers, Survival Outcomes in Patients with Primary Cardiac Sarcoma in the United States. This looked at the SEER database, and they found 10 million people who had sarcoma in the United States in these 42 years. So quite a lot of sarcomas. But in the malignant cardiac sarcomas, they found 786 tumors in 42 years. Of these, they excluded 291 patients with non-sarcoma malignancies. And they found primary cardiac sarcoma in 442 patients in 10 years. So if we took the total number of cardiac tumors as 19 per year, if we look at those people who had non-sarcomatous cancers, there's only 7 per year and 11 per year if we look at primary sarcomas. So when I talk about rare, I really do talk about rare. It's maybe not as rare as snow in Houston, but they're still pretty rare. Okay, I got a smile out of Vino there. But the point is it's very, very uncommon. Now, this is one database, and this is the problem with trying to find patients with sarcoma. There are recent papers looking at hospitalizations for cancer of the heart, and that shows a little bit more patients. But in general, it's a not very common condition. If you look at the early years between 1973 and 2005, and the latter years, 2006 to 2015, you could see that there are more patients coming forward with a diagnosis of cardiac sarcoma more recently. And that's a good thing. It's more perhaps because people are coming forward with them. It's probably more perhaps because people are getting a little bit better at treating them, so they're willing to take more people on, so they get into the SEER database. But I don't know what it is, but it is getting more common. And whether it's truly more common or whether it's just an idea of identification, I don't know. Just to show you what the issue is and why we continue to have these meetings, this is the outcome of these particular patients. The top left-hand corner shows the early years versus the later years. The mortality has not changed. This one here shows angiosarcoma is worse than non-angiosarcomas. It shows that operations do benefit individuals compared to no operation. And it shows that when you add chemotherapy to an operation, you improve the outcome for the first little while. So there is quite a lot of work to do. It'd be lovely to push these lines even farther to the right. And that's what meetings like this are all about, to try to get people together who are working towards this goal. So perhaps we can have some collaboration even through the website so that people can work on this goal. So there's still a long way to go. It's still a dismal mortality. And there hasn't really been that much of a change, really no change in the early time versus the later time. But it's something we are all working hard to get going. And perhaps something like this may help us to move toward that needle towards the right side a little bit. This is going to be an idea about what the reasoning behind the international database is. So here's an early paper, a 17-year analysis of primary cardiac sarcomas. And these people found that if you have an R0, in other words, a complete resection, your survival rate is better than if you had either R1 or R2, which basically fell down to the ground. This in 17 years, this particularly people in China. And China seems to have a big number of centers dealing with cardiac malignancies. We do have a person from China on our database. But in 29 patients over 17 years, they found that there was quite a signal for R0. If you look at the Houston group, and they are the most advanced group, I think, that I can see with big numbers in the world and are looking at this specifically. They did a larger series of 44 patients, 32 people. 32 of those 44 patients had neoadjuvant chemotherapy, and they also found a signal of R0 being statistically better than R1 or R2. They found that when they had neoadjuvant chemotherapy, they had an R0 result in 47% versus 33%. So perhaps giving people neoadjuvant chemotherapy resulted in more R0, which subsequently translated into better survival. And that's, I think, where we got the notion of giving people with cardiac sarcoma neoadjuvant chemotherapy. Unfortunately, as their numbers grew, instead of 44, recently they looked at their series and they reported their series in 2023 of 122 patients, all the patients they had amassed in their series. And unfortunately, when they got the numbers from 44 patients to 122 patients, there was no difference. And so what that shows is that the more numbers you have, the better you can actually see the truth. So 122 patients in 23 years is about 5 or 6 per year. The first 12 years, they saw 52 patients with 4 or 5 people per year. And more recently, they've seen more, 10 per year. Now, that was done in 2023. And Vino can say that because I'm part of the tumor board that they have once a month. I join that meeting. And I'm sure they would like other people to join as well if they have cases that they want to present. But there's probably more than that now. But they have probably the biggest catchment of the whole of the United States and maybe the whole world in terms of these patients. And they only see about 10 people per year at the time of that report. So the INTERACT project was conceived because the numbers are very small. You can't study anything well. When I started thinking about this, those large series of 400 patients, 600 patients were not there. And you can't really deal with this with one institution. For instance, the Chinese institution had 29 patients. Even Houston had 122 patients over many decades. So the numbers are small. You can't do a single institution to find truth. You can't even find a whole country that does truth, because even there, when you looked at the whole of the United States, the numbers were very small, 11 per year. You need bigger numbers. You truly need the whole world to collaborate in terms of finding numbers big enough that we can actually start to find the truth, start to collaborate, and actually start to do some studies. One of the studies I want to do is radiotherapy versus surgery as a primary treatment. We can't do that right now because we don't see enough, but if we got the whole world together, perhaps we could. So we're trying to capture all cardiac surgical centers and all oncology centers around the world. This will allow us to identify higher volume centers. So if that person gives us a call from, I don't know, Bangladesh or something like that, we know where to send them in Bangladesh or near environment. If they call us from Central Africa, John Cohen is part of our panel here today. He comes from South Africa. We'll know where to send them in Africa to get their treatment. It will identify the spectrum of disease around the world as one kind of tumor, either benign or malignant, because this is for benign and malignant disease, more common in one part of the world versus the other. And it will identify opportunities for collaboration, not just collaboration with respect to cardiac sarcoma, but collaboration with respect to cancer care around the world and collaboration with cardiac care around the world. So it's going to have a few knockoffs, a few spin-offs, which I think will be beneficial for individuals around the world. Right now, we have a planning committee, and you can see who they are and where they are around the world. We don't have anybody from Russia. Now that Trump is in, maybe he'll settle things down with Russia and we'll get somebody from there, who knows. But we have representation from all parts of the world, and that's what I wanted to do, is get the whole world involved. So the progress, we had 2 years of meeting with the global leads I showed on that previous slide, and the protocol and the bylaws and the database are all done. We're waiting IRB approval in my hospital, and we'll see how that works and what kind of challenges we have with our IRB committee, and we'll be able to pass that on to the other members. We're waiting tenders for the global vendor and expect it to be up and running in 2025. I really wanted it up and running in 2023, but COVID got in our way. And hopefully we'll add more centers starting 2026. So we'll start with the nuclear group in 2025, and we'll add more centers in 2026. So that's what I have to update you about the INTERACT project. That's what the thinking behind the INTERACT project is, and what the progress has been. It's been slower than I wanted, but it is a snail's pace, but still a forward pace. So let's get back to the meeting. We're going to talk about tumors, and we're going to have as an introductory session Johannes Cohen. Johannes Cohen is a cardiac surgeon in South Africa, born and raised in South Africa. His father's a cardiac surgeon, so he's had a long experience with dealing with these sorts of things as a non-medical person, but also as a medical person. He's devoted his life to this as well. He's with us right now in Toronto. Although he's in South Africa with his new family. He has a little baby girl, is less than 4 months of age. And he is with us at Toronto General Hospital. He's been working with us here, both clinically in transplantation, as well as an interest in cardiac tumors. So I asked him to join us. John.
Thank you for the lovely introduction, Dr. Cusimano, and welcome everyone to the presentation. So the case is here just to basically highlight and to provide an introduction to the agenda itself and to the honorable speakers we have that will be following. So the first case is a 32-year-old male that presented to us with a brief history of a suspected upper respiratory tract infection. He had a low-grade fever at presentation of 37.5 degrees Celsius and a resting tachycardia of 100 to 110 beats per minute. His chest X-ray in the emergency department demonstrated an enlarged cardiac shadow. Can we see the next slide, please? This is a picture of his X-rays. One can appreciate very large cardiac shadow. Next slide, please. This is the CT scan that was done in the emergency department. and one can appreciate there's a very large right-sided tumor, basically encasing the entire right atrium, parts of the superior vena cava, inferior vena cava, and the interatrial septum, including the tricuspid valve. Next slide, please. A percutaneous biopsy was performed, which demonstrated an angiosarcoma on histopathology and cytology. Next slide. So the patient underwent discussion at a tumor board meeting. The feeling at the time was that he should have neoadjuvant chemotherapy. So he completed 6 cycles of doxorubicin and ifosfamide and had a very good local cardiac response. However, he had multiple liver mets, and on that basis, he was declined for surgery because of his distant metastases. And ultimately, he was referred for definitive radiotherapy. Next slide. After his initial radiotherapy, he actually had a very good initial response. He had 66G over 33 sessions, however, did develop a temporary drop in his left ventricular ejection fraction. This was associated with a chemotherapy. The EF went down to 25%, and he actually had a dilated cardiomyopathy as well. He did develop, however, local cardiac recurrence 6 months after completion of the radiotherapy. And gemcitabine and docetaxel was basically given with stability of cardiac recurrence and the liver lesions on further follow-up. So presenting this case, it's a bit unusual. Patient that was declined of surgery because of liver mets, but are there other options for treatment? And we hope that we can get a consensus from the panel and discuss, future options, current options, and things that we may be able to research further in the future. Thank you.
Thanks very much, John. So you can see there are, for people who deal with this sort of thing, it's a pretty common presentation of an angiosarcoma involving the right side. And we have gone the transfemoral venous route to get a transvenous biopsy, and sometimes we don't get that. So big tumors, we go directly to transcutaneous or percutaneous biopsy. A couple of years ago, we had a presentation about this. So if you want to learn about it, go back a couple of presentations ago and look at that. We've had really, really good response with respect to diagnosis with that, much better than the transvenous site. So that's patient underscores the kind of patients that we all deal with cardiac sarcomas, recurrence either local or distant, and how to deal with those. And he's getting the second-line chemotherapy, and that's what we're wanting to talk about today. Does immunotherapy play a role in these types of individuals? So now let's get back to the agenda. In the morning, we're going to speak, Dr. Suzanne George is going to give us an introduction to immune therapy, because I'm not an expert in it, and she is, as is everybody else. We're going to have Dr. Michael Wagner talk to us about checkpoint inhibitors. He gave a fantastic talk last year, and I look forward to his talk again this year. We'll have a bit of a break. Oh, Dr. Wilkie will speak to us about immunotherapy as well, as will Dr. Seth Pollock. And then we're going to have another case presentation. It's a case that I think might be, I don't know what the cases are. So these are going to be cases that are going to be brought forward, and we're going to discuss as a panel as we would for a regular tumor board to help with these cases, these individuals. I don't know if they've had responses, or rather whether they're cases that are ongoing or whatever they are, but we'll act as a tumor board and give advice as we would normally. So it's a way for the audience to see how we deal with these cases in a real-time fashion. We'll have a bit of a lunch break to get people to answer their pages and stuff like that. And then we'll have the afternoon session. And Cassian Lee is going to talk to us about T-cell therapy. Dr. Decker is going to talk to us about vaccine therapy, and Dr. Conley about intramorality therapies, in other words, viruses and intertumoral therapies. We'll have a bit of a break, and then we'll have another panel discussion. This time, Dr. Reardon will join us with another case. We can all be happy to join in for our comments as with any tumor board. But there's going to be a second case, and then I'll do a quick closing remarks about what we've learned for today. So with that, let's learn. Stop sharing. Anybody have any comments about that?
Thanks, RJ, for a great introduction. Looks like we have a really all aspects of immuno-oncology to kind of touch on this area. Just want to, on behalf of the program committee, welcome everyone to the conference. We've several registrants and almost full house today. Um, I'm hoping to have a vibrant discussion on the application of immuno-oncology agents. And not specifically just, we've usually covered this topic in an hour session and wanted to kind of dive a little bit deeper this year. So RJ and I were fortunate to have the assistance of all of the key thought leaders in emerging immuno-oncology field. Today, as you can see from the program, each speaker is addressing a specific aspect of application of these immuno-oncology assets, how to combine them with other systemic therapies and novel approaches like intratumoral administration of viral assets in controlling these tumors. We have some interesting cases to discuss today as well. So I'm hoping this will be an exciting day ahead of us. We're running a little bit ahead of schedule. I'm pretty sure we'll eat up this time in questions. So I will, if it's RJ, if it's okay with you, we can keep moving.
Yes.
It's my pleasure to serve on this program committee and also a distinct honor to introduce our chair, Dr. Suzanne George, for introducing the theme of this year's Toronto Tumor Conference, Immuno-Oncology Applications in Cardiac Sarcomas. Dr. George requires really no introduction among sarcoma doctors or patients with this disease. She's been a thought leader in rare cancers. She serves as a chief of the division of sarcoma at Dana-Farber, and has been an author of numerous publications over the past couple of decades that has really changed the course of the management of this rare tumor type. Her work in GIST and all soft tissue sarcomas. One visit to PubMed and it'll be pretty clear the footprint. We're really thankful to have her time, her wisdom, and guidance in setting up the program and really precipitating such a wonderful group of speakers for us today. And I'm hoping we'll really have a vibrant discussion as the day progresses. I'll hand off to Suzanne. Thank you so much.
But no, thank you so much for such a kind introduction. And to RJ for really spearheading this together. This, as you all said, I mean, this is such a rare, it's sort of an ultra rare condition, but any of us that take care of patients with cardiac sarcomas feel the impact from the moment that we are involved in these cases. These are often young people and people that are presenting after some period of time of symptoms that no one would have expected this type of such a rare disease. So it's really wonderful to see this global community coming together to really learn together how to help improve outcomes for what's really a challenging disease. I just have one slide actually, and it's a bit of a reconfiguration of the agenda. And it really, as has been highlighted, we have a wonderful group of speakers that I look forward to learning from. Immunology, sort of immune-based therapy in oncology has been evolving over the last, well, for many decades, but really ramped up over the last 10 to 15 years. And we're seeing very large impacts in certain tumor types across all of oncology. So, obviously with the original early stage improvements in melanoma, in lung cancer, bladder cancer, Hodgkin's disease, um, and more. We do have in the field of sarcoma, and this will likely come up through subsequent talks, so I don't want to take away people's thunder, but in the field of sarcoma, we do have two approvals in the immune-based environment. So one is atezolizumab in a rare subtype of sarcoma called alveolar soft part sarcoma, and then recently a cell-based therapy which was approved in the first sort of solid tumor cell-based therapy in synovial sarcoma. And I think what we learn and what we'll hear throughout the day is that immuno-oncology strategies, although they're considered kind of on one roof and have many overlapping components, are also very distinct in their mechanisms of action, in terms of how immune checkpoint inhibitors may work in the immune environment versus how vaccines may work versus how T-cell therapies may work. And these different mechanisms of action likely have different applications in different tumor contexts, whether it's, as I said, what we've seen in more the carcinoma or melanoma-based environment, and even within sarcomas, because we have such a diversity of different disease types. So what I sort of was, I was thinking about today, I was thinking about how as we're going to go through checkpoint inhibitor data, checkpoint inhibitors in combination with targeted therapies, in combination with chemotherapy, we're going to start to learn how are we able to apply this in the cardiac tumor space, in sarcomas in general? What more do we have to do to try to understand why these strategies are working, why they may not be working, what do we need to do better? I think learning more about CAR Ts is super interesting as we continue to expand that in the solid tumor realm. And then, as has been discussed earlier, thinking about vaccines. I mean, how for many of us that have been doing this for decades, as Vinod said, I moved from many years to many decades at this point. But for how long have patients been coming into the exam room to say, isn't there a vaccine that you can give me? And now are we at the place where maybe we can start to say, we're learning more. And yes, maybe there may be now and or in the future, particularly as we think about TLRs as adjuvants in the vaccine space. So I think that we have an exciting agenda ahead. I think we're going to learn a lot about immuno-oncology in sarcomas in general, areas of unique opportunity, areas of overlap, and areas of potential future direction. So with that, I will turn it over to back to Vinod or whoever will be introducing our next speaker.
Thanks, Suzanne. Looking forward to a really interesting session. Mike Wagner, it's a pleasure to introduce Mike. I've worked with Mike for so many years. Mike trained in Boston, which is where he currently has gone back to Boston, his home. His training was here at MD Anderson Cancer Center for his medical oncology fellowship. Probably one of the most intelligent, gifted doctors I've ever had the pleasure of working with, and has really taken on vascular tumors, and hope to learn a lot from Mike. He serves as the clinical director of research at Dana-Farber for the sarcoma initiatives that are running here. Mike, even as a fellow, was probably the only trainee I've had who has pushed me to move faster. Usually it's the other way around, and I'm always thrilled to have people like Dr. Wagner really lead the field forwards. His publication and the use of a combination checkpoint inhibitors is it's a key milestone work in this particular area, especially for vascular tumors. We have so little data in it's specific to vascular tumors and in cardiac tumors. Mike's one of the few people who have actually taken this particular topic under scrutiny and really moved the field forwards, providing vascular sarcoma specific data. So looking, this is, I think, the second or third year in a row that Mike is talking about this. Every year, I'm always thrilled when he says yes. So looking forward to learning more. Over to you, Mike.
All right, thank you, Vinod, and Suzanne, so my former and current bosses, if you will. But also thank you just for the opportunity to speak again. So one thing I'll comment, so I was asked to talk about checkpoint inhibitors in rapidly growing sarcomas, but I changed that because I don't use checkpoint inhibitors in rapidly growing sarcomas. I generally use chemotherapy. And at least for this talk, it's almost more historical at this point because the field is evolving so rapidly. But I think it will provide some of the uh, sort of base of what all the subsequent speakers are going to talk about, which is kind of the more hot, exciting combinations and other ways to harness the immune system to fight against cancers and, of course, sarcomas. This is, some of them are quite old, but these are my disclosures. So I'll first give a very brief background on cardiac sarcomas. Of course, most, if not everyone here, is already familiar with cardiac sarcomas, and Dr. Cusimano gave some background already. And then I'll talk a bit about some of the earlier studies, still within the past 10 years, but some of the early studies of checkpoint inhibitors just in sarcoma in general, so across many subtypes, and almost or none or very few cardiac sarcomas. And then there is now some data, mostly retrospective, of patients who have been treated with checkpoint inhibitors who have cardiac sarcomas. And then finally, I'll briefly talk about a couple of trials that are trying to move immune checkpoint inhibitors up in the line of therapy. And that's all also emerging data and still actively being discussed how it should be implemented. So first, a little bit on primary cardiac sarcomas. So this was actually one of the last slides from my talk last year, where I was really focusing on angiosarcoma. But I wanted to highlight that primary cardiac sarcomas are not just angiosarcoma. Angiosarcomas are probably or are the most common ones. But there's also intimal sarcomas, especially of the pulmonary artery, which are characterized by CDK4, MDM2 amplifications, undifferentiated pleomorphic sarcomas. There are even some patients who can have a primary liposarcoma of the heart or synovial sarcoma. So there are lots of different subtypes that are all driven by very different molecular drivers, which then raises the question of, well, should we lump them all together and just treat all cardiac sarcomas the same, or as much as we can try and get more and more subtype specific? And this is a debate that's been ongoing and a sort of super subspecialization that's been happening in sarcoma in general. And even though cardiac sarcomas are ultra rare, perhaps we should be doing the same thing for the rare cases that do come up. So like I said, angiosarcoma is the most common subtype. And one thing that I think is important to note is that for cardiac sarcomas, they're just much more likely to, even at presentation, present with metastatic disease. So over a third of patients with a cardiac sarcoma will have metastasis at diagnosis versus about 13% in other sarcomas or just sarcomas of other places, where that still leaves about a third, or depending on how you categorize it, over half of patients who have localized or local regional disease. And as Dr. Cusimano presented in his introduction, chemotherapy has been, and I would say still is, really the main way that we try and treat cardiac sarcomas with systemic therapy. This is from a paper that Dr. Cusimano actually already mentioned, but it's the experience of the Houston group, or at least the early experience of the Houston group, treating cardiac sarcomas as a whole. This was heavily skewed towards angiosarcoma, but their preference is to treat with neoadjuvant chemotherapy, specifically with doxorubicin and ifosfamide. And then if there's not a good response, then to switch to gemcitabine and docetaxel. So of course we can have a whole day talking about the different chemotherapies and what might be optimal. But I think the idea here is that most of us, or at least many of us, myself included, will preferentially try and treat with chemotherapy in the neoadjuvant setting as much as that's possible for cardiac angiosarcomas. And why is that? So even though it was a small group, there were 12 patients in this cohort who did not have chemotherapy. And comparing the patients who had chemotherapy versus those who didn't, it at least seemed like the patients who had chemotherapy lived longer, so even twice as long. That being said, there are many potential confounding factors, and as Dr. Cusimano just presented in the larger analysis or subsequent analysis after this study, there really wasn't a difference in the group that had chemotherapy versus those who did. And even in this paper, even though it was numerically almost double the survival length, statistically, there was no difference. But we still will generally treat with chemotherapy. But I think no matter how you interpret this data, one thing that's unquestionable is that there's ample room for improvement. So I mean, neither of these survival curves, with or without chemotherapy, are particularly exciting. And even for patients with localized cardiac angios or cardiac sarcomas as a whole, the outcomes are not good, and we need to improve upon that. So what are really the things that have revolutionized cancer care? And I think the various immunotherapies, even in the time since I was a fellow, so within the past 10 years, have completely revolutionized the care of many different cancers. And there have been some studies, at least in sarcomas, and we're still trying to learn what is the best way to use immunotherapies. So for this talk, I'm focusing just on immune checkpoint inhibitors, which as time goes on, there are more and more and more immune checkpoint inhibitors. So the first one that was developed, which isn't even on this slide, was a drug targeting CTLA-4. And that's ipilimumab. But then shortly after that, the PD-1 inhibitors came out. And that's what really, I would say, revolutionized cancer care over the past decade. And for anyone who's not an immunologist or a medical oncologist, this is just a very quick demonstration of what are these drugs. So of course, there's T cells in our immune system. They express a protein called PD-1, which is this orange thing here. And PD-L1, which is PD-1's binding partner, can be expressed on lots of different cells. So it can be expressed on the tumor cells, on dendritic cells, and others. And when PD-1 and PD-L1 meet up, that's essentially a signal to the T cell saying, don't attack and don't kill whatever that cell is that's expressing PD-L1. So a number of drugs have been developed that essentially disrupt that interaction. And then when that happens, the sort of don't kill me signal is eliminated, and then the T cell can kill, ideally, the cancer cell. So there have been a number of clinical trials looking at these types of drugs in sarcomas. I'm only highlighting a few of them. So one is a SARC study, SARC 28, which looked at pembrolizumab. Another alliance trial looked at nivolumab, so two PD-1 inhibitors, pembrolizumab and nivolumab. So nivolumab versus the combination of nivolumab and ipilimumab, so the PD-1 inhibitor and CTLA-4 inhibitor. There was another study that was a single institution study at MD Anderson looking at durvalumab and tremelimumab, also PD-1 and CTLA-4 inhibitors. And then just more recently, so at the last ASCO and now published, there's data suggesting, well, maybe we should be moving some of these therapies up in the sequencing of when we give them, and also even up in timing of when we give them with the initial therapy. So first, the SARC-28 study. This looked at pembrolizumab in a number of different sarcoma subtypes. There were two different cohorts, so soft tissue, at least in the initial study, soft tissue sarcomas and bone sarcomas. There were 42 patients in each of those cohorts. And in this study, we saw some early signals of activity. So overall, the response rate was 18% of the evaluable patients. 7 out of the 40 had responses. The patients who did respond seemed to have certain subtypes. So those red lines or purple are undifferentiated pleomorphic sarcomas, and we'll talk more about that subtype with several of these other studies. The blue line is actually a patient with synovial sarcoma who responded, and green were patients who didn't quite have as deep responses, but it did seem like there was activity in liposarcoma as well, dedifferentiated liposarcoma specifically. The progression-free survival on this study was, not terribly exciting, because for a lot of these patients, or a lot of patients in general who are treated with these immune therapies, if they don't respond, then they really just don't respond. So the median progression-free survival in the soft tissue sarcoma cohort was 18 weeks. The median overall survival was 49 weeks, so a little bit less than a year. It was a little bit worse, at least for PFS in the bone sarcoma group. But one thing that's been intriguing about immune therapies, and especially in some of the very early studies, even with ipilimumab in melanoma, is that there does seem to be a few select patients who have really good responses that are durable and long-lasting. And you can see on these spider plots that, especially in the soft tissue sarcoma group, there are a few patients who were on therapy with sustained responses for, this is more than a year and a half of follow-up, which is really impressive and quite dramatic, especially at a time when all that was available was chemotherapy. There were 2 expansion cohorts stemming out of this study because it seemed like there was more activity in UPS and liposarcoma. From these expansion cohorts, the response rate with liposarcoma was 10%. With UPS, it was 23%. The median PFS for both groups was actually quite low, again, because if these drugs don't work, then they really tend to not work. Some people can have more prolonged stable disease with checkpoint inhibitors, but I think of them as at least for at least for tumors that are a little bit more rapidly growing. If they're not going to respond, then that growth is really just going to continue, and that's why for patients who have rapidly growing tumors, my preference is generally chemotherapy. And then the median overall survival in both of these groups was about a year. The next study, so the Alliance study, which looked at nivolumab with or without ipilimumab, again for really just all-comer sarcomas, they had 2 different groups, so but a little bit different, where here the patients were treated either just with single agent nivolumab, so just the PD-1 inhibitor, or the combination of CTLA-4 and PD-1 inhibition. And it did look like there was some extra activity with the combination. So Focusing at least on the combination group, the responses were in a number of different subtypes. So both uterine and non-uterine leiomyosarcomas, at least one patient each responded. There were 3 patients with the UPS sort of like tumors where myxofibrosarcoma molecularly is almost the same as undifferentiated pleomorphic sarcoma. That was the same group where we saw activity in the SARC study as well, and one patient with angiosarcoma had a response. If you look at the PFS also, it seemed like there was benefit with the combination, both in progression-free and overall survival compared with nivolumab, even though these weren't quite direct comparisons, where with single-agent nivolumab, the median PFS across the whole group was just 1.7 months. With the combination, it was 4.1 months. And then similarly with overall survival, the median overall survival with nivolumab alone was 10.7 months, and with the combination, it was 14.3 months. So perhaps there's an added boost with the addition of the CTLA-4 inhibitor. I don't have this on a slide, but with that added boost also comes extra toxicity, which has to be taken into account. And will factor into the discussion, especially of the sequencing of these drugs. And, is that toxicity worth the unknown real benefit if we were going to treat with something like combination or even single agent checkpoint inhibition earlier on in the course of the treatment? Just like with the other study, there were some patients, more so in the combination group, who had really durable, long-lasting responses. So on the right, you can see the swimmer plot of patients treated with nivolumab and ipilimumab, and at least at the time of this analysis, which was I think also about a year and a half on treatment, 3 patients were continuing on therapy. There were 3 expansion cohorts stemming off of the Alliance trial. One of them was GIST, and those patients just don't really respond. There's a few reports of patients with GIST responding to checkpoint inhibitors, but generally they just don't work. But again, UPS and liposarcoma were also expansion cohorts, and the result seen here was similar to what was seen in SARC, where there was more activity in the undifferentiated pleomorphic sarcoma group. With the combination, the response rate was a little over 28%, so 4 out of 14 patients with available disease. And in the liposarcoma group, the response rate was 14%. A little bit higher than what was seen in SARC, but it was a fairly small group, so just 2 patients who responded out of 14. And then the last checkpoint inhibitor study that I want to highlight is with durvalumab and tremelimumab. So this was a single center study done at MD Anderson, and it had many different cohorts. And one of the main reasons that I really wanted to highlight this one is because there was specifically a vascular tumor cohort. On that cohort, there were 10 patients, 5 of whom had angiosarcoma and 5 had leiomyosarcoma. So that sort of gets to the question of, well, how do we even define a vascular tumor? Because technically a leiomyosarcoma of the IVC is a vascular tumor. Should we be lumping those together? Maybe, maybe not. But that's what was done here. And again, with this combination, there was activity in a number of different subtypes. A few different, though, from what we had seen in some of the earlier studies. And specifically, one subtype that seemed to have a lot of activity was one that Dr. George mentioned when she was talking, where there's actually an approval for a checkpoint inhibitor with, at least now there is, with for treatment of alveolar soft part sarcoma, so ASPS, an ultra rare sarcoma subtype that happens to be more responsive to checkpoint inhibitors, and that was seen in this study. There was also a patient with chordoma who had a good response, and then just like on the SARC and Alliance trials, UPS also seemed to have more activity than some other subtypes. Um, so then that gets us to, well, what data do we actually have in patients with cardiac tumors? And the answer is very little. So Dr. Ravi mentioned this study of ipilimumab and nivolumab, the DART trial in angiosarcoma, or at least this cohort was for angiosarcoma. And I'm including this because, so of course, there was some activity in angiosarcoma, but there was one patient who had a cardiac tumor. This is patient 10 on this waterfall plot here. And that patient just did not respond. The tumor grew. We have a little bit of molecular information about what this one patient tumor looked like. The TMB was 3, so low. We don't know what the PDL1 status was. Interestingly, there was a BRAF mutation, not the sort of classical V600E, but there was an alteration there. And at least in this particular patient, the checkpoint inhibitors just didn't benefit them. Just last year, so this was published probably about a week before my talk last year, so I was able to sneak it in. But there was a retrospective study that was a multi-institutional collaboration, specifically looking at patients with primary cardiac tumors who were treated with various immunotherapies, or really just various checkpoint inhibitors. In this cohort, there were 8 patients with angiosarcoma, 8 with undifferentiated pleomorphic sarcoma or UPS, 4 that were just categorized as spindle cell sarcomas, 1 liposarcoma, interestingly, 1 chondroblastic osteosarcoma, and 2 intimal sarcomas. And they showed a few things. So one is that the patients with angiosarcoma did worse than the patients who did not have angiosarcoma. Where essentially all of the patients with angiosarcoma had progressed just by 5 months. And for both of the groups, the long-term survival remains fairly poor. Again, it's a bit better for patients with non-angiosarcoma subtypes, but still, by 3 years, all of those patients had passed away. There were a few hints of activity. They analyzed these patients, or at least grouped them as either non-angiosarcoma or angiosarcoma. So in the patients who had the other sarcoma subtypes, there was one patient who had radiographic response, and that was someone who was treated with a combination of an anti-CTLA-4 and PD-1 inhibitor. I'm not sure which one. And we don't know what subtype this was either. Just based on the prior data, I might guess that maybe this was a patient with UPS, but I'm not sure. So really just one patient had a RECIST response. A number of other ones had stable disease as best response, but none of those were durable. If you look at the patients with angiosarcoma, again, there was one patient in the cohort who responded. That patient also had paclitaxel. So I might actually argue that the response was probably from the paclitaxel. Of course, we can't say for sure, but paclitaxel and taxanes in general are really probably the most active drugs in angiosarcomas. If you look at all angiosarcomas collectively, so it's hard to attribute that response to the immune checkpoint inhibitor. But even then, the response did not last very long. So that patient was on therapy for less than a year. And then finally, so most, if not all of the data that I had just showed was really for patients who already had metastatic disease. So outcomes with immune checkpoint inhibitors and or chemotherapy for that matter alone for patients who have metastatic disease are just bad. So we need to do better. One way to potentially do that is to move immune checkpoint inhibitors up in the line of therapy. And when we're considering surgery or radiation or chemotherapy, well, maybe we should be thinking about adding an immune therapy at that time. And there's at least some data now to sort of help guide that thought process. So I'm going to talk about two studies. So one I think this was also a single center study at MD Anderson, looking at two different subtypes. So these are not cardiac tumors anymore, but sort of extrapolating from data from sarcomas of other anatomic locations. In this particular study, they looked at patients with dedifferentiated liposarcoma and patients with undifferentiated pleomorphic sarcoma. The treatment schema for each subtype was a little bit different. I think the key difference here was that the patients with UPS received radiation, whereas those with liposarcoma did not. And treated in the neoadjuvant setting, these patients had localized disease, so they went for surgery, which of course gives the benefit of actually having the tissue, so you can see, in addition to what happened or didn't happen radiographically, what did the sarcoma actually look like under the microscope. And it was pretty interesting, I think. So looking at pathologic response, and so that's actually those pie charts on the bottom. There seemed to be really significant pathologic response actually in the UPS group, with pathologic response defined as greater than or equal to 30% hyalinization seen in that surgical resection specimen. Radiographically, which are panels A and B, there was some reduction, especially more so in the UPS group. One patient at least had a formal response in the liposarcoma group. But do those two correlate? It's a little bit less clear. And then also just on the time frame of this, we don't know what would have happened if those patients, radiographically at least, if those patients didn't have surgery and we had just followed along. But I think the combination of a checkpoint inhibitor with radiation, at least from this study, seems very intriguing. We don't know, what would these tumors have looked like if the UPS tumors, if they just had radiation. So they're somewhat more radiosensitive tumors, which is why radiation was included in the first place. But I think the very high frequency of a pathologic response here is probably more than what I would have expected to see without a checkpoint inhibitor. And then the next study, and the last study really that I'm going to highlight, is the Stand Up to Cancer SARC-32 study. So this was just presented at ASCO and published shortly thereafter, looking at patients with extremity sarcomas, also undifferentiated pleomorphic sarcoma and liposarcoma, higher grade, so at least intermediate grade, tumors who were randomized to either receive neoadjuvant pembrolizumab with adjuvant pembrolizumab in the experimental arm versus standard of care, and those patients received just the usual radiation and then surgery and follow-up. From the results of this study, it looked like there was a disease-free survival benefit in the experimental group. So with the addition of both neoadjuvant and adjuvant pembrolizumab, there was at least a statistically significant improvement in disease-free survival. It's not clear what was the contribution of the neoadjuvant component versus the adjuvant pembrolizumab. I don't think I included it here, but there's some data from other cancer types, especially melanoma, I think was probably really the first one that was very well defined, that showed that probably the neoadjuvant component, at least in that in melanoma is more important, so that there's some tumor antigen there for the immune system to recognize. So, would this result have been the same if it were only neoadjuvant pembrolizumab and radiation and then surgery without that year of adjuvant pembrolizumab? We don't know. That study, wasn't done. But that's something to think about. But I think one thing that we can see from these data is, well, perhaps there's some benefit to moving immune checkpoint inhibitors up, and especially in a cancer like cardiac sarcomas, just in general, where the outcomes are just so poor, even with aggressive treatment of localized disease, this might be something that we can adopt. But there are so many open questions right now. So one is, well, should we wait for metastatic disease to develop? I think from the bits of data that already exist, we know that if we did that, if we waited for metastatic disease to develop, even though there will be patients maybe who benefit, the outcomes are generally poor. So I don't think just waiting for metastatic disease and treating with checkpoint inhibitors is the answer. Should we sort of replicate the SARC study of the neoadjuvant and adjuvant pembrolizumab for cardiac sarcomas? And I think maybe that's a good idea, maybe not. There just aren't enough patients to do a real study specifically in cardiac sarcomas. But that's one approach that I think people can talk about and collectively decide, or maybe disagree, and not collectively decide what might be best. Should we give adjuvant only? So the SWOG 1801 study is the one that I mentioned a slide or two ago that showed that there was an EFS benefit by including the neoadjuvant checkpoint inhibitors over just adjuvant alone. So I would probably not, at least based on the limited data available, I would probably not advocate for just giving adjuvant checkpoint inhibitors. But that's an approach that's been looked at in many different cancer types. And then the sort of more exciting and sort of hot talks that other people are going to give is, well, can we use the science and everything that we've learned from the studies that I just presented and come up with smartly designed combinations, or even try other ways to harness the immune system? So I didn't expand on any of this because there are whole talks on each of these topics. I actually just went through the agenda and put the titles here. But can we combine checkpoint inhibitors with targeted therapies? So Dr. Wilkie is going to talk about that, and she really pioneered a lot of those trials, especially with axitinib and pembrolizumab. There are studies ongoing looking at combining checkpoint inhibitors with chemotherapy. So Dr. Pollock's going to talk about that. Cell therapies, as Dr. mentioned, or Dr. George mentioned, there's now a cell therapy approved for synovial sarcoma. There are many challenges with that. And then that particular therapy is HLA restricted. So there are CAR T cells that are not HLA restricted in use for many heme malignancies. They haven't been quite as successful for solid tumors. But why? And are there things that we can do to those T cells to make them more effective for solid tumors? Vaccines have been studied for a very long time, have not been terribly successful, but now we have newer ways to give vaccines, and there's decades and decades of science and learning, and we can build on that to potentially become smarter. And then also newer things like intratumoral therapies, where anything that can be put into a needle can be injected into a tumor. And some of those might actually be good ideas to do. So things like oncolytic viruses, for example, there's some exciting data for, and I think Dr. Conley is going to present on that. So we've learned a lot just in the past 10 or so years about checkpoint inhibitors and ways that we might be able to combine them with other types of therapy. And we'll hear about many of those today. So just to conclude, I don't want to minimize the importance of chemotherapy in cardiac sarcomas. Even though the responses are not durable, those are really the tried and true therapies, and I think are the most likely to actually lead to clinical responses, especially if someone has rapidly progressing disease, or if they're not a candidate for surgery and are hemodynamically unstable because of their tumor. If they're well enough to potentially tolerate a bit of chemotherapy, that would still be what I would prioritize as the first intervention. Um, uh, in general, immune checkpoint inhibitors have just not been effective for cardiac sarcomas. There are sort of hints of responses here and there, but nothing that is conclusive. And I would say, if anything, they probably really just don't work as immune checkpoint inhibitors alone. But we have a lot of data now and a lot of knowledge about how we might be able to combine different modalities or different types even of systemic therapies to improve upon the activity of checkpoint inhibitors alone. And other ways to harness the immune system. So things we'll hear about like T-cell therapies and vaccines and intratumoral injections. So happy to take any questions if we have time.
Like we do have time. I just wanted to remind participants to please use the chat functionality for any questions you want to start off with. I'll get one of my burning questions out there. So when we originally put on the topic, as Mike pointed out, we wanted to try to talk about how do we use these checkpoint inhibitors, which usually take a while for a response to kind of evolve in rapidly growing tumors. And as Mike rightly pointed out, we don't use them in fast growing tumors because it just, even before the therapy can take off, the runway kind of runs short. Mike, do you in what phase of a particular cardiac tumor would you be considering the use of checkpoint inhibitors? Would it be in progressive disease or in stabilization as a bridging strategy after you've completed X number of cycles of chemo? How would you envision this moving forwards for rapidly growing tumors?
Yeah, so I wish there were just more patients so we could do some sort of study. But there aren't. So, the real answer is I don't know. I think, at least in other cancers, it's hard to say that there's enough evidence to support giving checkpoint inhibitors after, say, chemotherapy if there's stabilization of disease. I think it would be a rational thing to do as long as there's a good conversation about the potential for toxicity and really the unknown benefit. I think for cardiac tumors, specifically of any subtype, really, checkpoint inhibitors just don't seem to work. If they did, I'd be more inclined to adopt a strategy like that. But if you look at that last or not the last one, but the retrospective data of checkpoint inhibitors in just primary cardiac sarcomas, only 2 of those patients responded. And one of them, so the one with angiosarcoma, also received Taxol. So it's even hard to argue that the checkpoint inhibitor did anything. Anecdotally, I feel like I've seen patients. I saw one patient who was treated at another site, who then moved to Seattle when I was there, who had metastatic, I think it was a UPS, although I honestly don't remember, or it could have been angiosarcoma. Either way, had a primary cardiac tumor with just diffuse lung metastases, actually had radiation to the primary cardiac tumor, and the lung metastases all responded. It wasn't terribly durable, but it was dramatic. So there was some immune activity going on with that. So I think probably the approach that I might try is, especially for a tumor that's rapidly growing, really just prioritize chemotherapy. But then if there's growth again, try one of these other combinations that we're going to hear about, because I think that has more promise in actually getting activity out of the checkpoint inhibitor. What's the right combination? Well, we'll hear the other talks and then debate that. But I think there's just so little activity with checkpoint inhibitors alone that um, I'm just not so inclined to try those if there are other options or other combinations that we can try.
No, that's really insightful, Michael. It looks like using it solo in any particular phase of the disease is fraught with lack of data, and also in the limited use that we've had, a lot of inactivity. So the point is really well taken. Dr. George has a question there. So then, do you want to talk about it, or would
Yeah,
you like?
sure. So Michael, great talk. It's always really nice just to get the background and the foundation for sort of how this all started and these drugs are being used. One question that I had is because of the diversity of different histologies in sarcomas that can involve the heart, whether you thought there was a particular subset or particular type of sarcoma that may be more primed for studying in the immuno-oncology space.
So at least for cardiac sarcomas, I guess the one that I would put at the top of the list would be UPS, a UPS of the heart. If we were to think that UPSs of the heart are similar to UPSs of other sites, which I think is a big if because we don't know. And I think the only reason I feel like I'm confident saying that is because if you look at angiosarcomas, an angiosarcoma of the heart is just not the same as an angiosarcoma of the breast or of the scalp. Um, maybe UPS isn't quite that dramatically different, but we don't know, or at least I don't know if anyone's actually looked at that.
That's a good point. I mean, it's actually maybe a good thing to look at if there were ever enough cases to be gathered, or even a small number. Sometimes you can learn a lot from not too many. But it's a really good point about how even the diagnoses don't always tell you what's happening in the tumor. Thank you.
Yes, Suzanne, that's a really good observation. I think perhaps for Interact, RJ, one of the first projects to kind of kick off would be a multi-institutional look into this particular aspect of the UPS, or the primary pulmonary artery sarcoma group. The activity, at least anecdotally, the ones where we have used it, the responses has been really good. But again, nothing like formal data analysis to dispel our positive bias of remembering the things that we like to remember and forget the things that we don't want to remember.
One thing I'll say, you have to publish things like that, because if it's not in the literature, it didn't happen.
Yeah, exactly. Exactly. So maybe Interact's one of the first projects should be this particular one, so that we can get that literature out there for patients and for the clinicians out there. I think I see Dr. Wilkie is on. She has a pretty busy schedule today, so I want to be respectful of her time and make sure we move to getting her talk started. If you have additional questions on Dr. Wagner's talk, please email it to either myself or Dr. Wagner directly. Hoping to address that, and hopefully in the discussions that come up later today. It's a real pleasure to invite Dr. Wilkie, and I would like to really thank her for providing time to discuss this specific area of how do we really intelligently combine checkpoint inhibitors with targeted therapy options, an area that is showing a lot of promise. And Dr. Wilkie has done pioneering work in this particular area. Dr. Wilkie has been, very generous with her time, and I really want to be respectful of her time and get her talk going. So we use most of it for the talk and the questions that follow. Thank you so much.
Thanks, Vinod. Sorry, I just have clinic today. It's really nothing that exciting, I promise. All right, let's see if I can share this effectively. All right, can everyone see my screen, I hope? Great, wonderful. Well, again, I just want to thank the organizers of this event for the invitation to talk with you all today. It's an incredible initiative to have an immunotherapy conference on any topic. I think cardiac sarcomas are certainly one of the challenges that we face in clinic. And as Dr. Wagner just really eloquently pointed out, we still have a lot of work to do to understand how we can integrate immunotherapy and how the immune system really affects these tumors. So I'll spend my time today talking to you about targeted therapies in an effort to repolarize the tumor immune microenvironment. And of course, I forgot to put my disclosure slides in, but I'll just briefly mention I have research funding from Exelixis, Agenus, and then Merck and Pfizer funded the original Axi-Pembro trial. So shouldn't really affect what I'm talking with all of you about today. So I figured I would start with a slide that many of you have seen. But really, when we start to think about immunotherapy and what we need for an anti-tumor immune response, and when we think about immunotherapies, there's actually quite a lot that has to happen. And I think what we've learned from many of the studies of checkpoint inhibitor monotherapy, primarily a PD-1 and PD-L1 blockade, is that if you integrate this therapy that really happens at the very end of this whole cycle, where you're activating tumor-specific T cells at the tumor T cell interface, if you haven't established those T cells through a good immune response, really you're sort of beating your head against a wall because there's nothing to really activate. So you have to have initially good neoantigens, something foreign about the tumor that can be recognized by the immune system. This is typically antigen-presenting cells or cytotoxic T cells that then go on to further expand, activate, and generate this population. And then they actually have to be able to get into the tumor and not be shut down by the tumor microenvironment, which is what I'm going to focus a lot on today. And so again, kind of putting everything into perspective, many of our approaches to improve outcomes with checkpoint inhibitors have looked at targeting all of these different steps in the process. So chemotherapy and radiation are hoped to help boost that initial tumor immunogenicity, creating new neoantigens and liberating early innate pathways that help the antigen presentation and T cell priming process work better. CTLA-4 blockade also helps to improve T cell priming, and there's some really exciting data coming from novel CTLA-4 inhibitors such as botensilimab that I think are going to further cement the importance of this step in the process. But again, we heard a little bit about that. Cellular therapies, again, trying to bypass these early steps, which we'll hear more about today. But really, the tumor microenvironment is what a lot of us have thought has been a major issue. And this is a very complex concept, which I'll show you here in the next slides. But really, the idea here is targeting the microenvironment or trying to repolarize things with targeted therapies, including tyrosine kinase inhibitors. So this is just a recent review that I pulled that tries to summarize immune resistance in the tumor microenvironment. And as you can see, this is incredibly complex. But honestly, angiogenesis, which is essentially the formation of tumor-specific blood vessels or deranged vasculature, essentially, is about a third of the microenvironment. And so it's not surprising that many of our efforts have really focused on trying to target angiogenesis. In large part because if you can't get tumor or T cells into the tumor because the vasculature is not well established, or if you get T cells in and immediately they're shut down or put into exhausted states because of relative hypoxia or other metabolic conditions that result from poor perfusion, this is thought to be a major driver of why the microenvironment is so hostile. This also leads to skewing of this balance between pro-inflammatory and suppressive immune phenotypes. So there are many cells such as macrophages, T cells versus T regulatory cells, dendritic cells. Essentially, every immune cell that can live within a tumor has suppressive or activated forms, and relative hypoxia tends to skew that more towards a suppressive state. And then the idea also that you can reprogram T cells or immune cells by epigenetic changes is something that I think is really underexplored in sarcomas, but is coming as sort of the next wave. It's easier said than done, simply because we've had issues with epigenetic agents actually making that impact. But again, in theory, in the heme literature, you can reprogram cells towards a more stimulatory state, and something that needs to be thought about. And then finally, anything that targets the cytokine milieu can also change the indwelling balance between those factors. So specific targets that we go after for angiogenesis, VEGF and the downstream mediators are really the key pathway that we drive towards. And this includes a lot of different things that I'll talk about today. TGF beta is another one that, again, has begun to be explored in sarcomas, but probably still needs more work. And then a host of other pathways that are hit by tyrosine kinase inhibitors. And the fact of the matter is we actually don't know exactly what the targets are of many of our TKIs and which are the most important in sarcomas. But in general, that's basically the two flavors. Go broad or go directly towards the source of VEGF is what I'll focus on today. So this is just a summary slide of checkpoint inhibitor tyrosine kinase inhibitor combinations that have been performed in sarcomas. So I'll just highlight a couple of these. Most of these are all single arms. I'm going to show you some data from our one randomized study, but these are single arm phase 2 studies, fairly large in some cases. And what you can see here is that when you look at the response rate, there's some signals of promise. So Axi-Pembro was great for ASPS, alveolar soft part sarcoma, but really not so hot for other tumor types. Again, raising this question of whether we were being too narrow with axitinib, which is very much a VEGF-focused drug. So if you go broader and you look at sunitinib, pazopanib, apatinib, regorafenib, and you start to see some signals here in a variety of tumor types. So I do think there's something to be said here, and I'll show you data specifically for angiosarcomas, really focusing on cabozantinib as one of our leading drug candidates if we're really trying to hit a broad variety of targets to repolarize this microenvironment. So this is the randomized study that I'll just talk about briefly. So this is Brian Van Tyne's study. We were fortunate to be able to participate here in Colorado along with Penn and Stanford. So this was a randomized phase 2 study of cabozantinib plus ipi-nivo versus cabozantinib alone. And this was for metastatic soft tissue sarcoma subtypes. And you can see the eligibility here, 105 patients, a 1-to-2 randomization to either cabo alone with the option for crossover at the time of progressive disease, which essentially just meant adding in the immunotherapy, or starting with the combination up front, so cabo, ipi, and nivo all together. And the data that I'll show you here was actually pretty promising. The triplet combination had a disease control rate of 80% with 5 partial responses and 2 complete responses, compared to 42% for cabozantinib alone, with a couple of PRs, but overall mostly just stable disease if we got anything. And this was significantly different. And what was really intriguing is that patients who progressed on cabozantinib alone could still go on to actually respond when you added the immunotherapy in. And so this is one of the themes I think that's going to go across all of our combination talks today, is there's still a lot we don't know about sequencing. Is it really better to do everything all at once at the same time? Should we be priming with immunotherapy followed by targeted therapies or chemotherapy, or vice versa? So just another example of that quandary that we're all facing. But when you put it all together, again, 11% response rate. Responses were observed in angiosarcoma and myxofibrosarcomas, as well as leiomyosarcoma, epithelioid, and then myxofibrosarcomas, not surprisingly. And I don't, unfortunately, know if these were cardiac tumors. I'm anxious to see this final publication so we get a little bit more data out of this. But in the cabo-only arm, the only patients who did respond were leiomyosarcomas. And that included, even in the crossover arm, we were able to get another couple of responses in leiomyosarcomas. So something to be said for this idea of synergy potentially here. The progression-free survival, again, similarly better, 5.4 months versus 3.8 months, give or take, with the triplet arm compared to cabo only. And then what's really interesting in overall survival, again, improved with the triplet, but even the crossover patients, which are shown on the top here in green, actually did remarkably well. So this question of whether the sequential method may make more sense down the road. The other study that I'll briefly mention, again, cabozantinib plus nivolumab for patients with angiosarcomas that had previously received taxanes. This was Dr. Gurley Olson's study that was presented at ASCO last year. The Alliance trial design took recurrent and unresectable angiosarcomas and then basically looked at whether they were taxane naive, at which they were randomized 1-to-1 to get paclitaxel or paclitaxel plus nivolumab. And then they were allowed to cross over, or if they were pre-treated with taxane coming into the study, they got nivolumab and cabozantinib, and then this was a single arm phase 2 design here, so about 23 patients. So this data is really impressive. I think if you think about paclitaxel refractory patients, these guys are ripping, typically speaking, with angiosarcomas, a lot of rapid progression. So they were actually able to see a response rate of 59% with an overall clinical benefit rate of 16 out of 22 patients, which is pretty impressive. And then we had 2 complete responses reported at the time. You can see that many of these responses were also durable. PFS was 9.6 months, again, better than what we've seen in other single arm studies. But what's interesting then, if you look at the chemo arm, which I'm stealing Seth's thunder a little bit, I know he's coming up next. I'll just point out again that a lot of this comes down to the underlying microenvironment. So basically, when you looked at chemotherapy versus chemoimmunotherapy together, there was no difference until you sorted out what I would argue are likely to be the immune hot tumors. These are scalp and face tumors that often have a UV signature. And again, unfortunately, I don't have any cardiac information here, but typically visceral angiosarcomas are thought to be less immune responsive, which may explain why you're still not seeing a difference with paclitaxel until you start looking at that. So you could interpret this as potentially in the setting of paclitaxel refractory state, the cabo is enough to sort of drum up some sort of immune responses, or at least get some additional benefit in combination with immunotherapy at that point. So that's all fine and dandy. The question is any of this actually happening? Like, is there any data that we are repolarizing the microenvironment with cabo or any of these TKIs? And I'll say that our lab is in the process of working on correlative samples from the cabo versus cabo-ipi-nivo study. So stay tuned for that. But our group has actually delved into the correlative samples from my axitinib pembrolizumab study in quite a bit of detail, and we found some interesting findings that I presented at CTOS. So I'll just walk you through this. So again, axitinib is a very focused VEGF 1, 2, and 3 receptor inhibitor. So this is a very narrow TKI. And we've conducted this study, again, putting all of our eggs into the angiogenesis basket and saying that, that VEGF was really the target to go after. And so this was a phase 2 single-arm study that included 12 patients with alveolar soft part sarcoma, which is a disease that is known to respond or be very dependent on angiogenic factors, and then about 21 patients with other subtypes. And the take-home message was pretty clear here. Our responders were primarily ASPS. We had 2 non-ASPS responders, but really the biology drove the responses here. I mean, we were able to see quite an impressive progression-free survival, and patients did very well, again, with the immunotherapy on board. So obviously now, this is an older study, so we've seen that immunotherapy in general can work very, very well for ASPS. So we really don't have that randomized trial yet to sort of prove that the combination is more valuable than, again, the sequential approach. So it's to be determined, and I don't know that ASPS will ever get to the point where we have enough patients to do a cabo versus cabo plus immunotherapy or vice versa study. But hopefully through looking at these correlates, we can learn something. So what we did, we collected baseline and on-treatment tumor biopsies for all of these patients, as well as blood samples. And I'm summarizing a lot of data with this manuscript, hopefully going to get out in the next couple of months or so. But basically what we found is that responders, and I'll just caveat this by most of our responders were ASPS, but the idea was if we took this super responding tumor type, could we learn about what our goals are? Could we learn about what matters in the setting of a response with axitinib and pembro? And so what we found were several variables that we saw in responders, including higher PD-L1 expression. This is a radar plot kind of summarizing all this, but higher PD-L1 expression, you needed to have an underlying robust immune presentation system, so higher MHC1 expression, which is required for antigen presentation, as well as higher antigen presenting machinery scores. And what we saw with treatment is if you looked at the tumor infiltrating T cells, responders had this shift. They had higher influx with treatment of CD8 cytotoxic T cells relative to CD4 cells. And we saw an expansion of what's called a central memory population, which essentially are really powerhouses of T cells within the tumors. These central memories live the longest, they proliferate, they can expand the best. And there's some thought that they also can then turn into effectors if they're re-encountering antigen. And similarly, T-emeras hang out, and they are signs of old, very terminally differentiated cells that also can reactivate again upon encountering antigen. And what we saw was that we got big central memory expansion and then a loss of those T-emeras. And so arguing that the T cells were re-encountering antigens and beginning to actually respond again. The other piece that we saw that was interesting, it really hinges around Tregs. So recent data out of the French group has suggested that Tregs may be a potential resistance mechanism. You can take an immune hot tumor loaded with tertiary lymphoid structures, but if there's too many Tregs in that tumor, response to immunotherapy is blunted. And so we saw that our progressing patients had higher baseline circulating T regulatory cells, but we also saw a significant drop in CTLA-4 expression across multiple cell types in our responders. And it turns out that may actually be driven by Tregs, which are very high expressors of CTLA-4. So again, more evidence that we need to not abandon CTLA-4, even though there's toxicity and other things clinically that give us pause. And then the last piece that we found is that patients who progressed actually showed an increase in angiogenic cytokines. And so this is a lot of data summarized, but what we basically saw is that if patients progressed, they had this bump up in several key angiogenic cytokines, and this is sort of supporting that axitinib was actually doing something. And the main players here were beta FGF, VEGF-A, VEGF-C, the big ones that are not only associated with worse outcomes in sarcomas, but are hit by axitinib. And there were some other cytokines as well that, again, I'll get into at some point. The other piece, we looked here at genetic expression of nanostring signatures revolving around endothelial cells and hypoxia. And these are patients at baseline clustered here, with blue being high expression and yellow being low expression. And what we did was we selected genes that were available that were coming from that SIC-C cluster, if you're familiar with the Patty Price paper, which are thought to be more angiogenic signatures. And those are shown in this red cluster here, these top 5. And actually at baseline, these were higher in ASPS as well as most responders. And then if you look again at the patient level, we saw some changes here where most responders had a drop in these cytokines, but yet progressing patients could have upregulated cytokines. So it's sort of interesting to see these two things emerging. And so again, pointing towards some benefit of axitinib. And then if you look at just representatively macrophages, clusters of macrophage activity, again, in sarcomas versus low expression of macrophage activities, again, a limited sample, but it just kind of shows the complexity of the microenvironment here, how we were hoping to target some of these indwelling cells. And there's clearly high and low expressors, but looking for responses has not sort of panned out with this, at least looking at these signatures. So just in the last couple minutes, I'll focus a bit on cardiac sarcomas. So I will point out this paper that just came off the press this week that showed that 9 out of 11 cardiac angiosarcomas actually have KDR alterations, which is VEGF-3 receptor. And so this is really interesting data that ought to suggest that TKIs, particularly those hitting VEGF, might be an effective approach in cardiac angiosarcomas. There's a lovely case report from our dear friend, Dr. Ravi, who's on this call, showing that KDR amplification was associated with responses to pazopanib in angiosarcomas. But again, to echo what many people have said, these are rapidly progressive diseases, particularly if you're the primary tumor in the heart is not resected up front. And any of you who have used TKIs know there's this risk of cardiac toxicity, and not just direct cardiac toxicity in the way of ejection fraction changes, but hypertension, risk of bleeding and blood clots. And so if you have a giant tumor in the heart, that becomes a huge issue while you're waiting for these drugs to kick in. There's a high incidence of brain mets with cardiac sarcomas, so further risk for bleeding on a TKI, especially if there's something you're not aware of in the brain. So always worth taking a look. And then I've seen in angio patients in particular, even just with immunotherapy alone, there's this robust inflammation that occurs up front, but it predisposes to bleeding. So again, it's like, how do you balance all of these different factors? And again, the subtypes really matter. Again, if it's angio and it's got a KDR amplification, I think it makes a lot more sense. If you're looking at other subtypes, that data is less well established, but I'll just show you one patient. This is MAP 004 from the AXI-Pembro study, who had alveolar soft part sarcoma. So she presented with a cardiac MET, and you can actually see this large tumor here in the wall, and had a beautiful response to therapy. So ASPS is a slower growing tumor though, compared to angio or UPS. So you have the time for the immunotherapy to kick in. So in this setting, I think it makes sense and obviously can be quite effective in the right disease. But for just to highlight the things I just mentioned, this is one case report that I found with enlotinib, which is a broad spectrum TKI, and camrelizumab, which is a PD-1 inhibitor. So this was an 18-year-old with a cardiac angio, large right atrium primary that you can see here. I mean, this is just horrible stuff here. And they actually did some genetics, showed they were TLS positive, so should respond to immunotherapy, loads of PD-L1, high TMB, all of our immunotherapy biomarkers. And he had resection, but R1, and then he got postoperative radiation therapy and had progression within 2 months in the disease, so mediastinal and lung mets. So they put him on enlotinib and camrelizumab, but he developed pulmonary regurgitation, pericardial effusions, tachycardia, like all of the things we think about when people are just sort of not doing well. And he died within 4.5 months from surgery. So I think this is sort of the challenge to employing this broadly. And again, I'm not going to steal Pollock's thunder, but I just want to show my 2 cents on the chemo IO story for these tumors. My 2 best responders from my study of doxorubicin plus PD-1 CTLA-4 were a cardiac angiosarcoma and an intimal sarcoma, which was a giant thing in the pulmonary artery. But both of them had primary resection. So we weren't dealing with a cardiac tumor up front. We were dealing with bulky metastatic disease, and it melted beautifully. And these 2 people have had essentially no active disease now for well over 2 years for both of them. So again, I think it can be done. We just need to think wisely. So in summary, angiogenesis is a central driver of immunotherapy resistance, and the whole point of TKIs is to try to repolarize all of this. And I think there's signals of promising data, but we don't have the biomarkers to understand the response and resistant mechanisms. And I still think we're missing that sequencing and dosing approach. How do we best incorporate this? And so again, with cardiac tumors in general, we just have to be creative. I think resection of the primary for any of these tumors, if it's at all possible, will give you some more room to work and a lot more flexibility. So thank you to our surgeons who have so generously taken these on. With that, I will stop. Sorry to be a little bit over, but I'm happy to take questions.
Thanks, Bree. I think Suzanne has a couple of questions in the chat. The first one is about the best response to Cabo alone for LMS PRs in crossover. I think she's referring to the earlier study that you were talking about.
Mm-hmm. Yeah, so leiomyosarcoma is interesting, right? So if you look at the microenvironment of leiomyosarcomas, especially soft tissues, uterines are a whole other disaster, as you well know. But if you look at soft tissue leiomyos, all the tools are there. You've got T cells, you've got macrophages, you've got sometimes upregulation of these pathways if you look at the immune signatures. So we really don't understand what is holding us back in that disease, because immunotherapy and checkpoints really ought to work better than it does. And so I think what you're seeing in that study with leiomyos actually getting responses from Cabo Ipi-Nivo, we actually saw responses in the Ipi-Nivo trial as well, particularly in soft tissue leiomyos. So I think you're needing to boost that initial antigen presentation for sure. You're needing to improve your T cell priming and probably skew some of the suppressive to activating phenotypes. But I think this is one area I'm actually really excited to delve into more, because it's not just Cabo. Like we've seen that in other tumors as well. But I think we don't completely understand why it is we just can't get on top of leiomyos. But we've had partial responders to chemo. The blue here shows like my DoxPD-1 CTLA-4 study, where we've actually gotten deep, durable responses in leiomyo patients as well, but soft tissue primarily. So it's just a really different disease that needs a lot more work.
That's great. That was a great talk. Suzanne has another question there about the 18-year-old case report. whether the death was due to progression or due to treatment-related toxicity.
Yeah, it's a great question. Again, everything's sort of subject to interpretation when you're looking at the case reports. Like, I certainly don't know why chemotherapy wouldn't have been used for an 18-year-old. Frankly, I would have whipped this guy. This guy would have been on doxyphosphamide like in 5 seconds. So again, it's sort of an alternative approach. And I think the radiation piece also is a little dicey. He clearly had progression of disease, but I would argue with 2 months of therapy, you're not even to the point where you can really say progression of disease or not. So with TKIs, you're all familiar with this concept of pseudoprogression, right? There's increased inflammation, the tumors swell, they start to get leaky. Like, there's a whole thing that has to happen. And in an immune responsive tumor like this, TMB, PD-L1, TLS, you're probably going to get some pseudoprogression from the checkpoints as well. So I think what happened here is he didn't have room to get worse at all. Like, he just ran out of room and then died from the fluid shifts and from the stress of the whole disease. But this is reality, right? If you put a rapidly progressing patient on TKIs or immuno, honestly, and then the combination, I think you're going to get into trouble for most patients.
Oh, absolutely. RJ has a question regarding hypoxia. If hyperbaric oxygen has ever been utilized in order to improve the hypoxia situation at the cellular level, in the microenvironment level, and where does that stand?
Yeah, I get asked that all the time by patients. I'm sure you guys do too. So to my knowledge, and please someone correct me if I'm wrong, I am not aware of any data suggesting that we can meaningfully change the hypoxic state with hyperbaric oxygen in the tumors that leads to better outcomes, because it's not really just hypoxia, right? The tumors that we are dealing with in sarcomas are often really, really big. There's a ton of necrosis, right? So like, even if you load up the oxygen, if you aren't perfusing the tumor, like, you're still going to have these relative pockets of poor perfused tumor. So it's not necessarily hypoxia directly that is limiting us. It's really the metabolic state. It's more complex than that, because you're basically living off of lactic acid. You're living off of whatever materials are in there, and the tumor cells are just kind of, percolating in these pockets of necrotic areas. So yes, I think the other concern obviously is how that affects responses to drugs that we actually know can work, or at least we have data to suggest they can work. So I tend to discourage it, but I'm happy if anybody else has like any data that might prove me wrong.
It doesn't look like it's a partial pressure of oxygen in Colorado that is to be blamed more.
Well, it is an issue. I mean, I'll tell you, the relative hypoxia is not great for tolerance of treatment. And certainly when you get loaded with lung mets, our patients get into trouble when they live at 8,000 feet. But I don't know that anybody's proven that you're more likely to have worse outcomes in the state of Colorado because of the oxygen. I hope not. Otherwise, I'm out of a job. I'll have to move to Texas or something.
It's nice for Houston to be strategically located at sea level.
There you go.
I think thank you so much. This is such a riveting talk. Do appreciate your time. I hope your clinic day goes peacefully.
Thank you.
Thank you so much.
Appreciate it, guys. Have a good one.
I just want to, we're encroached a little bit on our little break time that is coming up, but we'll meet back up 10 minutes past the hour for Dr. Pollack's lecture. Looking forward to it. So we'll take a brief bio break right now and rejoin at 10:10 Eastern. Please connect back up.
Okay, I think we're just about at the end of our break. So welcome back, everybody. It is my pleasure to introduce Dr. Pollock, Seth Pollock, who will be our next speaker, talking about checkpoint inhibitors in combination with chemotherapy. Dr. Pollock is the head of the sarcoma program at Northwestern University. He has done extensive amounts of research in sarcoma, both in clinical trials, but also in the translational realm, and has really had quite a lot of focus in the immunotherapy space, even before it was as popular as it is now. So, Seth, thank you for being ahead of the curve in sarcoma, and we look forward to your talk.
Yeah, thanks so much, Suzanne, and thanks for to everybody. Thanks for the invitation. It's really a pleasure to be here. Let me just that looks okay? Yeah, great. Okay, so I'll be talking about immunotherapy combinations with chemotherapy for cardiac sarcomas. And here are my disclosures, and I don't think any of them are relevant to the talk today. So why would you use chemotherapy with immune checkpoints? Well, first, there's really three reasons in my mind. One is that when you kill a tumor, you release these damage-associated molecular patterns. So similar to toll-like receptors, and there are receptors for cell fragments that get released when things are killed rapidly. So the some of the common ones that people talk about are HMGB1, ATP can be one, S100, and all of these interact as part of the innate immune system. So they stimulate other surrounding cells to upregulate MHC, which presents antigen to the immune system. They activate macrophages to become more polarized to an inflammatory reaction. They activate lymphocytes so that lymphocytes are more primed to seek their cognate antigen and react to tumor in a way that will produce cytokines and create more inflammation. Chemotherapy can also cause immunogenic cell death, and by what I mean by that is that the tumor cells will die and be taken up by dendritic cells or other antigen-presenting cells, so that the specific tumor antigens will be presented to elements of the immune system. And then finally, they can kill inhibitory elements within the immune system, most notably the macrophages that we think are a really important part of inhibiting the immune response within tumors. So let's just, I always think about things in terms of histology when it comes to every sarcoma. So we do have data with chemotherapy and immunotherapy combinations for the most common cardiac sarcomas, and that's really what I'm going to talk about today. So that's angiosarcoma. That's a third of cases. Bree, in her excellent talk, alluded to some of this data, and we'll talk about it a little bit. Undifferentiated pleomorphic sarcoma, which is the most common type of sarcoma and also a common cardiac sarcoma. We have some data. And then leiomyosarcoma, I'll talk a little bit about as well. I feel like in Chicago at Northwestern, intimal sarcoma is one of our more common cardiac sarcomas. I was surprised that it's not higher in the list of the most common cardiac sarcomas. But even though there is some data and isolated reports about immunotherapy responses in intimal sarcoma, there's not that much. Because they're not chemotherapy sensitive as a rule, there really isn't clinical data right now about intimal sarcoma with chemo and immunotherapy combinations. Synovial sarcoma, likewise, another important cardiac sarcoma, and a very important important disease when it comes to targeted immunotherapy, meaning immunotherapy where you know the specific antigen of interest, like in a cellular therapy, like in a vaccine. Those have not been responsive to checkpoint inhibitors. And despite a very famous response in the what's called the SARC-28 study, which was a trial of pembrolizumab, there haven't been a lot of responses in synovial sarcoma. The largest one was actually a vaccine study that treated over 50 patients with a PD-L1 inhibitor that had synovial sarcoma, and there were no responses in the synovial sarcoma patients. So we don't think of that as being a checkpoint inhibitor responsive disease, and because of that, there really haven't been a lot of patients treated with chemotherapy, immunotherapy combinations in synovial sarcoma. Also worth mentioning, rhabdomyosarcoma and PNST, not very checkpoint inhibitor sensitive tumors. Also, more unusual cardiac sarcomas, and because of that, there's not a lot of cases of patients treated with chemoimmunotherapy combinations. So I'm not really going to be talking about those today. So these are really the ones that I'm going to be focused on. So angiosarcoma, of course, it's a hot topic. What should be the frontline the frontline treatment for patients with angiosarcoma? Some people don't think it's controversial, but I think I actually think there's a variety of different opinions when I talk to different people about how they treat angiosarcoma. I think there are some patients that get doxorubicin. I think there are definitely patients that get doxorubicin with ifosfamide. I think there's some patients that just get single agent taxane. And of course, single agent taxane is an effective treatment for angiosarcoma. But in terms of what in cardiac sarcomas, a lot of the times you really want the best response because this is probably before a surgery. So, for me in our practice, when we have a patient in the metastatic setting, especially one who had a cutaneous sarcoma, we'll frequently go to a single agent taxane first. But I think if you really want to shrink the tumor, if that's your main objective, I think there's a lot more to talk about there. I think AIM might have a better response rate. That's something that we could talk about. But there's good, there's a lot of ways to do it, but I'm going to tell you about the study that was done by the Alliance and presented by Junico Grigliolson, who led this study that compared paclitaxel to paclitaxel with nivolumab, the PD-1 inhibitor, in patients with advanced angiosarcoma. So this trial, I'm going to skip ahead. Yeah, here we go. I'm sorry. So this trial, there was patients were randomized who had never received a taxane before to either get paclitaxel with nivolumab or paclitaxel as a single agent. And you can see there were about 30 patients on each arm, 32 with the combination, 35 with paclitaxel. These patients had to have advanced angiosarcoma, not amenable to surgery. They had to have a good performance status, and they had to have measurable disease. And for these patients, they couldn't have had a taxane before. I thought the arms were pretty evenly balanced. The authors noted that there were more women on the combination arm. You could say that there were a little bit more breast primaries in the combination arm, but they were largely a well-balanced cohorts. And this is a slide that Bree had showed before, and what it basically shows is if you look on the PFS curve on your left, that there's basically no difference between the taxane versus the combination, with the combination in blue. You can see, if anything, there's maybe a trend towards the single agent activity in the taxane alone arm, which was not a statistically significant trend. But on your right, you can see where you break it up by primary site, that the patients who had scalp and face disease, which is the broken line, the broken blue line, those patients did significantly better than the patients who had the scalp face that were treated with the taxane alone. That's again the hashtag red line. And the reverse was true for the patients who had non-scalp face. It wasn't statistically significant, but you can see if you compare the solid line that's red to the combination solid line that's blue, it seemed like for those patients there really is a trend towards better outcomes with just a taxane alone. And it makes sense, just if you think about it biologically, that the scalp face tumors, these are the ones that are induced by UV radiation, we think, and they have very mutation heavy tumors. There's a lot of T cells that react to these mutated proteins that are mutated by ultraviolet light, that those patients are going to have a more robust response to the checkpoint inhibitor. This is showing the waterfall plot, illustrating the combination on your left and the single agent on your right. And you can see on your left, pretty much every the patients with scalp and face disease did fantastic, but there really weren't any other great responders, these complete responders in the combination that didn't have scalp face. So I think what this is showing is for patients with scalp and face angiosarcoma, those patients probably do benefit from this combination, but for the cardiac sarcomas, which I would argue are not like the scalp and face sarcomas, they're more like the every other kind of sarcoma, I don't think that there's any benefit to the checkpoint inhibitor in this combination. This is just showing the durability of these diseases for the patients with scalp face angiosarcomas. For some of them, it really was durable. You could see the yellow lines on the bottom on your left. Some of them are very long lasting, but again, only for those patients and not for the angiosarcomas that we think are more like the cardiac sarcomas. So I don't think there's any benefit to the chemotherapy immunotherapy combination of paclitaxel and nivolumab in these cardiac sarcomas. This is just alluding to this cabozantinib nivolumab data that Bree was talking about, and these patients did really well. I think this is something that you might want to think about in a very refractory cardiac angiosarcoma, because those patients did very well, but that I'm not sure I would do that kind of upfront. These were refractory patients, so this is something to consider in late lines for patients with refractory angiosarcoma. Again, these were very durable responses, so we are doing this for our patients with refractory angiosarcoma, but not upfront. And this is addressed by Bree in her TKI immunotherapy talk. I think it is a good combination for refractory patients. Next, we'll talk about undifferentiated pleomorphic sarcoma, which is really, I think of as the family of diseases related to undifferentiated pleomorphic sarcoma. There are a lot of histologies that we consider to be similar, and this is sort of the basket that used to be called malignant fibrous histosarcoma. They're very deadly cancers, even when they're not cardiac sarcomas, and they do have single agent activity, we know from checkpoint inhibitor, and they also have activity in a randomized study in the neoadjuvant setting with radiation. So we were interested in trying to combine a PD-1 inhibitor with doxorubicin. Doxorubicin is, at least in our practice, the most commonly used regimen for patients with advanced unresectable undifferentiated pleomorphic sarcoma, or sarcomas generally. And you can see these are some of the studies that included doxorubicin single agent arms, and the PFSs are generally in the 6-month range or less, with one study at 6.8 months, and response rates are generally 20% or less. And because of the large body of literature, I talked about kind of the things that we think might make chemoimmunotherapy beneficial. There's lots of literature about all those points with doxorubicin in particular, even going way back beyond the beginning of immunotherapy. You can see that this is a figure from 2005 where they show immunogenic cell death caused by doxorubicin. And this was so we did this phase 1/2 trial of doxorubicin plus pembrolizumab. This is all comers. This is all types of sarcoma. And you can see that there were a lot of responders. The overall response rate was 19%, which is consistent with the better studies of doxorubicin, and a PFS of 8.1 months, which is better than some of the other trials. But of course, this is a phase 1/2 trial, and there's always better outcomes when you look at some of these early phase trial populations that have to be fit and are often self-selecting for some of the best patients. But when you looked at some of the histology specific results, we did think that the results were pretty impressive for undifferentiated pleomorphic sarcoma and for dedifferentiated liposarcoma. You can see this patient. I like this figure because it shows the combination chemotherapy. There's a great response, and then it continues on the single agent checkpoint inhibitor in these patients. And you can see these were very long lasting responses. One of these patients I just talked to a year ago, and she basically ultimately had a complete response years after starting on the treatment, and she was still doing well 5 or 6 years after being on the trial. So we do think it's an effective combination, and we weren't the only people to study it. So there's another trial from North Carolina at the done by Livingston et al. And they also saw very good response rates in the UPS patients. 100%, all 4 of their patients responded. And they also saw great responses in liposarcoma, where they had a complete response and partial response and a number of stable disease patients. People also point out that the leiomyosarcoma patients did pretty well with nice objective response rates and partial responses. So this is now being studied in a large phase 3, large for sarcoma, phase 3 randomized trial that we are running through ECOG Akron. There's going to be 180 patients randomized with a metastatic or unresectable, undifferentiated pleomorphic sarcoma. They get stratified by having ECOG performance status of 0 or 1. Either the patients get randomized to doxorubicin plus pembrolizumab, which goes on for 6 cycles, and the doxorubicin drops out, and then they keep going with pembrolizumab, or they just get doxorubicin for 6 cycles, then they're surveillance, then they get surveillance, and when they progress, they get pembrolizumab. And this is available in Canada. It just opened in Canada. I think most sites are probably still finishing their implementation, so we haven't actually enrolled anybody in Canada yet, but you will be able to put patients on this trial. Okay, what about leiomyosarcoma? Oh, I'll mention one other thing about this trial. There is discussion right now of having a parallel randomization with dedifferentiated liposarcoma. So that may be coming your way soon as well. What about leiomyosarcoma? This is a study recently published by the Spanish group where they used this combination of doxorubicin and dacarbazine with nivolumab. And they had similar clinical results to other chemoimmunotherapy combinations, but what was unique about this study is that they really saw that the patients where they were able to detect the release of this damage-associated molecular pattern, this DAMP, in the serum, in the patients where there was a lot of it induced, they saw better responses. At least it looked that way when we looked at the results, in a plot like this. So that was that was exciting because it kind of showed the biology of what's going on. There's been a lot of looks at combining, or a lot of interest in combining trabectedin with immunotherapy, because trabectedin is very effective at killing macrophages, at least in mouse models. This is from this, this paper you can see the reference is I'm sorry, it's in the bottom, but it's Germano et al. It was from Cell. It's from 2012. It's that this figure I really like it because they basically replaced they depleted the macrophages and from these mouse tumors. And they found that most of the effect of trabectedin in these mouse tumors was from killing the macrophages, and they showed it very elegantly by repleting the macrophages in some of the tumors. So, because of the mechanism of action of trabectedin against macrophages, I think a lot of people have been excited that maybe this would be a really effective agent for combining with immunotherapy. And we saw this in a retrospective study when we looked at patients who had done well on trabectedin. It seemed that the patients who had when we looked at gene expression in formalin fixed tumors, the patients that had macrophage gene signatures did better. We did a study combining trabectedin with the PD-L1 agent avelumab. Michael Wagner, who spoke earlier, was the first author of this, and we did a dose escalation of the trabectedin along with avelumab, and we saw pretty good results with a decent PFS of 8.3 months and which was better than the previously reported PFS for trabectedin. And for patients who had if we looked at their blood and we did TCR sequencing, the patients who seemed to have a more focused T cell response, the kind of T cell response that we think of as being better for tumors, those were the patients that had PR. So that was a really interesting biologic finding. There have been some other looks at trabectedin and immunotherapy combinations. There was a German study presented at ASCO 2023 that found similar results. And then there's a private practice in Los Angeles that does a lot of these combinations off trials and has reported similar results in retrospective series. So to review, there's been a good look at taxane plus immunotherapy in angiosarcoma, but there really wasn't activity there. And there is a good look in a phase 3 trial that's happening right now in UPS. And leiomyosarcoma, there's been some look, but maybe there's a hint of activity, but I don't think anybody is well, I don't know. There's some people who are interested in exploring this combination further. I'm not as excited about that. So in summary, chemo plus immunotherapy is not yet the standard of care for any sarcoma type. The taxane plus PD-1 inhibition is probably not an effective combination for cardiac angiosarcomas. Doxorubicin plus PD-1 is being tested in a large phase 3 randomized trial in the US and Canada, and chemo plus PD-1 inhibition still has an evolving role for leiomyosarcoma. So thank you.
Great. Thanks so much, Seth. That was a great talk, as always. I'm just looking to see if we have any questions yet in the chat.
While we wait on the questions on the chat, Suzanne, may I ask a question regarding the angio taxane plus checkpoint inhibitor data? The results were really very intriguing for me to actually see, even try to understand it. So wanted to pick your brain, Seth, about what you think might be operating there. We do know that taxanes have activity, at least in cardiac sarcomas. Taxanes generally aren't as stellar as in the cutaneous setting. I always thought that was because, in the cutaneous setting, there's more of that cooperation with the immune system that is necessary. And in any case, taxane has individual activity separate from the checkpoint inhibitors. Checkpoint inhibitors seem to have good activity in the cutaneous setting, as Mike had pointed out. And in the visceral, it's still something to be looked at. We all have individual reports of cases. So how do we put these two together? Should it be used sequentially, or is there still further investigation of the combined approach that needs to be looked at? How do you see this?
Well, for the cutaneous ones, I haven't been combining them. It's a good point. I've been doing it sequentially. I do think there is that data was intriguing, but the thing is that it's not, as you said, there's activity of both, right? So it's not clear that it looked like in the subset analysis for just scalp and face that the patients with combination, they had better responses, they had better PFS, but it's not clear that uh, in the advanced setting, what's really more important is how long do the patients live with great quality of life, right? So it, it's not clear that sequential administration of taxane followed by the PD-1 inhibitor is not superior to the combination. And I'm a little suspicious of it, just to be frank. I think maybe it's better to try one and try and really get as much as you can out of one, and then followed by the other and get as much as you can out of that. So that's my personal bias. I don't think it's wrong in a cutaneous patient. Yeah, it's really tough to sort out the differences between cutaneous and non-cutaneous angiosarcoma. I think that there's the non-cutaneous are less responsive to these agents, but they're also just less responsive to everything. So but it was striking to me that actually it looked like the patients were doing worse with the combination taxane plus nivolumab versus the taxane alone. And maybe that's just random, assortment of patients, but maybe it's real. So I definitely don't think it would be reasonable to use the combination in a non-cutaneous patient. I do use single agent checkpoint inhibitor in a refractory non-cutaneous patient because at that point you got to try something, and they have great quality of life, so it's worth it. And I think most people do have a case where a patient responded or at least did well with a checkpoint inhibitor in a non-cutaneous patient. So I think it's worth a shot.
That's the question, if nothing's else. Is that okay, Vinod? Can I ask one?
Yeah.
So one quick question, because I know we may be needing to get onto the panel, but do you think that the combinatorial partner matters? Like, is it the disease, or does it matter if it's Taxol versus doxorubicin versus TKI? Like, do we know anything about that?
Um, we don't know as much as we should, right? But my hunch is that it matters. I think it does because I think that I think there's multiple different components for how these things work. One is just kind of like how, like the rate that they kill the tumor. So I think you want fast tumor kill so that
Mhm.
the mutated proteins are released intact, and there's less autophagy that's going on, right? You want to alter the immune microenvironment in a way that preserves antigen presentation, but reduces the inhibitory immune elements. So I think it probably does matter. And I think it matters the subtype as well. So it's a really complicated thing. I don't think our models are very good for studying this. I think we're looking at kind of subtle things when we talk about the different, we're talking, I think in the mouse, you're putting a chemo into it. I think it's affecting
Mhm.
human very differently. And once you get into chemoimmunotherapy combinations, there's just so many different areas for variability that I think can get washed out in the models.
Yeah.
So I think it's hard to study.
No, thank you.
I also feel like, sometimes in these non-myelosuppressive chemotherapies like single agent Taxol on a weekly basis, one of the things that we've noticed, at least on the clinic side, again, observation bias is always going to be there. When patients who are on solid organ transplant post immunosuppression state or HIV, and they develop these malignancies where we use taxanes. The kind of responses I get are nowhere close to what I get with people with competent immune system. So in a lot of times when we are thinking about using these agents by themselves, they're not in skid mice. They're really in people with competent immune systems, which may be getting,
Right.
as you pointed out as well. So it makes the teasing out of what is the contribution of the immune system even more tricky. I feel just was wondering if you've seen this as well.
I absolutely think it's true. I think that we undervalue the contribution of the immune system to the conventional responses that we see. And I think that it definitely is playing a role. Absolutely.
These these immune modulators are theoretically, fantastic, but practically a little bit disappointing in terms of what's happened. Why do you and others today feel, hypothesize as to why it's not working as well as it should? Feel free for anybody to
Yeah, yeah. I mean, I think it's that's like a that's a it's spoken like a cardiac surgeon, right? I think that when I started out, like there was there like when I got into this, there were some people who like Steve Rosenberg at the NCI was culturing till and showing great responses to that, but there were, I think probably a lot of people thought of immunotherapy as being a niche thing, right? And um, now it's standard of care and so many different cancers and has a clear role in even in sarcoma. I think less so in Canada, but in the U.S. I think it's checkpoint inhibitors are a standard part of the treatment of refractory undifferentiated pleomorphic sarcoma. So I think that they've proven that they have activity and now I think what we're trying to figure out is how can we get the most out of them? How can we make them, you know, uh, improve the care of cardiac sarcomas, specifically, right? And cardiac sarcomas is a very particular treatment paradigm, right? It's a place where, we're used to doing these things for patients with really widespread metastatic disease. They have, lungs filled with little tumors. Cardiac sarcomas, one little tumor growing in a little bit in the wrong way can really impact a patient's life. And it's kind of a different way for us to think about these things. So, yeah, I think we're still making progress with them, and I think we're still learning a lot quickly. So I think we're having success. I think this is what success looks like. So I I don't disagree with what you're saying. It's just that we have to be patient.
why do you think they work when it's everything else has failed and they don't work at the beginning as well?
No, I don't think it's
Themselves?
that. I think they will probably work better at the beginning. It's just that the competition is higher at the beginning, right? So, as I said, with cardiac sarcoma, the millimeters difference of the tumors really matters, and you have big gun chemotherapy that we know can shrink these things, right? So if you're getting somebody ready for surgery, maybe you want to do the big guns, right? And if you're going to replace that or you're going to alter that regimen, you really need good data. You need right. So the bar is higher as you move further and further up in the line of therapy. That's why I'm really excited about our phase 3 trial, right? Because that's really going to be looking in the frontline setting for patients with advanced disease. Although I don't know how many cardiac sarcomas are going to enroll on that because I think probably a lot of the cardiac sarcomas are getting AIM, as I said, because that's a patient that you really need. Where shrinking really matters more than kind of like the long term. Following the patient for years, right? It really matters to shrink it really quickly. But at least we'll get a look in a lot of treatment naive patients how the chemoimmunotherapy combination works.
Yeah. And I think just to add quickly is that I think part of that is the combinatorial partner. That's like what I was wondering, is it something about adding the checkpoint inhibitor to Taxol versus adding the checkpoint inhibitor to doxorubicin? We know the Taxol can work really well for angiosarcoma. Could it, and so that's the bar issue that Seth's talking about, which is absolutely correct. On the other hand, if, does it need to be a different type of cytotoxic? What if we did Cabo-Nivo first line? Would that have looked different? Like, I don't know the answer to that, but that was kind of what triggered my wonder about it. Like, sort of like, what do we need that cytotoxic partner to do in order to optimize the checkpoint inhibitor to make it enhance or synergize with the upfront treatment? I'm not sure there's still questions to ask in that area.
No, absolutely. And I think, RJ, one thing we sarcoma medical oncologists are really good at are identifying drugs that have no activity, because we try a lot of things that doesn't work. And I don't think this class of drugs actually fall in that bin. In fact, I feel like we definitely see activity and specific observations in the clinic. How do we test it in the context of an ultra-rare tumor type in a logical fashion so as to figure out the intelligent partners and the sequencing and the appropriate clinical setting to use that particular tool is the real challenge. I think in a rapidly growing cardiac angio that's doubling every 2 weeks, stepping in with a drug that can take up to 12 weeks for a response to evolve is a recipe for disaster. However, its application, and this is a nice segue to our next section, which is a case discussion, is a patient who was exposed to checkpoint inhibitor where the taxanes actually worked for paclitaxel in a cardiac setting, which I have never seen, and perhaps the rest of the group can weigh in on this, where the taxane worked for 18 cycles, and it was post use of checkpoint inhibition in a patient who developed DKA because of the use of checkpoint inhibitors. So clearly the immune system is getting engaged. We know that from the toxicity that the patient had, and it changes fundamentally the way in which the patient's tumor is behaving, even to therapies where we don't have a track record of having excellent responses. So I think we're in the early stage of investigating the activity. I think, as Michael had pointed out, and Seth and Suzanne have alluded to, we don't know exactly what is the right sequence to apply these. There is activity, and how we sequence it is going to be the subject of a challenge and our investigation going forwards. But as we study these drugs in other sarcomas, I think that's going to evolve. The neoadjuvant use, as Dr. Chrissy Rowland and others have utilized, have shown like spectacular results in the neoadjuvant setting, and its impact on even recurrence-free survival is quite impressive. This is the Stand Up to Cancer paper that had come out with the preliminary. I'm pretty sure there's a very high probability it'll show survival advantage on the update that is coming through as well. So I think the class is interesting. How we use it needs exploration, and that's exactly why we have these sort of discussions going forward.
Yeah, that's why I love listening to you guys, because you guys are the smartest folks in the world, listening to what you guys are doing and then putting it into practice to see whether your thoughts are correct. I've really enjoyed it, and I look forward to the rest of it.
I think we're a little over time, so we'll thank you, Seth, for this amazing
Thank you,
talk.
everyone. Thanks. A great conference. Thanks so much.
Thank you. So we'll move on to our next topic, which is really a case discussion. We have a fantastic panel. So I have Dr. Prapasan Thirasester, who would be discussing the case of one of our star fellows here at MD Anderson. We have Dr. Dinesh Tavendiranathan, who is also a cardiologist, joining us from Toronto to be weighing in on the cardiology aspects of both the diagnosis and some toxicity consideration. And my good friend Andrew Bishop, my partner in crime from radiation oncology, regarding application of radiation approaches in these particularly challenging site where we always worry about cardiac toxicity of radiation, and how can we intelligently approach it. And RJ, who needs no introduction, will be joining us for the discussion of the surgical aspects of the case we are hoping to present. The overall goal is really to try to get a theme of how these patients present and how we can actually improve on our process flows associated with managing of this disease, and hoping to have a lively discussion. As always, please feel free to include questions in the chat line. I'm happy to incorporate that into the discussion as we move forwards. Professor Zorn, over to you.
Thank you for the kind introduction, and also thank you for this opportunity to present this interesting case. Do you see my screen?
Yes.
Okay, I will move forward to the case. So this is the case of a 47 years old woman who present with the progressive dyspnea for more than sorry. I know where my slide. Okay, for more than 3 months. She present with the heavy chest pain, shortness of breath, autopnea, and PND. She was trying to stay active and start jogging, but then she experienced a lightheaded while she exercised and had many pre-syncopal events. So she went to the PCP, which she has done the EKG, and then she was referred to cardiologist who ordered an echocardiogram and a PE protocol CT scan. As you can see on the right side are the pictures from her CT scan. Then the case was proceed to do the MRI of the cardiovascular scan, which showed the lobulated right atrial mass, 8 centimeters, invade free wall of RA and extended to the RA appendage. There is no evidence of vena cava extension. As you can see, as the invasive nature of the mass and the presence of the first pass perfusion in the MRI, these are favor malignancy process, which can be sarcoma or metastatic from the magnetic scan. The patient had no more LV, RV, and LVEF. So then she will proceed to do the biopsy, the open right anterior telecotomy biopsy of the mass. During the procedure, the first section showed high-grade sarcoma, which may consider neoadjuvant chemotherapy. And the final diagnosis was high-grade sarcoma with high mitotic rate, consistent with angiosarcoma, with the IHC showing the strong and diffuse positivity for vascular markers. On the left side are the picture of her MRI. It is imaging at initial presentation. Okay. It is imaging of the MRI. So at this point, I will move forward to the panel for discussion of how to manage this case. Oh, Dr. Levy, you are mute.
Oh, sorry. Let me go ahead and start off the discussion with connecting with Dinesh here on the presenting symptoms. We often hear the story from patients regarding presenting with shortness of breath. How does this look like, the workup of this look like for those of us on the front line where you're in a ER setting or an cardiology setting and a patient is presenting? When does a index of suspicion of cardiac tumors typically start, and how do you proceed with that workup?
Thank you. I think as you've heard throughout this conference, these are uncommon things. So on average, when you see somebody with shortness of breath, you think of common things, right? A 47-year-old woman, obviously, you're a bit worried that there's something atypical when she presents with shortness of breath and sort of functional decline and progressive dyspnea. It's a bit worrisome. So you look for common things, and you look for pulmonary causes, cardiac causes, etc. Our typical workup obviously is with an ECG, and if you find anything abnormal, then you sort of pursue from there. I would imagine in the ER now, with the availability of POCUS and ability to quickly have a look at the lungs and the heart, I think POCUS is very commonly used, and a common referral for us is there's something abnormal on the POCUS. We're not sure what it is. In this woman, for example, there may be obstruction to flow from the IVC or the RA to RV, which obviously raises the concern whether it's a forward flow issue that's contributing to her symptoms as well as to her syncopal episode or pre-syncopal episode. And then, of course, then that progresses on with an echocardiogram, which allows us to have a hemodynamic assessment of what's going on. I think that's important. That's a unique aspect of echocardiograms. And then subsequently moving on to some form of more definitive imaging, understanding what's going on in the entire chest, as well as some tissue characterization techniques, as you heard about, to try to help understand what this may be, keeping in mind all our non-invasive testing can point in a direction but not make the diagnosis. Ultimately, tissue is king, but it helps us kind of decide what it could be and what the differential diagnosis is. For the sake of time, I'll stop there and answer other specific questions.
Thanks, Dinesh. So I think index of suspicion and preliminary imaging are going to be kind of crucial to kind of drive the workup in the direction of tumors. May I ask you, at least an echocardiogram in the investigation of a patient with shortness of breath, what percentage of patients do you think would have at least that transthoracic echo, somewhat of a broad screener where these patients may get picked up early enough?
Yeah, for shortness of breath, Ravi, I mean, it really depends on the pre-test, right? And I think, you really have to have a high index of suspicion that there's something cardiac contributing to the shortness of breath. And I think the index of suspicion is high, especially with now POCUS. I think it is not uncommon for them to get an echocardiogram as a screening test to look for causes of shortness of breath.
That's certainly reassuring. So I'm gonna.
I think the age. I think the age of the patient is as well. So if this were a 20-year-old, you may not get an echo versus a 47-year-old, as he said, pre index of suspicion.
So to answer what POCUS is, I'm sorry, it's POCUS. It's point of care ultrasound. So echocardiogram were the typical ways to assess the heart, but now I think ultrasound has become more accessible to anyone who can kind of understand what ultrasound provides. So this point of care ultrasound is now used in the eMERGE for multiple different things, including quick cardiac assessment, pericardial assessment, lung assessment for pleural effusion, etc.
And the interpretation is this? Are there any tools built into the device that picks up things, or it's very operator dependent? Because whenever I look at ultrasounds, I see what I see. Yesterday, looking out of the window in Houston, it looks like a snowstorm, not a whole lot of things going on there. So how does that work?
Question. I think in POCUS, the world of POCUS standardization has been the challenge, right? For me to read echocardiography, I need a fellowship training, a certification, and examination. I think the regulation of POCUS, I think it's evolving, and there are societal guidelines now, and there's a need for training, and billing remains a challenge. And in Canada, for example, for billing purposes, that you need certain level of training. And then, of course, many of them have the benefit of the expertise to say, some of the calls now on call, unfortunately, to say, can you look at my images? Because I don't know what I'm looking at this point. So adds a challenge to us, but I think there is a move towards standardizing this, and I think it'll get better. And now POCUS is being, part of the medical school curriculum, right? So I think we'll see more and more use of POCUS and a lot more experience with it.
Thanks, Dinesh. So RJ, this is a patient that at least at preliminary workup, we are not seeing any metastases. So how do you assess resectability in a case like this?
Yeah, clearly a case like this, we always, at the beginning, before I met you guys and got really more into it, we would resect something like this, or at least attempt to resect it. But the important points, other than the metastatic issues, are whether you can completely resect it. So in other words, does it affect something that if you want to remove it, you can't because of that other structure? In this particular case, I'd be really worried about the pericardium, whether it, even though it usually stays inside the heart, a lot of times you see it outside the heart, and a lot of times there'll be a localized adhesion to the pericardium. So you have to worry about removing the pericardium with that, and does it affect the phrenic nerve? You can usually peel it off posteriorly. But more importantly, the SVC, and here in this particular case, the IVC. The IVC to me has not really been excluded from the resectability point of view. So the IVC, you can resect it. It's about 3 centimeters long, the IVC, between there and the diaphragm. So you have about 3 centimeters to play with. But notoriously, when you resect one of these, usually after chemotherapy, even though you look like you're resecting normal tissue, by microscopy, it's the R1 resection. So when it's huge like this, especially when it gets so close to the IVC, I'd be really scared about that. And if I were to resect this, I don't do that anymore prior to chemotherapy. But if I were to resect something like this, let's say a person were in hemodynamic trouble, I would resect the IVC and reconstruct the IVC and the SVC, even though it looks like it may be clear of the SVC, and resect and reconstruct the SVC, IVC, right atrium. And then depending on how close it gets to the AV groove there, the right coronary, I would resect the right ventricular inflow tract as well. So all those things are removable, but there may be some things that aren't, but you have to do a really wide resection for that. And it's really nice to give neoadjuvant chemotherapy. I don't know that it necessarily reduces the resection amount that I would do. So if I were to do a resection of this patient, if she were to respond to neoadjuvant chemotherapy, I might still reconstruct the IVC and SVC to ensure I get an R0 response, or maximize my benefit of getting an R0 response, including pericardium. I would resect the pericardium on that side of the heart. So it's really, is there anything that's going to prevent you? Anything that's not disposable? The things that aren't really indisposable, the things that really are not very disposable in the heart, are really the base of the interventricular septum. I'm a little bit scared to resect that. I have resected portions of the AV groove along with the left ventricle, portions of the interventricular septum, but that's the area where we sort of get problematic, because the mitral valve, tricuspid valve, aortic valve, and pulmonary valve, along with the interventricular septum, are in that area. It's a lot of heart to resect. But that's the things that we look at. What can you remove and what you cannot remove? We've resected portions of the liver, along with taking the liver out and resected it along with that stuff. So you can do a lot, but you really need a specialized center and a specialized group of individuals who work well together to do these kinds of resections, because they're monster resections.
So I'm hearing locally advanced is not necessarily always a contraindication to a surgical approach, and neoadjuvant therapy is something that we certainly would love to engage. Last quick question is oligometastatic disease. If there was a 1 centimeter spot in the periphery of the lung, how does that change your outlook on this case? And if it is not just one, and if it's 3, how does that change the way you look at this case?
Well, I always, as you know, I've been part of your tumor board for a long time, and we have our own here at Princess Margaret Hospital. I ask every oncologist what they think about it, because I can do whatever I want, but you guys have to take care of them later on. I remember there was one lady who had exactly the same sort of thing. She had an angiosarcoma and had an anterior thoracotomy biopsy. That nowadays we would do a needle biopsy, but percutaneous needle biopsy. But the bottom line is she had a great response to neoadjuvant chemotherapy. I did a big resection on her. And at the time she had these like 2 millimeter spots in her lungs that I asked the thoracic surgeon to go and resect. And I was surprised that she was actually able to feel them. You know, what they do is they go in at the same time and with their fingers, they feel the lung and, oh, there it is right there. And she wedge resected it. I saw her 2 months postoperatively. She did fantastic from her case. Lungs were cleared, CT scan. 1 month later, she was dead from metastatic widespread disease. So I get scared about it. I don't do it unless I get confirmation from both our oncologists and the tumor board that I'm part of a neuro center to see what you guys think. I'm scared about metastatic disease. The one that I showed this morning, you know, that guy had mets in his liver, and I didn't do him. I sent him to radiotherapy, even though it's lovely to resect it. I haven't really had any local recurrences, but I'm scared of the distant disease.
Thanks, RJ. Professor, on back to you for regarding what neoadjuvant therapy this patient received.
This patient, she received AI over 5 days for 5 cycles. She tolerated well in the very first cycle, but then later on she had pancytopenia requiring the transfusion, both the red blood cell and also platelet transfusion. She had severe fatigue, and in the end she developed pneumonia and constipation, and then we have to change to gemcitabine and docetaxel due to the other toxicity. So she received another 2 cycles with gemcitabine docetaxel. And during gem and docetaxel, she had anemia and platelet decrease requiring transfusions as well. A little bit of neuropathy and swelling, which resolved by the time. This is the imaging before starting the chemotherapy. Through the AI, as you can see the PET scan here, that the activity and the size of the primary mass slowly decreasing, and the SUV slowly decreasing as well. Also, after receive gem tags, another 2 cycles, the activity further declining. As you compare this CT scan that compare before and after both regimen, the mass like decreased a lot.
So let me just check in with my meta colleagues regarding neoadjuvant therapy. This patient, Professor, if you could go to the previous slide there. So it looks like patient was treated with 5 cycles of AI. We really didn't get to cycle 6 because of some toxicity, then switched around to gemcitabine and docetaxel as we were preparing for a surgical resection. Dr. George, does this seem like an approach that you would take? Is there a different way to proceed with this systemic neoadjuvant approach? Are there other agents or approaches that you would consider?
Yeah, no, it's a really good question. I think this was very reasonable. The only thing that has come up at times at our center is whether to start with something doxorubicin based or to start with Gemtax. That has come up at our center because we in Boston are close to the proton center at MGH, where there has been historically an interest in doing radiation with protons to these types of tumors, and their preference has been to minimize upfront anthracycline prior to the radiation. But that is an anecdote. So I think everything that you guys, I think this makes good sense. Whether to do AI first or Gemtax first is just, I think, an unknown question and really depends on what the multidisciplinary team thinks in terms of potential toxicity risk from either in the context of the overall treatment plan.
No, that seems very, very reasonable. We, at least in this particular case, toxicity even though the patient is young, we ran into a lot of count-related issues, and she was not one of those patients who tolerated the therapy immensely well. So we were finally in May of 2018 at a point where we were sort of considering, okay, it's a time to push the patient to the local consolidation approaches, whatever we need to do. I'm not sure if Mike is on. Dr. Wagner, could you let us know if you are?
Oops, sorry. Can you
Yeah.
repeat? I
Yeah.
was multitasking.
No worries, Mike. Mike, so this patient, as you can see from the panels, has received, 5 cycles of AI and the gem tags, seems to have had a reasonable response. And having some degree of toxicity, would you push on with more chemotherapy or consider, because of toxicity, we were kind of thinking about moving into local approaches to the patient is non-metastatic at presentation and no mets developed during the initial treatment. Was just wondering if this is a point where you would consider pushing to surgery or not.
I probably would, depending on what a surgery would entail, because these are major surgeries. But if it's localized and the surgery, I'm always impressed by what the cardiac surgeons say they can easily do. But if this is something that could be removed with an expected negative margin, then I think moving ahead with surgery would be reasonable. And the alternative, I think Dr. Bishop is on, would be considering something like radiation if a surgery couldn't be done.
So Andrew, the question for you is, is this something that you would want to pursue more definitively, dosing consideration, this location for more definitive versus would you consider something neoadjuvantly? And if you were to do something like that, what would be the best way to work together with the surgical team so that fibrosis and other issues post-radiation don't mar the surgical approaches that come after?
Yeah, thanks for the question. So obviously the topic of radiation for these cardiac tumors is complex. It's always we're trying to balance the benefits of the treatment with the risks that we all know that radiation has. Incorporating radiation for these patients can be done in multiple ways as part of the combination therapy with surgery. As part of a definitive treatment in unresectable tumors, in the management of METs or oligomets, as well as palliation, and so each of these cases, has to be so individualized and discussed with a multidisciplinary team to kind of come up with the right strategy. In this particular patient, obviously, we rely on our surgeons to tell us resectable or not. If it's not resectable, definitive radiation is an option, and that can be done. If you look kind of at the literature, the series that report on radiation are marred a little bit in kind of the old techniques. It's historical series where radiation techniques were a bit more primitive than they are now. And so we do have new capabilities that allow us to kind of get good dose in and try our best to spare certain nearby structures or organs at risk that we think about. So definitive radiation is an option. The question of neoadjuvant radiation, in the management of sarcoma, obviously preoperative radiation is well established as a standard option. But it comes down to risks benefits. And in cardiac tumors, if you look at the literature, there's a handful of patients that have received preoperative radiation. But I personally worry about that. I would worry, I have that discussion with my surgeons. But with the wound complication risks, the potential to increase surgical complexity, I probably would lean more towards a post-operative approach when incorporating radiation versus a neoadjuvant, unless we really thought that benefit of radiation was going to help make surgery feasible, reduce the size of the tumor, and we were accepting of those risks.
Got it. Thank you. Professor, on back to you.
Okay, thank you.
I think this is the paper that showed the that neoadjuvant approaches
The role
may
of
do more to a margin negative resection, which I think is I think, as RJ was pointing out, is pretty helpful in the long run. Back to you, Professor.
So she received the surgery in May 2018. The surgery required the use of cardiopulmonary bypass and also the reconstruction of the RA with the pericardial patch. There was no complications during a procedure, but after surgery, about 1 week, she developed heart block, which required pacemaker implant. The pathology report reviewed angiosarcoma 6.5 centimeters with treatment effect around 60 to 70%. But the margin involved by the tumor at the superior caval margin. You want to discuss more about the margin? I'm sorry.
No, this is a good segue. So it looks like RJ, the resection was actually had a margin positive outcome. And before I go there, I think Suzanne has a question in the chat line about whether the patient receives Zinacard. All 5 cycles were administered along with Zinacard. It was given bolus with Zinacard.
Yes. So in MD Anderson, we always give the Zinacard since the very first cycle of doxorubicin. Yeah.
So RJ, back to you. You've got a margin positive resection. This sort of a situation, how often is it this identified in the OR, or is it a scenario where it's just technically not possible to get a margin negative resection? And what steps do you take post in such a setting?
Yeah, so this is not surprising. As I said, it's not surprising because the myocardium looks completely normal. And I don't know whether it's a positive margin, it's almost like a glacier going backwards, or I think about you drop some milk on the floor and you wash it up, but your cat comes and licks the floor because it's still there. In other words, is this a receding, still positive tumor, or is it just multifocal disease inside the atrium that you don't know about? When you go, I should have shown a picture, what it looks like when you go in there. The myocardium looks completely normal. And that's why I've moved to wider and wider resections and resected the SVC and the IVC, even though it doesn't look like it's involved, because it can be involved. So if I get a positive margin like this, and it's more common on the left side than the right side, but that's what I'll ask my radiotherapist to go and clean up afterwards. So I think that if you have a resection, it's worthwhile to resect it, because inside your specimen of the main tumor, you often will see viable tumor cells, even though it looks like it's not growing anymore. So that's good to do. And you try to resect as much hard as you can, to the point of people going, do you think that might be excessive? People being myself. But it's better to have an excessive resection with an R0, I think, than to have a positive margin. But when it is positive margin, that's when I turn to our radiotherapists here and ask them to irradiate the field that was affected. And I'll sit with the radiotherapists and let them understand what I did in the OR and what may or may not be involved. I mean, I don't know. We don't know. That's one of the reasons for doing the Interact is when a surgeon goes in there and they have muddy hands and they go and move everything around, this tumor spillage happens, and whether we should be standard treating people after cardiac surgery with any kind of therapy afterwards to mop up all that stuff. But when it's clearly involved like this, I always ask radiotherapists. I'm going to turn the tables and ask, what do you guys do in your centers after cardiac surgery? Do you give, I think I know the answer, but do you give adjuvant therapy to everybody, even though the margins may be negative? Is it worthwhile to do that, or just when they develop new disease elsewhere or locally? But that's what I do. what do you guys do in Boston?
I'm not sure we have a pattern necessarily. I mean, if the patient's young and depending on how much they might have gotten neoadjuvant, then I would at least probably offer adjuvant therapy. But if they were heavily pre-treated with AIM and then gemcitabine and Taxol already before, then I'd probably lean more towards waiting
Yeah,
and
we
then
didn't-
starting something systemic when there's a recurrence.
And in Houston?
Yeah, this patient, I think the challenge here was that, the counts were not supporting any additional therapy. If it did support it, I would have given it front loaded because it just increases. If any further reduction could be engineered, we would want it before surgery as much as possible. But anyway, that was not that was just not feasible in this particular patient at that point in time. So it was either stay with the tumor, take a break to allow the bone marrow to recover, or should we, in the break for the bone marrow to recover, get the surgical resection done? And we opted to go with getting the
Yeah.
surgery done
I
at
think you
that
did the
time.
right thing. I think you did the right thing.
The whole question is, Andrew, so the post-margin status, do you feel like there could be something that could have been offered to this particular patient?
Yeah, for sure. I mean, I definitely agree with the comments from RJ. In a case like this, patient with localized disease, positive margin, I think radiation definitely has a role. The data, certainly support that. If you look at some of the larger series like the French sarcoma group, in patients with localized disease, radiation had a progression-free survival and overall survival benefit. So, these patients, obviously their risk of distant metastasis is high, but local recurrences are a problem, and radiation can help with that. It's just a matter of how to get that dose in, how to get it in as safely as we can. But in this case, I think the benefits of radiation would outweigh the risks for me, and I would recommend it for this patient.
Is there anything we can do in the OR that helps you with radiotherapy? Like marking with anything?
Yeah, that's a great question. No, not specifically. I think the most important thing is having a conversation with the surgeon. Reviewing the imaging together, discussing what was the surgery like, what margins are they particularly worried about. I find that sitting down or virtually meeting with the surgeons in complicated cases like this one, and reviewing the scans and I will contour kind of what my target is. And then I'll say, hey, does this fit your concern as well? And having that conversation is more important, I think, than putting clips or kind of indicating in a surgical way what's going to be where we're going to have issues.
And RJ, this is probably an important place to put in a plug that in our multidisciplinary monthly cardiac meetings, we need more representation from RADONC, and we should attempt to do that because I think this is one of the gap areas where we are underutilizing this amazing resource that might have a substantial impact on the outcomes for our patients. I have in the chat box, Suzanne's asking about protons. So, Andrew, any comments there?
Yeah, that's a good question. Are protons necessary? I think the short answer is no. I think protons are one of the tools in the tool chest that, just like every tool, has scenarios where it's most beneficial and scenarios where it's not as beneficial. Some of the physical limitations of protons, if you're going using them to treat a target where there's a lot of changes in density. So you're going from a dense material to a less dense material back to a dense material. There is a lot of uncertainty and unknowns about proton-based radiation. And so, in scenarios like this, going through chest wall, through lung, through heart, I honestly don't think protons are always the best tool. They have an advantage in certain scenarios, and I think it's a nice tool to inquire about and have in our back pocket. But sometimes a good photon plan with great imaging is going to be better serve the patient than protons, in my opinion.
Can we use some brachytherapy in this kind of stuff? Is there anything we can put in that's temporary?
That's a good question too. I honestly don't have experience with brachytherapy in scenarios like this. We do use brachytherapy sometimes, like intrabronchial brachytherapy in certain scenarios. Could we do that in cases like this? Potentially, but I do think that external beam radiation therapy has an advantage in being more comprehensive. With brachytherapy, I'd be worried about a marginal miss, not being broad coverage enough to provide that benefit because of that short, that dose fall off. So yes, it's a tool worth thinking about, but I think in a lot of cases, external beam radiation has the advantage.
Let me ask another question. Let's say that you go in there as a known debulking R2. I don't ever suggest that. If the patient is in trouble, they're going to die. The only reason to do debulking is to let the patient survive long enough for you guys to give chemotherapy or radiotherapy. But if a person were to go in there with a known plan of debulking, definitely leaving R2 disease, is it worthwhile to stick a few things? I don't know anything about it. I'm just asking. I'm just thinking about it today. If you were to go in there, is there anything we can leave behind, or is it still better to do external?
I think it's still probably better to do external, but I do think that scenario is an interesting one, and there aren't data to kind of draw upon to really guide that conversation. But I think if a patient has localized disease and there's a surgical way to debulk the tumor before offering radiation therapy, I do think using kind of first principles that there might be an advantage to that, because radiation, in terms of local control, the bigger the tumor, the less local control we have, especially when we're limited with the dose that we can safely get in, like into the heart. So if you can remove 60-70% of the tumor and leave us with less bulky disease, our chances of more durable local control go up with less tumor. So I do think that there are opportunities there to kind of work together for the benefit of the patient.
And how long after cardiac surgery will you irradiate somebody, or for the oncologist, medical oncologist, give somebody chemotherapy?
I think again, that's kind of a multidisciplinary decision. I probably would wait at least 4 to 5 weeks for healing, and probably err more towards 6 weeks. Dinesh, from a cardiology standpoint or from a surgical standpoint, what would you guys recommend from that perspective?
From my point of view, I'll just jump in. My first dealings with this was a young woman, about 17 years old, who came with a sarcoma, basically filling her right ventricle, and she was in cardiogenic shock, and I resected the whole thing. And I knew I left R2 behind, but the reason for doing it is because she was going to die and I wanted to get some chemotherapy. And 17 days later, she was ready for home because she was in the ICU for a week recovering from her cardiogenic shock. So a week later, she was ready for home. At 17, she recovered really quickly. I got a pre-discharge CT scan, and 3/4 of it had grown back in 17 days or 16 days. And so these things can go really, really quickly. And so I'm wondering, that's why I asked my question. It's one thing about going through the sternum, but is there any way to avoid it by going elsewhere? I know you guys are planning it. I've been through with the radiologist how you plan stuff. But I think 5 or 6 weeks later, for some of these tumors, if we truly leave R2, is not enough time. What about for chemotherapy?
I mean, traditionally, chemo we've administered as long as the skin is somewhat intact. We've pushed through for the very same reasons that we see progressive disease emerge fairly quickly in a lot of these particular patients, which then again brings up this whole question of how much are we really getting by taking that particular surgical break. So we've always kind of positioned that surgical break at a time when the bone marrow really needs recovery, and again, technically keep moving forwards with it, and then kind of gone. At least in this particular patient, post-op therapy with chemo was just not feasible. It was hard to pull off. So, we had to pivot in a different direction. There is a question in the chat regarding the cannulation strategy. RJ, is there, Mike was not available for this time slot, so
Yeah.
do you want to comment on what the ideal?
Sure. When you're going to resect, like in this particular patient, I would cannulate from the femoral. There's obviously a surgeon asked this question. You would cannulate from the femoral vein, so you wouldn't have any tubes blocking the way to the liver. And you can, under low flow, in fact, under normal flow, you can do an open resection of the IVC and attach directly onto the either diaphragm or liver. And then for the SVC, you can always cannulate the innominate vein, so you stay away from the superior vena cava. So there's ways to get around it. There are cannulations that people may not necessarily think about, especially from the head, but you can get around it. And for sure, you should not cannulate within the chest, the IVC. And if you do cannulate within the chest, you should plan for a resection superior to the innominate vein. So it's very, very superior, or if you can't get that superior, cannulate the brachiocephalic vein with a right angle Pacifico type of cannula. And then you can resect even the innominate, resect even the azygous vein. So you have to do a huge resection, otherwise you'll have positive margins. So that's how you cannulate.
Raju, I hope your question was answered. In the interest of time, I'm going to pass on back to Professor to continue the post-op course.
Yeah, so the patient received adjuvant pembrolizumab for 7 cycles. This is the patient who Dr. Levy mentioned before. So after the first cycle, she developed DM type 1, the new onset one. She presented with DKA to the emergency room with dyspnea, headache, nausea, and polyuria for 2 weeks. And also the blood test show high sugar and ketone acidosis, white gap acidosis. She was admitted to ICU and have received IV insulin. After that, she discharged with long-term insulin injection and diet adjustment.
Professor, we'll keep going.
Okay, yeah. So this is the some paper about adjuvant setting.
I think because we're a little short on time, we'll keep on going with
Keep going with the
quick
case.
presentation, because I want to engage Mike and the rest of the Medong team regarding their comments regarding how they would proceed in this.
Sure. So then during the adjuvant, we regularly follow up, but in March 2019, so there was questionable enhancement in the right shoulder area. And then the MRI of the right shoulder was done, which showed the metastatic bone lesion. This lesion, so in conclusion, is about 12 months since surgery. Let's talk about the management at this point. There is no other metastatic lesion at that point.
Thank you, Professor. Mike, Suzanne, so this is solitary metastases presenting 12 months in surgery after being on some checkpoint inhibition. At least to me, it seemed like it did have some impact on the patient's recurrence-free survival. I generally tend to see recurrences a lot sooner. It's hard to say with NF1. This was the very first patient where we, in a cardiac setting, we utilized checkpoint inhibition. I was, as Mike mentioned, too worried about using it in active disease. So which is why we utilized it in this setting. I'll start off with Dr. Wagner. Do you feel like this approach is something that you would consider?
So I'll be very quick because I have a 11:30 meeting I have to jump to. But I'll let Dr. George answer as well. But I think generally, if there's no disease, then at least my practice has not been to treat with immune therapy, in part because of some evidence in other cancers suggesting that neoadjuvant or just having active tumor there sort of helps the immunotherapy work, but then also in part because of the toxicity. And I think we saw that in this patient where they developed type 1 diabetes, and we don't know, was there any benefit with the immune therapy? So I generally would not do that, but waiting in favor or waiting to give it preferentially if there is active disease, even if it's one solitary recurrence like this, at least that would give you a sense of what's happening with the tumor while they're getting the therapy.
Thanks, Michael. Appreciate you staying on. Suzanne, what do you think? In this cardiac setting where we generally tend to see the metastases quite early, would you consider this approach, or do you see the recurrence after 12 months as somewhat perhaps it worked for a certain length of time? How do you see this?
So just to remind me, how much pembrolizumab? I saw that she had one cycle and then ended up in the ICU. Then was that it? Just one cycle?
No.
7 cycles.
No, she had
So
7.
we
Okay.
continue.
Got it. Okay. Well, I think, as Michael said, we tend not to, we're a little more conservative on administering drugs in the NED status. But with that said, I do find this intriguing because to your point is well taken. You would expect, gosh, the fact that she went a year without any disease is pretty impressive to me. So could it have had an impact? Maybe. I don't think it's out of the realm of possibility to consider that it might have. I think it's hard to know for sure, but that's a really nice disease-free interval for this disease.
Yeah, we had a pretty deep discussion with the patient regarding should we even keep moving forwards after the initial presentation of toxicity. This was one of those, oh crap, what have we done here? Because we had no evidence of disease, as Mike pointed out. In a setting like that, there's really no data to support sort of an approach, except the track record of this particular malignancy always recurring in the post-op setting, especially with positive margins. And that's sort of what drove our decision-making to move forwards. Professor, do you want to talk about the systemic therapy that was initiated after this?
Actually, can I interrupt real quick? Albie put a good question in the chat, which is how did you convince the insurance company to pay for it? The Pembro.
That was a very long phone call that utilized the patient's young age and the margin positive status and our dismal. So our survival of our patients with margin positive resection is identical to the metastatic patients. And that was the paper that we were trying to utilize and obviously the insurance company was very sensitive to that argument that those patients have the same outcome as metastatic patients, and therefore we should consider utilization of it. And no protocols were available in a rare disease. So thanks, Albie. That's a very good question. Very practical.
Okay, so the bone metastasis was treated with EBRT to the lesion, but then after that, after finish the radiation about 1 month, the CT PET scan found that there are many more metastatic lesions involving the lymph node around the paratracheal and mediastinal lymph node. Also, the more metastatic at C3 and sort of local recurrent here at the pericardial. It's 3 centimeter with SUV 5.2. So what is the next management in this case?
Yeah, so this is we discovered multifocal involvement. So I want to ask a quick question regarding, when you see lymph node activity in a patient who has received checkpoint inhibitors, do you always assume that this is disease, or do you wait for another site also to show? So, Suzanne, any thoughts there?
Yeah, no, it's a really good question. It's a bit of a struggle. It's something I sit in we have a radiology consult room and say, tell me, tell me what this is. If it's only limited to lymph nodes, I find it very hard. We often will do sort of a second assessment, take into consideration symptoms. So I think unless we have a clear pattern of continued progression and or disease outside of the lymph nodes, we will often give it a benefit of the doubt that it's checkpoint inhibitor related.
No, I think that's the approach that we've had as well. And it was another site of bone met that kind of prompted us to keep on treating with more chemotherapy. Since we are over time, Professor, do you want to just talk about what chemos we used in that setting?
So thank you. So she received paclitaxel weekly initially, and then adjust because of her side effect from pancytopenia. The PET-CT scan later on after the 1 cycle show the response of the precardial disease and also resolve of or the activity in lymph nodes as well. Yeah, in the end, so she received 18 cycle of paclitaxel, and we have to hold the chemotherapy due to platelet decreasing despite transfusion. And after we hold the chemotherapy in December 2020, later on, like 1 month after, she will develop a symptom of left hemiparesis, and the CT scan found that she had multiple hemorrhagic brain metastasis. Yeah.
And this was kind of at the point where we referred the patient to Dr. Bishop. Andrew, any comments in this particular setting?
Yeah, this is a difficult scenario and one that is all too common. So, we reviewed our experience with cardiac angiosarcoma using, a database that you helped build, Vinod, and 25% of these patients develop brain metastases. So we know the risk is high. Surveillance is important for the scenario. And oftentimes, these angiosarcomas have a high risk of hemorrhage, for which terminal hemorrhage is actually a real problem. So detecting these early and jumping on them, getting them treated early is, I think, important. Brain mets management has evolved over the years with increasing efficacy of systemic therapy. Sometimes we will observe small tumors like this and give a trial of systemic therapy to see if we can get CNS penetration and get a response. But for cardiac angiosarcomas with that risk of hemorrhage, I would probably shy away from that approach and use radiation to treat even small spots like this. So how do we think about radiation? If they have limited disease, stereotactic radiosurgery with a tool like Gamma Knife or other tools, very focal treatments, I think are reasonable strategies. For patients who present with more diffuse metastatic disease in the brain, whole brain radiation therapy, while again we try to avoid it in modern radiation days, it's still an important tool and still an effective tool, and should be considered in patients who have more diffuse brain metastases.
Would this be considered diffuse, or would this be something you'd use a Gamma Knife for?
This I'd use Gamma Knife for. I mean, if with an MRI brain, if we saw generally, I mean, there's no rule of thumb for how many we can treat, but if they're 10, 10 or less, generally stereotactic radiosurgery is very reasonable to consider, at least as a first, as a first step. If 3 months later, again, there's 10 more, then you start worrying a little bit about undetected, more diffuse disease. But this is, I would do SRS for this.
But for this patient, we planned for the SRS to the brain metastasis, but then the procedure was home due to her positive COVID infection. And then she had a rapid deterioration and had intubation, and then she deceased before receive any more treatment in this case. Yeah.
Sorry, Professor. Please continue.
Okay.
Yeah, I was just
During
add here that the importance of treating these brain mets in an expedited fashion is clearly. I mean, this was in the middle of the pandemic where the hospital was actually isolating patients who couldn't get any radiation when they were COVID positive. And that interval while she was cooling off from the COVID was enough to generate a fatal bleed, and kind of points to how quickly these patients need to be moved to radiation therapy if it's a ticking time bomb scenario there. So, and I think Andrew has kind of illustrated this in the paper that Andrew published as well. So let him speak about that.
Yeah, I mean, you're right. This is something, before we looked at the data, anecdotally, you would always be pushing the radiation oncology team to, efficiently treat these patients. And there was always this question of, why are we treating a 5 mm brain metastasis? This is why. Because that risk of hemorrhage, because that high risk of terminal hemorrhage is real. About 50% of the patients in our series that had brain mets died of terminal hemorrhage. Which, from thinking about modern day brain metastases series, that's unheard of. And so jumping on these early, getting them treated, detecting them early, I think is really crucial.
Thanks, Andrew. We're really over time, 15 minutes over, so I want to let everyone try to get some lunch, depending on your time zone. We will regroup at 12:30 Eastern. Thank you all for participating. I want to thank the panelists and also our co-hosts and speakers who were able to weigh in on the case discussion here. Thank you so much. See you all at 12:30 Eastern.
Bye.
So welcome back, everyone. Our next speaker is Dr. Cashin Yi. He does have a very tight meeting schedule with another podium presentation right after this, so I want to just make sure that we get started on time. Dr. Yi is one of our superstars at MD Anderson, is a pioneer in adoptive cell therapies, serves as a co-lead of our adoptive cell therapy program and a director of our solid tumor cell therapy program at the Center for Cancer Immunology Research at MD Anderson. He specializes in antigen-specific T cells. Amazing physician scientist. His distance from the bedside is very short. The lab to bedside distance is very short, and all projects are highly clinically relevant. And when we have a difficult case where we are trying to develop novel therapeutic options, I've had the pleasure of working with him, one of the most brilliant minds I've ever had the chance to work with. So I'm really pleased that he was able to find time for us. So the afternoon, we're going to have more tumor agnostic, new innovative strategies that we should consider adopting into the treatment of cardiac sarcoma. So without delaying any further, I want to hand off to Dr. Yi. Thank you.
Hi, thank you, Vinod. It was very kind. And now I have to manage everyone's expectations after that. So also in solidarity with my roots here, I was raised in Toronto, actually, and basically still a Canadian, and I'm hanging on very tightly to my passport, as you can imagine. So let's see. Let me get my slides up here real quick, and thank you again to the organizers at this meeting for the invitation, and delighted to be here. I'm not sure which insertion point I should start in terms of immuno-oncology, but I'm going to jump right into cell therapy because that is our wheelhouse. If you can't hear me, I hope you can all hear me. Let me know. I'm going to pull up the first slide here. There we go. So I call this talk patient-centric tumor agnostic approach because I think what we're looking at here are targets for whatever cancer we're interested in directing our therapy to. A lot of what I've done was developed at Fred Hutchinson Cancer Research Center, and then 11 years ago, I moved to MD Anderson Cancer Center to expand this beyond melanoma. And as part of that process, identify novel TCR targets, including those for rare tumors. So the first slide is actually more of a overview, and we can talk more about this during the question and answer period. But obviously, if you're doing adoptive cell therapy, then I've been doing this for literally 25 years, I guess now. And when this all started, really, there was only TIL therapy, and that wasn't working very well. At that point either. It was obviously pioneered by Steve Rosenberg. You get tumor where they're infiltrating lymphocytes and T cells, expand those in vitro to give that back to patients. And I think there were two major issues at that time. One was persistence of these cells, and the second really was a way to expand them. And so Phil Greenberg and Stan Liddell at Fred Hutchinson, where I worked, actually developed a method to expand them called the Rapid Expansion Protocol, which Steve Rosenberg then co-opted into his regimen. And I think you're all very familiar with REP or REM as Steve calls it now, but essentially it was a way to expand cells 1,000 to more than 5,000-fold sometimes. But also the lymphodepletion, again, something you co-opted from several mouse studies, was important during that time. And so basically now TIL, as you heard, is licensed to as one form of therapy for metastatic melanoma, although it's being evaluated elsewhere. It is really the, sorry to use a meme from the Olympics, is the OG of cell-based therapies. But it does have its drawbacks, one of which obviously is the requirement for lymphodepletion and high-dose IL-2, which can be somewhat toxic. But it did pave the way for other cell-based therapies to move forward for the treatment of cancer. And we're all familiar with the engineered T-cell-based therapies like CAR T-cell, which was developed by Michel Sadelain. And I'm just going to say this because I'm really quite a supporter of Michel's work also Carl June, of course. Michelle was the first actually to show that a second generation CAR T cell with a costimulatory molecule, in this case CD28 signal molecule, led to persistence and clinical efficacy in patients with CD19 positive B cell leukemias and now lymphomas as well. Carl obviously expanded this to other cancers, popularized it, and also into the autoimmune space. But the CAR T cell or T cell engineering space is more similar to this air pistol guy with all the sophisticated engineering, dual targeting armor, T cells, switch receptors, and so on, as one approach that we've taken over the last 20 years in about a dozen first-in-human studies, has been a more plain, I guess, less sophisticated, but equally scientifically complex in a way strategy, which takes advantage of the naturally occurring T cells and all the natural cues that we think millions of years of evolution have endowed our antigen-specific T cells, which circulate in our peripheral blood, and so required enabling technologies in terms of endogenous T cell therapy in order to isolate and expand these rare antigen-specific T cells. And so I would liken that to the Hungarian or Turkish. I think he's a Turkish air pistol guy. Maybe not because we share the same dad bod, but because really this requires a more naturally evolved approach to identifying those T cells, and actually also enabled us to identify memory cells from the peripheral blood and strategies to transfer that technology to CAR T cell and TIL-based therapies. And so when you talk about naturally occurring T cells, you have an intact circuitry, intact cues, and also something you're digging deep into is the epigenetic control of memory, the prevention of exhaustion, and so on. We'll show you this one slide here we published some time ago. First off, the Osha Pui, who was a postdoc in my lab, and initially Phil had treated patients with high-risk AML following transplant with WT1 specific T cells, which had no memory properties, and you can see that these T cells came in and the frequency went down in the peripheral blood, and in all cases the leukemia came back. So I added to the study the essential memory cells from the second cohort of patients who received WT1 specific T cells, which had this memory protocol we developed, and are now used in clinical trials. You can see the T cell infusion after last infusion has prolonged in vivo persistence of a year or more, and none of these patients did the T cell. And the only difference between this first cohort of patients that Phil treated and the second cohort, which our lab treated, was the memory module. And you can see how important it is, especially for low volume disease, but also in this case where there was universally incidence of relapsing in patients with high-risk AML. And so one thing I guess we should know about T cells is how they kill, so that we can understand how to target them. And obviously, a cell needs to divide before they can kill. It's a question of numbers. These are images that were collected by Hanko Verban from Austria, who worked in our lab doing some pretty seminal studies in T cell synapse formation and the parameters involved in that. And you can see the synapse here, the SMAC T cell binds to the tumor cell and then ends up killing it. Sometimes requires multiple contact with one or more T cells, but also leads to apoptosis, blebbing, and then eventually the T cell kills it and then moves on, process known as serial killing. I think serial killing is not well known, but it's obviously important. Cells need to divide, kill, and then move on. But how they recognize the target is really the question I'd like to address here, because it's relevant to targeting rare tumors like cardiac tumors, cardiac angiosarcoma, and so on. And so what does the T cell receptor actually see? It actually doesn't see antigens or proteins on the surface like CAR T cells. The T cell receptor sees bits of protein which are processed, presented by the tumor protein as peptide fragments, usually 9 amino acids of the CD8 T cell, which is then presented on the surface by self-MHC. And that's really the recognition programming of T cells leading to killing and so on. And so just drive this message home, because I think it's very important when we're flooded with a lot of CAR T cell products that what the T cell receptor actually see is just a fragment. So that protein can come from anywhere in the cell, any cellular compartment, and then If you look at this example, for example, this is a PBK antigen. It's actually a pan-cancer antigen associated with a nuclear nuclear transcription localization. In terms of, it's a kinase responsible for cell division, and it's highly expressed in a lot of tumors, all tumors. This is not on the surface, obviously, but the protein is degraded by the proteasome, and the antigen peptide is produced. This sort of 9 or 10 amino acid bit binds to MHC, and then is dragged to the surface where the T cell receptor then sees it through its T cell receptor complex. In contrast, CAR T cell therapy recognizes surface antigen, so that's why you're looking at CD19 on the surface, BCMA on the surface, TROP2, and other targets. ETC therapy, which is what we've been doing, this peripherally derived natural occurring T cells, doesn't require tumor. Obviously, we isolate very rare tumor-specific T cells from the peripheral blood, uses the T cell receptor recognizes target. And I think that's important to understand because CAR T cells use a chimeric antibody, this leads to very, very slow dissociation rate, constitutive signaling, and some of the efficacy, obviously, but also some of the serious toxicities when it doesn't disengage like a normal T cell receptor would. And so when you look at the consequences of that, really is that you can get a lot of off-target and on-target toxicities, some of these life-threatening neurotoxicities, for example. And in some cases, you get in vivo persistence, but this is often limited. And still, the relapse rate from CD19 CAR T cell therapy, single valent targeting, is upwards of 40%, even to achieve complete response. And part of this is not only because you're targeting a protein that can be lost without consequence to the tumor survival, but also because you acquire high dose lymphodepletion. And so there's no chance for anti. You remove all the endogenous T cells that are present that can give rise to non-targeted tumor antigen-specific T cell, and also very difficult to add combination-based approaches because of the toxicities. You sort of have to wait till the toxicities abate before you can do that. Whereas with ETC therapy or TCR-T-based therapies that use a memory module and take advantage of the natural intrinsic regulation for memory and external cues associated with memory, there are limited toxicities in outpatient-based therapies. Now we're talking about ETC, not TCR-T here. It has proven clinical durability, and because you don't need them for depleted antigen spreading, and you can add combination the next day. In fact, one of our studies published in JCO gave ipilimumab the day after we gave the T cells, and that led to actually increased antigen spreading potential for long-term persistence. Several of those patients had a major clinical response. The difference, of course, with TCR, the disadvantage is it has to be HLA restricted, where for CAR T cells it does not. So in terms of, the bulk of antigens that can be identified, most of them are TCR antigens, meaning they're recognized by the T cell receptor, the bits of protein brought to the surface. And one of the most popular ones that people hear about are the neoantigens, neoepitopes. And this is sort of a timeline of immunogenic T cell epitope discovery. Last 10, 15 years, this has been very popular for both vaccine and T cell based therapies, especially in tumors where there is. But it doesn't treat a lot of patients. So the y-axis is patient and or tumor prevalence. And you've got some sort of, you can call them neoantigens as well, because they're very, very tumor specific, the virus associated antigens. We've actually treated patients with Merkel cell cancer by targeting the T antigen. And then you've got some shared neoantigens, KRAS, TP53, and some epitopes are still being discovered here. However, we want to look at the core of the apple, which is, as I described to you, epitopes that come from proteins present in any cellular compartment. And if you're doing that, you really should not be limiting yourself to this relatively small, personalized, and private group of antigen targets. You should be thinking about what is truly. Go back about 30 years, a long time. And the problem with the field is a lot of trainees and new students in this area do not understand or appreciate that immunotherapeutic targets were identified back in 1991 by Thierry Boone and this group in Brussels. And these were true tumor rejection antigens. This is actually the bulk of immunogenic targets. It's not the neoantigens. You really have to take a look at MAGE-1, melanate, tyrosinase, others identified by Steve Rosenberg. I don't know why he renamed this MARP1, but that's what we know it as now. We discovered that, as well as some other epitopes. And they're still obviously in use today, and unfortunately, and also PRAME and MAGE-A4 CT antigens, which are important for a lot of cancers. But the problem really is that here we have tens of thousands of potential antigen targets, but we're only focused on maybe 3 or 4 of them. What happened to all these other potential targets that make up the core of the apple that T-cells can see through the receptor? And so the problem is that the easy way of doing this, which is in silico analysis for predicting neoepitopes or shared tumor-associated antigenic epitopes, is trying to remember what immunogenicity is about. So there's one message I want to drive home to everyone here is that immunogenicity is key. And what I mean by that is if you're trying to use a TCR target or epitope for vaccine studies or T-cell based therapies or bispecifics using TCR, you have to ask the first question, is that peptide actually processed and presented? Because the in silico prediction won't give you that information. There's a lot of empiricism, there's a lot of vicissitudes in terms of what the proteasome sees and degrades. But not only that, is that epitope sufficient to elicit a T-cell response? And you can't predict that. That has to be done empirically. And then does the T-cell exhibit sufficient affinity to recognize the tumor cells? And is that epitope presenting sufficient density? And can you transfer the T-cell receptor? And if you do this with a conventional approach using silico prediction for neoantigen discovery, you can prove none of this. Basically, by luck or by chance, you actually happen to have an epitope that is actually processed and presented, but the over 90% of them, as I'll show you in a minute, are not processed and presented. And I'll just give you a bit timeline here. Back in 2008, Bervogesine and Jim Allison sort of looked at all the mutations and said, hey, you know, if we just feed this in a computer and look at MHC binding affinities and consensus sequences, we can predict a lot of epitopes. Well, that's true or not true. I think it did lead to a flood of neoantigen-specific vaccine studies. Literally tens of billions of dollars and tens of thousands of patients were invested in this sort of neoantigen approach to cancer vaccine. Now, some of them are very effective, as Vinod Balachandran has shown in some of the pancreatic tumor vaccine studies that he's done. But by and large, because these were prediction methods, it's unclear whether the epitopes that were used to develop these vaccines were in fact immunogenic. And the published PNAS, where the same method was used for SARS-CoV-2 vaccines, and the epitope turns out the immunodominant epitopes do not exist in nature. So, this is a much more complicated system. And in fact, in 2014, the people who were skilled in mass spec to identify these peptides on the surface of tumor cells, like Hans-Jörg Raumann-C and the people in Tübingen and some folks now at Genentech, like Leo Demare, they went and actually did the study. They looked in the mouse MC38, which is a number of mutations. They looked at 1,300 predicted epitopes, but only 7 of them were actually processed and presented on mass spec. And only one of those, and only one of those 7 was found to be immunogenic. So very, very low frequency of those predicted epitopes were in fact immunogenic in this mouse model. And then in 2020, the Parkman Institute sponsored a study in which it invited 25 teams, both from industry and from academia, to make these same predictions as people have been doing and treating patients. And 25 teams were given the same exome sequencing data, and they came back with hugely different predictions. Some predicted as few as 7 neoantigens, and some as many as 82,000. So obviously no consensus, but they still did their best, and they narrowed it down to 600 of the top neoepitopes from this very large expanse of predictions. So that represents only 0.7% of all of them. 51 of these, they were further refined and selected and filtered for immunogenicity according to the loosest criteria, and only 3 of these were found to be immunogenic. So 6% of the 51, which is some fraction of the total, which is some fraction of a larger number for which nobody had a consensus to. So if you look at this, you kind of like, hey, I think I know how to predict neoepitopes. You may question the validity of some of that work without doing the empiric studies that need to be performed, as I described to you previously. So how do we deal with that? And so what we said, well, okay, let's do the hard work. We've got equipment here for the mass spec. We've got skilled people, data scientists, Yulin Chu and Kirpan, and let's just go where the money is and elute the peptide off the MHC of various tumors. You can see we have 11 million spectra. We now have 20 million spectra, thousands of targets, and narrowed that down to 250 epitopes, which are novel and not previously been seen. But that's not the only thing. Beyond that, you have to synthesize the peptide, make the T cells using the ETC protocol I described to you previously. from the peripheral blood, we can generate these very rare and specific T cells, improving the fact that they recognize tumor, that's sufficient affinity to elicit that response to kill the tumor, and then finally transfer that T cell receptor to lymphocytes and transfer the specificity, which we proved in about 24 novel epitopes now for common and rare tumors. So what is the thing that we found? What we found was that what we know already, these tissue-specific and cancer testes, and really, if you look across the tumor database in terms of transfer per megabase, in terms of expression across various tumors, I'm sorry, I made it smaller so you can just get an idea in this heat map that there's expression of CT antigens like MAGE-A4 and NY-ESO and MART1, but they're relatively low, but still immunogenic in the cancer testes and obviously expressed in normal testes. That's what's known now. It really serves only 3% of the population, whereas our new tumor antigen repository, immunopeptidome here, has new epitopes for cancer testis antigens, tissue-specific antigens, proliferation antigens, resistance genes, all give rise to epitopes across multiple alleles, serving up to potentially 80% of all cancer patients, very high levels of antigen expression and across multiple alleles. So if you do this in a more robust and comprehensive fashion, now you have surprisingly even targets for cell cycle proteins, which you don't expect to be immunogenic, but which are constitutively expressed at very high levels. You can see here on this heat map in across multiple tumors, and also some which are tissue specific. You can call prostate a dispensable organ, highly expressed in prostate as well as the cancer as well as normal tissue, but also resistance genes. So DNA repair genes, multi-drug resistance genes. So these are non-mutated tumor-associated and tumor-selective targets which deal directly with tumor genesis, less likely to undergo antigen loss, and actually maybe in fact upregulated following chemo, immune, or targeted resistance. And so I don't expect you to read this poster, but this poster was presented by Kerr and Yulin at the big meeting of the Human Immunopeptidome. And across all these lines and all the novel spectra, the numbers here I'm trying to tell you is that there are 200,000 potential targets, and they cover a huge range. And well, that's great. Well, let's talk about some of these targets briefly. This is a pan-cancer antigen across multiple alleles, which kills pancreatic cancer. We isolate glioblastoma as well. When we make the TCR-Ts, they also kill very well as anaplastic thyroid cancer. This is prostate cancer, as I mentioned before, highly specific prostate or prostate tissue, some are shared antigens across multiple tumors. Leukemias, lymphomas, one of these is a gametocyte-specific transcription factors, so highly tumor selective, very high levels, also found high levels in the testis, found in T-cell lymphoma, B-cell lymphoma, liver cancer. And then in the last minute or two here, what about cardiac angiosarcoma? And so it turns out that as long as the antigen is shared and you have a matching HLA for your tumor of interest, your favorite tumor, the epitope also turns out to be shared. Remember, this is not a neoepitope, not a private neo. This is a shared tumor-associated antigen. But the amazing thing really is that that epitope is also shared. So if you screen in your RNA-seq or proteomic library, whatever, of your tumor of interest against our immunopeptidome or a large immunopeptidome library, and you have the same antigen and matching HLA, if you run through that protocol, it turns out we have epitopes for a number of rare tumors, including glioblastoma, angiosarcoma, chordoma, anaplastic thyroid cancer. And we may even already have the T cells or TCR-Ts that recognize those because we generated those for other reasons against more common tumors. Let me just drill down a little bit for our angiosarcoma, random aspect actually on this and the RNA-seq library. And it turns out some of these are pretty high value targets, very high levels of transcript expression over normal over normal tissues and very high confidence epitopes for A11 and A24. ASPM is associated with proliferation. Obviously, these are transformed B cell lines, so high levels of expression in those normal tissues, but very low levels in other normal tissues, but high levels not only in angiosarcoma, the lines that we were able to evaluate, but also it's a pan-cancer antigen. And you can see here anything above 4 is immunogenic, and this is the percentage, for example, of patients who have, let's say, sarcoma. Maybe almost 70% of them express transcript levels above 4, but above 10, it's maybe 30% or so. So actually anything above 4. So this antigen sort of, when you look at it, it's sort of a gateway to other cancers. In fact, if you look at the spectrum of T-cell discovery, really overshadows a lot of neoantigen targets, and really because people haven't completely explored or validated these targets that we identified by mass spec. And there are a few interesting things like the dark matter and transposons, which we and others are beginning to identify as potential immuno targets. And so conclusions are discuss a little bit really of the different cell-based modalities, that in vivo persistence correlates with clinical response, that immunogenicity is key, and T-cell-based therapies target a large portfolio of tumorigenic proteins. Validation is key. Shared tumor antigens equal shared immunogen epitopes, and that's T-cell-based therapy of rare cancers can lead to gateway in common cancer. Sorry, I'm borrowing a room. Actually, that is my last slide, that T-cell-based therapy can lead to, and then so that's why we have an interest in cardiac tumors and working with Dr. Rob Bernard has sort of allowed us to identify and also validate some of these targets. I'm going to, I might have to go dark, but I can keep my audio on and answer questions because I am borrowing somebody else's room here. And I'm going to stop right there. Thanks so much, everyone. Yeah.
Thanks, Keshan. Appreciate your time and accommodating us in spite of the tight schedule. The only question that I would have for you is for our cardiac group, how do we get more organized in terms of samples, in terms of trying to make sure, is this a NF1 sort of an approach for every patient that you would recommend, or should we be collecting a large volume of samples, understanding there's a whole bunch of heterogeneity even in these rare tumors?
Yeah, so I would just say yes to everything you've said there. The heterogeneity is an issue, but when you have sort of pan-cancer antigens like ASPM and some of these other DNA repair genes, they are broadly expressed even intratumorally. Now, the best way to do that is to do something like RNA scope, right, to see exactly what expresses what. Obviously, and if we had IHC stain for the tumor for that particular antigen, we can evaluate the heterogeneity of that. So I totally agree with you on that aspect. Some of these so-called pan-cancer antigens are seen as considerably overexpressed because they're cell cycle proteins or what have you. But I think there's a really wide therapeutic window between that and sort of transient expressed cell cycling cells that you might find in bone marrow, for example. But I think that you're right. I mean, the more material, more information we get, the better we can define multivalency, because obviously you can do this with more than one TCR target and so on. The one thing I will invoke, which people may agree or disagree, is that what we've seen with melanoma is actually evidence of antigen spreading. And so if you lower the threshold of activation, your T cells can get in there, you kill the tumor, even though, for example, in one of our New England Journal papers, when we killed the tumor, and what you saw was heterogeneously expressed, we had a complete response because we found also that some of the endogenous T cells could be activated against non-targeted tumor-associated antigens, and you saw antigen spreading in that case. And even though it was a small number of patients, our JCO paper showed that the antigen spreading correlated with the response. And so I think that's a very important idea. And there are different levels of antigen spreading. There's epitope spreading, same antigen, multiple epitopes, so different alleles. Antigen spreading across different antigens, clearly different proteins. You can even talk about effector spreading. How do you get other effectors to play, CD4 cells, bring in the AKIN cells, even macrophages, and so on. So all those things need to come into play. And the one event is you need to start somewhere, to catalyze this response. And the ETC therapy, or trying to remove some of the toxicities, this is the combinations you can add immediately to it or right away. And I know that's where the field is going with a lot of the cell therapy companies, but really to be sure that toxicity is minimized and you don't need lymphodepletion if it's not necessary, for example, and other aspects of it. Long answer, short question. Yeah.
Appreciate your time. Any other questions? If not, I'll let Dr. Yi go. He has another talk coming up in 3-4 minutes. So thank you very much, Dr. Yi. I appreciate you.
Thanks so much. Thanks for the invitation. Sorry I went through that quickly, but I'll share the slides. Okay, take care, you guys. Thank you.
Take care. Bye.
Have a great conference. Bye-bye.
So I do apologize. It was tight scheduling, so we still wanted to make sure that we got the speaker in. So if there are additional questions, please feel free to send them via email to me, and I'll make sure that it is routed to Dr. Yi, and we'll get you the responses that you need. We'll keep moving forwards with the agenda. Our next speaker is Dr. William Decker. He's going to be talking about a cell-based therapeutic vaccination as an adjuvant approach in cardiac sarcomas. Dr. Decker and I, we've been working together for a long time. Dr. Decker has a history of developing dendritic cells to be responsive to both normal and tumor tissue using a very unique double priming method that has always amazed the data that whenever I look at it. And we've been trying hard to work together to establish approaches in angiosarcoma to take this approach to see its utility. So in cardiac tumors, which is very site restricted within the chest, if there are certain learnings from what we have investigated so far to carry on forwards, that would be really interesting for this particular group. We realize that there isn't any cardiac sarcoma specific data, but looking forward to hearing what Dr. Decker has to say.
Great, thank you. Thank you so much for that introduction, Vinod. So should I go ahead and share my slides?
Yes.
Okay. Right. All right, I hope that is effective. So this is really this is somewhat of an honor for me to have been asked to speak at a conference about which I know nothing at all of the subject material. It's been a really interesting morning for me listening to the cardiologist speak and listening to the sarcoma oncologist speak, because again, this is not my area at all, and it's all very new to me. It's all very interesting. So I'm about to, I think, also present something new to you guys, and I hope it's not too difficult to follow. So we're gonna talk mostly about things that so far have nothing to do with cardiology and have nothing to do with sarcoma, but we do have a slide at the end of the talk that is aspirational, but will point out or describe how we'd like to adapt the work that's been done so far in dendritic cell vaccination to a meaningful approach for cardiac sarcoma. So this is my disclosure. I'm terribly conflicted. So we're going to discuss a little bit of hardcore immunology, and I hope it's not too hard to follow, but the immune response, the adaptive immune response, which is what is largely or completely, we think, responsible for the amazing results that cancer immunotherapy has produced over the last 15 years and all of the new checkpoint inhibitor drugs that we're all using in our practice, is driven largely by the Th1 response. So broadly, adaptive immunity can be subdivided into two general categories, Th1 and Th2, and we'll ignore Th17 for now. It's not part of the paradigm. And this goes back to a critical decision that the immune system has to make at the beginning of every adaptive immune response, whether it's responding to an intracellular pathogen or an extracellular pathogen. So the goal of cancer immunotherapy, the goal of creating new responses, not necessarily the goal of using checkpoint inhibitors to reactivate existing T cells, but the goal of generating de novo curative responses, or at least reactive responses in cancer, is to stimulate the Th1 side of the immune response, i.e. the cellular arm of adaptive immunity that's generally tasked with generating an antiviral immune response. This is what we're trying to mimic or hijack in cell-based vaccination. Why do we want to be doing this? So this is an old slide, but it really illustrates the point well, and you can draw one of these Kaplan-Meier's for just about any indication. Generally, when patients on their own experience a Th1 response in conjunction with their conventional therapy, survival is very good, as you can. So this is colon cancer. But you can also see that the numbers tend to be very low. Patients tend to generally not spontaneously at very high levels or in very high numbers generate this Th1 high immune response in conjunction with their standard of care. They generally produce a Th1 low response, which has much lower rates of survival. So the goal of what we're trying to do, and what a lot of others in vaccine technology are trying to do, is to stimulate this Th1 high response with much greater frequency than ordinarily occurs. So Th1, Th2 polarization, whether or not you're going after something intracellular or extracellular, is canonically informed by pattern recognition receptors. So these recognize specific molecular structures associated with bacteria and viruses, and they not only recognize those structures, but the placement of these pattern recognition receptors is also very useful for informing the adaptive immune response, with the intracellular pattern recognition receptors that generally recognize viral replication intermediates located intracellularly. As you would expect, the viruses are replicating intracellularly. So replication intermediates, which are generally nucleic acids that are stimulating toll-like receptors or other pattern recognition receptors that indicate the presence of an intracellular infection that would require Th1 immunity for clearance, are also located inside intracellular compartments and are not located on the surface. So that's also important. And this is this general paradigm of how the immune system decides if something is intracellular and extracellular. Definitely holds true under all circumstances that we're aware of. So the information I'm going to present to you today doesn't counteract or contradict any of this. It simply augments it and adds a little bit to it. So without getting too far afield and presenting a lot of information that might be difficult to understand. So our work over the last 20 years has characterized an additional intracellular mechanism that determines whether or not a viral infection is present. So this operates in the context of pattern recognition receptors. Pattern recognition receptors do have to be triggered to initiate an inflammatory response, at which time the immune system looks for additional information. Particularly the cells tasked with determining whether or not there has been an intracellular or extracellular infection, and whether you need an intracellular response or an extracellular adaptive response for clearance. This is the dendritic cells. So dendritic cells actually possess a number of other mechanisms that provide more information as to whether or not the antigens against which the immune system is going to be primed represent something that's truly of viral origin, or perhaps less probabilistically of viral origin. And so this is again, it's a little difficult to explain, so I'm just going to say it. The immune system actually can compare the amino acid sequences of MHC class 1 and MHC class 2 peptides that have been loaded onto the antigen presenting cell. So to briefly explain that, all cells are constantly sampling and surveilling their own internal contents by chopping up internal proteins and presenting little peptide bits on a presentation complex termed MHC class 1. So the peptides that end up on MHC class 1 are a good representation of what is inside a cell at any given moment. In contrast, professional antigen presenting cells like dendritic cells also express a different presentation complex called MHC class 2. And professional antigen presenting cells are constantly chopping up and presenting extracellular antigens on MHC class 2. So as it turns out, when antigens presented on class 1 and class 2 are identical, when they look exactly the same, that generally physiologically is only happening in the context of a viral infection. So without going too much more into the concept, this is another mechanism by which the immune system probabilistically determines that it's looking at something foreign versus self. So again, by surveilling and identifying an antigenic situation that statistically and probabilistically really only happens when you have a very fulminant viral infection and you've got lots of viral particles on the outside of antigen-presenting cells. And if those cells are indeed infected, and it's the antigen-presenting cell's job to try to get itself infected as much as possible, you also have those same viral particles being produced inside the antigen-presenting cell. So again, this is an area, this is a mechanism that probabilistically adds more information to the adaptive immune response. Oh, sorry about that. So we've shown this in a number of different ways with very specific class 1 and class 2 peptide antigens that differ only by a few amino acids. So you know we can do this clinically using things other than peptide epitopes. But to show this conceptually, we have these series of peptide epitopes in which the class 1 and the class 2 antigen differ only by one amino acid change. And so we can have a class 1 and a class 2 that are mismatched by this single amino acid change, and we can have class 1 and class 2 epitopes that are perfectly matched. And we can take the mutated class 2 with the non-mutated class 1. We can also take the reciprocal mutated class 1 with the mutated class 2, and we can recapitulate these responses. So I'm not showing that here. I'm simply showing what happens when we load dendritic cells with a peptide epitopes that differ by a couple of amino acids versus peptide epitopes that are identical at both class 1 and class 2. And what you can see starts to happen under these circumstances when you're using these very defined peptide epitopes is we start to get differentiation of those dendritic cells into what we call a CDC1-like phenotype. So again, you can add disparate peptide epitopes and the steady state is maintained, or you can add matched peptide epitopes and we actually get differentiation into what are called CDC1s. And these are dendritic cells that are specifically tasked with specialized function of priming very high quality CD8 T cells. So this simply shows that in vitro, what happens during the differentiation process when we load matched class 1 and class 2 antigens. We can also do this in vivo. We can shoot up a mouse with either matched peptide epitopes or unmatched peptide epitopes. And in this experiment, just to explain it, and you can see the peptides we used at the bottom, we took a well-characterized class 1 epitope by itself. We took a well-characterized class 2 epitope by itself. We took well-characterized class 1 and class 2 epitopes from the same protein that did not overlap an amino acid sequence. And then we took, again, well-characterized peptide epitopes, class 1 and class 2, that did overlap identically in amino acid sequence. And what you can see is when we load a mouse with just these various combinations of single or double peptide epitopes in conjunction with an inflammatory signal, the only signal that generates high-level tetramer-positive CD8 T cells is the class 1 and class 2 epitope that have substantial overlapping sequence. And this is all we loaded into the mouse in this case, either the peptides, only the peptides and the inflammatory signal, producing this very distinctive result. So this is showing both in vitro and in vivo what is induced by the addition of matched peptide epitopes on class 1 and class 2. So this underpins our basic vaccination strategy. So to get really deep into the weeds, there is a sensor complex inside the dendritic cell called the multi-amino acyl tRNA synthetase complex that is responsible for comparing class 1 and class 2 antigens. And that's really all I want to say about that, because it has a very, very complicated and sophisticated biochemistry that has still not yet been completely or even marginally elucidated, you can imagine. This is the sensor complex responsible for the phenomenon I just described. One thing we have been able to do, even though the biochemistry of the sensor complex is still a work in progress, is we've been able to characterize the signaling changes inside dendritic cells that result from adding matched peptide epitopes versus mismatched peptide epitopes. And so we know at the signaling level exactly what's happening. We both get activation. So when we add matched peptide epitopes to a dendritic cell, we get activation of p38 MAP kinase, and we get inactivation of mTOR. Both of these substantially influence the composition of AP1 and cause a different type of heterodimer in response. And this impacts substantially gene transcription that will lead to the CDC1 phenotype. So even though the biochemistry of the complex, like I said, is still a work in progress, the signaling is very well understood. So here I'm going to pivot to, unfortunately, not cardiac disease or a sarcoma, but to what my group has been doing with this vaccine approach that we've undertaken, is to talk a little bit about glioblastoma and present you some data from our phase 1 trial in which we used this general approach that I've just described. And I don't think I have to tell you that glioblastoma is a critical problem. Everyone buys that. This is how our trial worked clinically. Patients are diagnosed and enrolled in GBM's an oncologic emergency, and these patients are usually on the operating room 48 or 72 hours later, at which time the tumor is resected. And the surgeon is kind enough to chop off a little piece for us, which gets sent to us under GMP conditions. And sorry about that. Chopped up into two different fractions. So we'll take the bulk of the tumor cells and freeze thaw them just to make a generic tumor lysate. We'll take a small part of the tumor cells to amplify the tumor transcriptome. So we can amplify the tumor mRNA basically to any level that we'd like. And so we get these two fractions that faithfully recapitulate the antigenic environment of the tumor. We get a protein lysate, and we get an amplified tumor transcriptome. And we use these then to load patient dendritic cells. So patients after resection proceed to GCSF mobilization and steady state apheresis. We get that apheresis product at the GMP lab, and we generate immature dendritic cells and marry those together with these two antigenic subfractions. The lysate is thrown on the outside of the dendritic cell where it's taken up and presented by class 2. The RNA is electroporated inside the dendritic cell. So the proteins are made inside the dendritic cell. Those are chopped up by the proteasome and presented on class 1. So in doing this, there is an opportunity for epitopes that bind class 1 and class 2 to be matched and to induce the signaling changes that I showed you in the previous slide. And while all that might sound a little bit improbable, I'm going to show you some data that suggests that is actually, in fact, what happens when we load dendritic cells with mRNA and lysate derived from the same autologous source. So regardless of whether you buy into the basic biology of the approach, these dendritic cells are then cryopreserved and shipped back to the clinical site for administration into the patient perinodally. So we're targeting the brain by getting the dendritic cells very close to the deep cervicals that target T cell responses to the brain. And we're adjuvanting the patient with some type 1 interferon, which again provides some critical antiviral signals to the patient. So the exclusion criteria of our trial were very inclusive, which I think is important. We had no upper age limit. Subtotal resection was not exclusionary. We're not looking for the perfect patient. And evidence of progression in the time prior to vaccination was also not exclusionary. So we took all comers, and once they were enrolled, we did everything we could to get the vaccine to them. So what I'm going to show you here is simply a summary of the immune system changes we observed following vaccination. These are the peripheral blood changes. It's somewhat difficult to sample changes at the level of the tumor in the brain. Because generally you don't do fine needle biopsies of the brain. So we did see a number of very substantial and significantly, statistically significant changes in the peripheral blood. We saw post-vaccination big increase in CD4, CD161 cells. We actually saw an upregulation of regulatory T cells, which I can tell you in the context of vaccination is actually a good thing, not a bad thing. It's indicative of a response. And we did not see in the patients whose brains we did sample, we did not see these regulatory T cells in situ at the tumor. We simply saw them in the peripheral blood, which the literature does suggest is indicative of a good response to a therapeutic vaccine. We saw a big upregulation generally of CD4 central memory T cells, as well as CD8 central memory T cells. That's generally considered good. We saw an upregulation of these MPEG cells, these CD8 memory precursor effector cells. And we did see a dose-dependent upregulation of interferon gamma expression in the naive T cell subset. So these were all very significant and interesting things that we saw peripherally. Really cool. We sequenced the vaccine cell product of all the patients, and we were looking for changes. We were looking for transcriptome changes in comparison to a matched patient sample that was treated exactly the same, but not doubly loaded. It was this matched patient sample that we made for every single patient in the trial. Was electroporated with the amplified RNA. We simply didn't throw the tumor lysate on top of it. And so we're looking for statistically significant gene changes between the vaccine cells and this mRNA only loaded only control. And to increase the statistical power of what we were doing, we were comparing these genes that we're trying to pull out of our sequencing among 18 products with high levels of variability to some work that was done almost 20 years ago in which we did do a very thorough and robust characterization of genes that change when in fact you do get a double loading event and the signaling that I discussed earlier. So we were able to pull out statistically 31 genes that were statistically different between vaccine product and mRNA only loaded product. And we were excited that statistically we were able to see anything at all. And again, we were able to use the data we generated almost 20 years ago to enhance our statistical power. And so just seeing a signature that appeared to be associated with loading matched antigens was nice. But then what we went on to do was show that the quality of the vaccine signature, i.e. the number of genes that were actually changing in a congruent direction, was associated with clinical immunologic response. So that was pretty cool. So what we showed, in fact, was there was a very high degree of correlation between gene changes in the vaccine product and the development of this regulatory T cell response and the development of the MPEG cell population. So this is both very statistically significant, and these were independent statistical events. We pulled out the vaccine signature, and then we independently went and correlated it with the immune system changes post-vaccination. As I mentioned, we did also see that dose was important in generating higher levels of interferon gamma positive reactive CD8 T cells. And then we were even able to correlate one immune system change with patient survival. So we're just looking at activated CD8 T cells, you can see that the fold change in activated CD8 T cells was statistically significantly correlated with patient outcomes, with patient survival. So again, a lot of different ways in which we show that the vaccine is really doing something, and presumably by the mechanism that we think it's doing something. I don't actually think this is important, but I've come to understand a lot of other people do. Apparently, it's disbelieved that T cells get into the brain. I believe it, but apparently others don't. So it's supposedly a significant thing to show you guys by IHC that T cells are getting into the brain. So this is derived from primary and secondary resection. A lot of patients did get a second resection, probably too many patients, as I'll show you in a future slide. And at the time of second resection, we were able to do a little immunohistochemistry and show in the majority of the patients we looked at second resection, much higher number of CD8 T cells in the brain. So they do cross the blood-brain barrier, which, to be honest, isn't really a barrier to T cells. It's really more of a barrier to small molecules. So I do possess the belief that T cells routinely get into the brain, and here we're showing it through IHC. We also were able to do some spatial transcriptomics, and this was really pretty cool. I'm showing you 2 of the 3 patients here where we were able to do transcriptomics. And the really interesting thing we saw when doing transcriptomics was these very prominent foci of CD25 expression in the post-vaccination population. And that's important because CD25 is a lymphocyte activation marker. Now, not shown here is that these activation foci actively excluded CD4, so these guys were not CD4 positive at all. They were CD8 positive. They were also CD127 positive. They were also CD161 positive. So we think that these guys are the MPEG cells that I was talking about earlier, which therefore actually are making it into the brain. And you can see that for both these patients, you can see these prominent CD25 foci that also co-express CD8, CD127. Even more interesting and also much more visually appealing and believable, we saw local antigen presenting cells complexed with those activated CD8 T cells. So these guys were post-vaccination. So these were C1QA positive, CD68 positive, and OLF ML3 positive. As you can see that these very intense foci of those markers also correspond to where we're seeing CD25 expression. And so as it turns out, these are markers of migratory hematopoietic-derived microglia. So the resident yolk sac-derived microglia not present in these clusters because we didn't see those markers, but we did see, as again shown here, the markers of the migratory hematopoietic microglia. So what we're hypothesizing is that we're getting local antigen presentation and immune activation in many months after vaccination. So we are seeing significant evidence here of an ongoing immune response in these patients. So looking at the radiologic outcomes, obviously I'm showing you the good ones. So we did have a substantial number of patients that experienced what looked like progression. And it was sometimes, difficult to tell the docs, just sit tight and watch the progression. We think it's going to go away. And sometimes they would do that, if they were paying attention to patient symptomology. If the patients weren't very symptomatic, they were okay. They were content to watch and wait. If the patients were, of course, symptomatic, you do want to go back in and reoperate. So what we saw in a substantial number of patients was what looked like progression that then of its own accord disappeared over time and left these patients who are at this point pretty far out looking radiologically intact, as if the disease burden is relatively minimal or even absent in quite a few of our patients. So these are looking at a few of the good radiologic outcomes in a methylated patient, an unmethylated patient, and also a relapsed patient who also showed some pseudoprogression and disappearance of signal over time. So here are our survival outcomes. Again, it's a very small sample size. It is statistically significant if you look at it in the right way. So, there's always a little bit of hand waving when you want to try to make these claims in a phase 1 study. But what we did see was a very big stratification between patients who received reoperation and patients who didn't receive reoperation. So essentially, watch and wait worked well in these patients. And if you look at just the GBM specific survival, most of the patients who got watch and wait are alive. And if you got hurry up and reoperate, those patients didn't do as well, or they didn't do well at all. They did about as well. You can see here we have a historic control. They did about as well as historic control. And you can compare both GBM specific survival over here to total survival over here. Regardless, at the time that this curve was made, 2/3 of the patients who had not been reoperated on were alive, and none of the patients who'd received reoperation were alive. So this was, again, very statistically significant. And I can tell you today, which is just about 4 months later, these curves were made 4 months ago, that almost all the patients who were alive then are still alive now, and disease for one additional patient's died and are doing very well. So we got more of these really good outcomes than we would have expected in a trial of this small size. So just to conclude, and I hope, do I still have a few minutes, Dr. Ravi? Great. So this is how we are thinking about adapting this to cardiac sarcoma. So basically, in conjunction with autotransplant, we would get our tumor sample, right? So you guys would do your magic. You have a far harder job than we do. Somehow taking the heart out and taking the tumor out and reconstructing it and putting it back in, and everything still works. So we get our tumor sample from autotransplantation, and then we do the same thing to it that we do to our GBM sample. Freeze, thaw, irradiate to get our lysate, amplify our mRNA. These patients, once they're well enough, then can be apheresed, and we can get the apheresis product, marry the apheresis product dendritic cells that we produce with our antigenic fractions, and again, get a vaccine product that we can give. We won't give it in the area of the deep cervicals, but we'll give it pericardially, so that we're hitting the cardiac lymph nodes in a non-destructive way, to see if then we can implement or affect any immunologic changes or any impact in patient outcomes. So this would be the general paradigm of what we'd like to do in cardiac sarcoma. So just to highlight the conclusions, I've shown you a little bit of data today that suggests that dendritic cells can compare the sequence homology of the class 1 and class 2 antigenic epitopes with which they've been loaded. And when those class 1 and 2 epitopes overlap in sequence, dendritic cells adopt a CDC1-like phenotype, both at the surface level with surface markers and also transcriptionally. The regulation of this process is governed through a very large protein sensor called the Mars complex. I didn't talk about it at all, but the signaling intermediate is this AMP1 molecule that is released from the Mars complex when antigenic epitopes match, and AMP1 goes on to interact with multiple signaling pathways that we did talk about. So this complex mechanism may be exploited for therapeutic use in malignancy. I've shown you some data from our phase 1 GBM trial. This trial is entering phase 2. It's supposed to open in March at 20 sites around the country. I'll believe it when I see it if it opens in March, but it should definitely open in 2024. I am confident that it will open in 2024. And it's a 135 patient randomized trial, randomized 2-to-1, with concurrent site-based controls also added to augment the control group. So that should generate, we hope, a more definitive, more conclusive response as to whether or not we're doing something productive when we vaccinate these patients. So there are, obviously, so I've summarized here 20 years of work in 20 minutes, 1 year a minute. There are a lot of people to thank who've been involved, including Dr. Ravi, who, again, that's been my very long-term collaborator. And with that, I am very happy to take any questions.
Thanks, Will. That was really exciting stuff. A couple of things that I wanted to kind of note was, brain is an area where we don't know how effectively the immune system gets in. Sort of a bias has been there, and you showing activity in such a site is truly remarkable. It's also relevant for us because about a quarter to a half of our patients do develop brain metastases. We just discussed a case where a patient passed away from brain metastases, and a site where we are hoping we can have better penetration and utilization. In this particular study, did you happen to use any checkpoint inhibitors alongside this, or?
We did not. So for a couple of reasons. So one, this is a phase 1 study. So we're looking at safety of the element itself, right? The intervention itself. Two, if you read the brain cancer literature, it's very unambiguous. Checkpoint inhibitors do not work in brain cancer. Now that's primary brain cancer. So metastases from other cancers, completely different story. We are interested, this isn't going to get done in the current iteration of the phase 2. We're definitely interested in having a checkpoint inhibitor arm, and whether these can be infused or have to be administered intrathecally. We don't know yet. We're still waiting for the data from the intrathecal brain cancer trials, although I haven't heard anything earth-shattering about those to suggest that they're producing a better result than simple administration systemically of checkpoint inhibitors in brain cancer produced. So no, but it's definitely an avenue that we'd like to explore if time and funding permit.
Will, if you could bring up that slide for the cardiac sarcoma one. I have
Sure.
a question.
Before I do that, there's a question in the chat. Would it be okay if I answered that?
Yeah, no, it was specifically for that. So the
okay, sure.
Actually,
no problem.
You had a nice graphic for the nodes that near which you deposit the.
I did. And hold on a sec here. I having trouble finding my
And that's okay if you can't. I mean, you can answer it without it, but I thought.
No, you're absolutely right. That would be great. So let me just having some technical difficulties. Let me try this again. Share. There we go. Okay. Okay, so it's a very good question in the chat. And to summarize the question, it's why do we have to specifically target various lymph nodes? Doesn't, vaccination in general just allow T cells to surveil everywhere? And the answer, surprisingly, is no. And this has actually been understood by the T cell homing people since the 1990s, but science being very siloed, that information took some time to leak out to everyone else. I first became aware that T cells home specifically back to the sites in which they were primed when I was at the MD Anderson Cancer Center maybe 15 years ago. That information started to get around. So as it turns out, when T cells are primed in a lymph node, they are programmed with what are called surface addressing molecules. So these are various ICAMs and chemokine receptors that allow the cells to home back to areas where they were primed. Specifically, some very specific areas are gut and brain and skin. But since the concept seems very sound for those particular organs, I make the assumption that it's true for the rest of the immune system, even if people haven't specifically shown it. But it's definitely true for mucosal surfaces in the gut and for the brain and for the skin. So these chemokine these chemokine receptors and integrins actually allow cells to home to those sites and then extravasate based on receptors that are differentially expressed on the vascular endothelium of those sites. And homing to the brain is actually very, very specific. So the integrins that allow cells to home back to the brain are very well characterized, as are the receptors in the cerebral vascular endothelium that allow extravasation. And one interesting aspect of the brain receptors and the vascular endothelium is that they are not constitutive as they are everywhere else in the body, but they're inducible, and they're inducible with interferon, which is one of the reasons why it's very important to give interferons to these patients. So while, it is possible, just, you vaccinate someone and you start looking and you can find a reactive T cell here and a reactive T cell there. You can, you look and you find, but physiologically, to get the bulk of the response to go where you'd like it to go, it makes sense to actually do this lymph node targeting, which takes advantage of the physiologic mechanisms of T cell homing. So that's why we do that. And this is why in my schema, I anticipate delivery to the cardiac lymph nodes. It might be something we could model in mice, or we might just do it as we did it in the brain.
So RJ, I hope that sort of answers the question. The key concept, this graphic is particularly important that Bill had on the previous slide. Our approach of really biopsying the tissue up front may be the point where the tumor tissue will go to Dr. Decker for development of these dendritic cell vaccines, which then, after completing systemic therapy and surgical resection, the cardiothoracic surgeons can actually deliver this particular payload in the vicinity of the nodes that actually matter to see if that has utility in preventing recurrences. As you know, we've had very high recurrence rate in spite of chemotherapy in a lot of cases. Dr. Wagner and yourself, Dr. Cusimano, demonstrated that in large series, the effect of chemotherapy in preventing recurrences and the survival was showing a trend towards diminished utility. So these sort of novel approaches would be really interesting to look at and pursue. So Dr. Cusimano, you have any comments there? I think you're on mute.
The patients really don't die of local recurrence most of the time. Sometimes they do, but they die of distant disease. Will this have an effect distant to the heart if you inject it into the heart to those
right?
Elsewhere?
So that's a great question. So to explain the paradigm base, so targeting metastatic disease is actually very difficult because by definition, it's not targeted, it's everywhere. So the goal is actually to mop up after autotransplantation. So the cells, the cells that end up metastasizing and causing patient death, or you get to these patients before that happens. So the goal is to mop up at that level so that metastasis doesn't occur. I would speculate that if and when metastasis does occur after vaccination, the vaccination has failed, and then it is qualitatively much more difficult to target a disease that then is all over the place. So the goal would be to prevent metastasis entirely.
RJ is still on mute, I think.
So how long does it take for the vaccine to have its effect? In other words, I can understand you biopsy the tumor in those time it takes for the chemotherapy to have its effect. When we go in there and we operate on the person, inject it back in. Now, how long after that does it happen? We should really be injecting it before we go and operate, right?
Well, so vaccine therapy, and again, my opinion, has its limitations. When you have big bulky disease in a very immunosuppressive tumor microenvironment, that tends to be very good at knocking down immune responses. So we tend to think that vaccine therapy is going to work the best when you're doing it in the NET or MRD setting. So actually, it would depend how long it takes for metastasis to come back and kill these patients. So you put the dendritic cells in, you get your T cell priming within 3 days. The T cells then exit and start to surveil. In the brain, we're seeing pseudoprogression in some of these patients as late as 14 months, and that could be, the immune system coming back in and taking care of new disease that's appearing at that time. We don't really know. But generally, T cells can become active and start surveilling, the week that they have been primed. So unless this is very fast, unless this happens, within days, I think we would give some of these patients a shot. Generally, we like patients to have at least 3 or 4 months of life expectancy to do vaccine therapy. And I think from what I've heard today, a lot of these patients do have that kind of life expectancy after autotransplantation.
Yeah. Great.
So I think there's time.
Great.
Thank you all. Appreciate your time and stimulating us to kind of think about these sort of novel approaches to combat rapid and also a relatively high prevalence of recurrence in this pretty difficult to treat disease. So we do appreciate you joining us today.
All right, it's my pleasure. And again, it's fascinating for me to learn about something that I know nothing about. This has been great. So thank you for the invite.
Thanks, Will. I'd like to introduce Dr. Tony Conley, my colleague. We've worked together now 2 decades, I guess. It's at MD Anderson. Dr. Conley is our director of our clinical research program in sarcoma, is one of our most innovative. So if you know the kind of people who go out and get the first new iPhone that gets out there, Dr. Conley is right there when it comes to oncologic assets, novel therapeutics that is working anywhere else within oncology. We've had the pleasure of having him work with these early stage companies to bring them in and also to demonstrate utility. We have had a lot of success with oncolytic viruses that was introduced at a time when they were not cool, and now Dr. Conley has made them cool again. So would love to hear more about approaches that are relevant to vascular sarcomas and the potential utility in cardiac sarcomas. We have a case where such an approach was utilized, which will be right after Dr. Conley's talk, and he'll be joining us for the case discussion as well. So welcome, Tony.
Hello, everybody. Thank you for that very kind introduction. I'll go ahead and share my screen right now. Please let me know if there's any issues with seeing my screen here. Let's see here. Okay, can you guys see my screen well? Okay, great. Yeah, I'd like to thank everybody involved with the conference for allowing me to give a talk today. It was wonderful to actually follow Kashini and Dr. Decker, mainly because of their more basic science or translational science backgrounds. Full disclosure, I am a clinician. I do not have a lab. I'm happy to collaborate with folks that do work in the lab, though. And so I'll talk a little bit more about intralesional immunotherapy strategies for advanced metastatic solid tumors. And so, of course, the usual type of why slide is obviously if all the other stuff was working, we wouldn't have to look in strange places like viruses. or other microbes for therapeutics. I think intratumoral administration offers advantages. I mean, Dr. Decker was just talking about it extensively. Oncolytic viruses, as one mode of intralesional immunotherapy, is a way that could leverage different components of immunity. To be fair, there are also bacteria that are also being investigated in this space as well. The other way to look at viruses in this sort of manner is that it's a form of gene transfer. So it's no longer just about inducing a local immune response by the virus itself, but manipulating viruses to have payloads that can then further augment or modify the immune microenvironment, hopefully make it more favorable for therapeutic killing of these tumor cells. Now, importantly, there have been approvals of oncolytic viral therapies on a global scale. The first of which actually occurred in Latvia in 2004 with an echovirus for early stage melanoma. But then in China, nanovirus was approved for use in patients with nasopharyngeal carcinomas. And of course, in the United States, we had the TVEC, which was using an HSV-1 vector based on its ability to induce durable responses. And the payload in that case was the use of GM-CSF to help stimulate certain components of the immune system. But as you can see over time, there have been...
Sorry to interrupt, Dr. Conley. We lost your video and your slides.
Oh, you did? Okay, hold on just a second. That's odd. Just give me one moment. I'm not sure why it did that, because I was already in the conference, but I will jump back on again if you guys can just give me a moment. See, where is... I'm just going back to one of the emails that you guys sent me today to get the link. Okay, here we go. I'll jump back on. Sorry, I don't know why that happened, because I was already in the conference and it was acting like I was joining in. Okay. Can you guys still hear me or no?
Yes, the audio is clear, Tony. I think the phone is
Okay.
phone line is working great. I don't
Yeah,
know if you
okay.
have audio through phone. That's
Can you hear
working.
me or is there an echo?
We can hear you fine.
Okay, good. All right, sorry about that. Let me just... Okay, let me go. Okay, there we go. And I'll just share my screen again. Later, okay. Okay, good. So just let me know if there's any other issues. So basically, there have been a number of oncolytic viruses that have been approved on a global scale in different areas with different indications. I think the area that's been most investigated, of course, have been melanoma. Some bladder cancers have also been evaluated as well based on, prior immunotherapies or conjugates that have been used. But the history for oncolytic viruses and their use in oncology, dates back to as early as the 1950s, where there were actually clinical trials using various viruses to hopefully induce responses or clinical responses within humans. And of course, around that time, interferons were discovered, and then it just progresses from there. And of course, as our technology has improved for a number of different areas in the lab, we've been able to now have numerous types of oncolytic viruses approved, and so while there have been great strides with immune checkpoint therapy, the approvals of CAR T, I do think that there is a role for these intralesional immunotherapies going in the future. Now, importantly, I guess one of the big issues is how do we actually get any form of responsiveness in a tumor with the use of an oncolytic virus. And of course, Dr. Decker gave a wonderful presentation about, in his early part of the slides, talking about how viruses can induce different components of the immune system. But essentially, when a virus infects the host cell, there's usually responses to your immune system that the virus puts out either directly or in the case of like microbes, you basically will interact with toll-like receptors or other pattern recognition-based receptors that will then stimulate different forms of innate immunity. And then you also have the ability of the virus to cause infection, usually because tumor cells, when they have certain machinery faulty within its complex, it may sometimes favor conditions that allow oncolytic viruses to flourish. And of course, this can lead to the usual cascade of immune-like reactions. And so we think of what they call like pathogen-associated molecular patterns or damage-associated molecular patterns. And these are methods by which our bodies will engage the virus. But I think it's important to note that because we're using viruses that have been with humans for as long as we think we've been existing, our body has very good ways to immunize against these pathogens. And so, is it important that there's persistent exposure to these viruses, or is it more a matter of just exposure, non-exposure? Are there manipulations that have to take place with the virus to favor growth within tumor cells versus normal host cells? And then what do we do about preventing autoimmunity? Normally when you have an infection, there's a point at which your immune system will upregulate a variety of pathways to essentially nullify the acute effects of inflammation. And oftentimes the payloads that we're using with oncolytic viruses will manipulate to induce further or pro-inflammatory environments. And so there's kind of an interplay. And as we've come to understand, I think, these different mechanisms better over the last 20 or 30 years, I think it's become, I think there are more therapeutic oncolytic viruses that are now in development as a result of this type of knowledge. And importantly, and of course, when we think about viruses, there's both DNA viruses and RNA viruses. Of course, the DNA viruses tend to be much larger. The common types of viruses used for oncolytic viral therapies generally include adenovirus, pox viruses, and herpes viruses. And in the case of the herpes virus, it's a rather large molecule, and it allows for placement of a variety of different transgenes that can then be used to sort of manipulate the immune microenvironment. And of course, there's different ways by which these cells actually bind to the human cell or tumor cell, and there's different methods by which replication takes place. There's also the issue of whether we want a replicating or non-replicating virus to be present, right? I mean, obviously, we want to treat the patient, but we don't want to give them additional medical problems as a result of what we're using. But herpes virus, of course, have been used quite a bit. In terms of the RNA viruses, these are typically smaller molecules. There have been certain types of viruses that have been utilized for oncolytic viral purposes, such as reovirus or Coxsackie virus. And in this situation, the issue is, whether there's the capacity for placement of transgenes, or whether we really are relying on sort of the immunogenicity of the capsid itself or other components of the virus and what it can do. And this is kind of an example, when we think about, well, okay, fine, if we're injecting a tumor in your arm, how is that going to induce an effect elsewhere? And obviously, Dr. Decker just gave a wonderful explanation about this process, at least involving the dendritic cell vaccines and T cells homing into their site of origin or site of engagement, I guess I should say. But for the purpose of like HSV1 or HSV2 viruses, usually there's manipulations of genes like ICP34.5 or protein kinase R. And essentially what happens is when you manipulate either ICP34.5 or PKR, you're essentially affecting a normal cell or cancer cell's ability to induce protein synthesis, which would then allow the virus to proceed further with processing and replication. It turns out there's been elegant work that's been developed over, again, the last 20, 30 years showing how tumors that have loss of TP53 function typically have reduced protein kinase R expression, which limits its ability to regulate elongation initiation factors, favoring environments where protein synthesis can occur, followed by lysis. And so usually when these companies are going after or manipulating these viruses, it's usually in this form. So it's not necessarily that the virus can't infect normal cells. It's just that it doesn't do a very good job of it, and it certainly doesn't do a very good job of persistence. Of course, this varies. I mean, adenoviruses have other ways by which they can bind to cells. There's also the belief that many types of tumors frequently have impaired interferon signaling, which can favor sort of persistence of these pathogens within these cells. But this is basically just to kind of illustrate. So, when we're injecting a tumor, essentially, you are favoring the tumor because of where you're placing it, but that doesn't necessarily mean it can't move on to other cells. It's just a matter of whether it's going to activate or carry out its process within those normal cells versus tumor cells. The other thing we've noted too is that tumors are generally very vascular, and so sometimes when you inject these tumors and you have assays to look for presence of virus in blood, you can sometimes actually find or note viremia within these patients, sometimes as far out as 2 weeks, but typically at least 1 week. There are assays that one could do to look for the payload. So for instance, if you're trying to bring TGF-beta receptor blockade into the mix, there are assays that can query for that. But the issue there is that the quantities are probably so small that I think detection would be difficult in blood compared to the typical assays that we use to detect viruses in blood. And importantly, at this point, there are many different types of oncolytic viral therapies or modifications that are being used. And what I tried to do here was kind of illustrate some of the more common types of areas. So with regard to cytokines, of course, we've got TVEC and some of these adenoviruses. There's molecules like KB707. And so these are relying on different types of cytokines as their payload to help with different forms of immune cell activation or maturation or differentiation. There are viruses that have been used to bring in chemokines. I think a really fascinating type are actually viruses that are essentially acting as bispecifics or trispecifics, where you can manipulate your transgene to anchor into T cells and also activate PD-L1 or PD-1. Among other types of receptors. I mean, there's some to CD19, the CF33 vaccinia virus, which is part of a company-sponsored study ongoing in the United States, uses a truncated, non-functional CD19 to coat affected tumor cells, and then you can treat with a bispecific targeting CD19. So really, really cool that these types of technologies are present. There's also some that use molecules that help with immune suppression or sort of deregulation of autoimmunity, others that rely on suppression of T regulatory cells, and others that are specifically trying to target macrophages. But the important point here is that the payloads vary and the number of targets are rapidly expanding as we understand more. This is from a nice paper that was published about a year and a half ago that kind of gives us an idea of some of the more popular transgenes that have been looked at, primarily IL-12, followed by the typical checkpoint receptors, followed by a few other notable genes. And in terms of indications, it's for everything, right? I mean, the most common have been solid tumors, mainly because they enter in as phase 1 studies that are generally non-specific. While others have sort of cohorts already carved out for specific indications, but solid tumors, liver, hepatic malignancies, colorectal cancers, and such, melanomas. So you can see that there are a number of different indications, a number of different transgenes that we use. But how do we mix this up with what we do, right? I mean, how does this relate to a cardiac sarcoma patient, or any sarcoma patient for that matter, or cardiac tumor patient? Well, I think there's different ways that can be sequenced in. I mean, obviously there was just an approach that was discussed regarding using a vaccination, right, as an adjuvant following resection. But what about use in oligometastasis, right? What about, especially in patients that may already have had radiation exposure to a specific area, or a situation where resection isn't possible? We use cryoablation quite a bit, but you can't ablate surface lesions without causing substantial local tissue damage, right? So an oncolytic viral or intralesional immunotherapy might be a way to treat these areas. There's combinations with chemotherapy, targeted therapy, use in combination with immune checkpoint therapies, combinations with epigenetic modulators to hopefully help re-express HLA molecules. So there's a number of different ways that these types of intralesional immunotherapies can be incorporated. But then there's the practical consideration. I think this is kind of important because, I mean, again, not going deep into the science as our last two folks did, but just from the practical standpoint, when we started running oncolytic viral studies, we ran into concerns right away, right? Where do we inject this? Can we do this safely in clinic without harming patients that are supposed to be getting these viruses? What about staff? How do we store this? And so thankfully, there are a number of companies that have worked on this, and institutions that have worked on this for years. There's also the matter of how we inject or administer these viruses. Can it just be IV? Does it have to be intratumoral? What gauge, what angle, how many injections into a site, what volume? Do we have to modify it based on size? So there have been a number of very interesting sort of practical considerations that have come up. And so at the moment, sort of the common ones that have come to light or have been used have been, of course, direct percutaneous injection, intraarterial administration, right, intracavitary, and of course, lymphatic. And there have been a number of individuals looking at different types of techniques to deliver these products into the space, right? Because the other issue is, if I inject a tumor, am I going to have to worry about increased interstitial pressures that are going to limit my ability to circulate this through the tumor, or there are just tensile strength issues or tension related to the tumor itself that might prevent this issue? Well, there have been, thankfully, a lot of interventionalists with interest in this area. At MD Anderson, we've had several individuals in the lab look at how we can engage these factors using, direct injections. And this is kind of an interesting study that was done using mouse models. I think where they were basically trying to show you when you inject with some of these different agents, how it affects the different components of the immune microenvironment. To essentially show that by introducing product into these spaces that we'll actually see qualitative changes to the immune microenvironment. As I mentioned earlier, sometimes, when injections are done, you might encounter quite a bit of resistance. Dr. Ravi and I have injected a number of patients on trial in clinic that have superficial tumors, and oftentimes when you first do these administrations, you get a lot of resistance. It can be very difficult to actually force the volume into the target lesion. But over time, as the tumors begin to at least qualitatively change, you find that the interstitial pressures frequently drop. And so it's kind of fascinating to see how these sort of situations arise as we practice. And then there's also the matter of just standardizing the technique. Obviously, I think in sarcoma space or rare tumor space, we always worry about, the design of trials ruining an active drug, or, other sort of scenarios where, such as toxicity being a preventative factor in the development of a potentially useful therapeutic. Well, the same is true when we're thinking about intralesional therapies. We have to take into place, how is the best way to check for PK biomarkers? What's the best way to biopsy? Should we use photography in addition to imaging when we're looking at these tumors? Now, that may not necessarily apply to a cardiac sarcoma patient at that point, But it's not limited to patients that just have advanced unresectable disease. We have treated patients with metastasis. And depending on the interventional radiology department or those that you work with to administer these injections, we have actually been able to do very deep injections of tumors in the human body. Dr. Ravi has enrolled patients with cardiac tumors onto these types of studies. So it's definitely feasible, but of course you want to make sure you've got the right folks in IR or cardiothoracic surgery and such that would be willing to consider it. So there is kind of a multidisciplinary approach to this that needs to occur in terms of making sure that patients are treated in a similar manner for informational purposes, and also making sure that safety is paramount. Recently, there have been guidelines in terms of how we should gauge response. Sometimes when we do these types of therapies, you may initially see some levels of progression, but the patient feels fine. And so in some studies where we're allowed to continue treatment, we sometimes see that there is actually improvement over time. So there have been guidelines produced and endorsed by organizations such as SITC, the Society for Immunotherapy and Cancer, that have allowed us to demonstrate that there can be a uniform method by which we can evaluate responsiveness for patients that are receiving intratumoral immunotherapy trials. And of course, I think if you have a program that's considering these types of therapies, you definitely want to make sure you're working with your institutional biosafety committees, infection control. If it's something that's going to be in the hospital, obviously, like cellular therapies, you want to make sure you're engaging the nurse management in the outpatient setting, whether it's through your regular treatment center or if it's in a research-based administration center. You want to make sure you've got buy-in on everybody, so that way everyone's rightfully protected. And just kind of briefly, my take on some of these trials have been that side effect profiles for these viruses itself generally are low. They're usually injection site related reactions. There have been some immune reactions, whether you would classify them as CRS-like or just simple flu-like symptoms, I think may depend on the payload that you're using with your oncolytic virus. But in general, tolerance has been good. I think as we combine them with different types of agents, this might, of course, change, but I think it's important to note that in general, I think I've found, and I think Dr. Ravi could agree, that a lot of these therapies have actually been reasonably tolerable compared to many of the other types of agents we've used in the past. We've had to develop considerations or mitigation strategies for some protocols where we sometimes do encounter CRS-like symptoms. When you're using, I think, viruses to try and introduce IL-2, IL-12, or similar cytokines, you need to be prepared to consider the possibility that patients may develop CRS-like symptoms. And so anticipating this up front, I think, helps to provide better safety for patients, better coordination with your nursing staff. But so far, I think we've been able to, overall, we've been able to do a reasonably good job. But of course, we're always open to suggestions if our nursing staff don't agree with that assessment. And then lastly, I just wanted to show you just a few brief examples. So this is a patient that had prior immune checkpoint therapy in the past, received numerous therapies after immune checkpoint, and then eventually received Adapta-01, which is a modified adenovirus that allows for, it's a replicative virus, and it carries a transgene or fusion for TGF-beta receptor 2, which helps to sequester TGF-beta. And in this patient's case, within 1 month, the tumor did in fact get bigger, but it got softer. The patient allowed us to continue with injections, and 9 months out, the patient had a tremendous response. By imaging, I think the appearance was less enthusiastic, which I think it's important, therefore, to have not just imaging assessments, especially when you're dealing with flat lesions, but also photography to illustrate these changes. Here's another patient with a radiation-associated sarcoma who received treatment after the first month, was exhibiting signs of resist progression. As you can see, there's a nodule that's present that wasn't there initially. Again, tolerance was very good, so the patient was continued on treatment, and then they had a very remarkable clinical response. This too is a patient that was refractory to prior immunotherapy. And then just, kind of last two examples are patients that had other malignancies. So it's not just limited to necessarily sarcoma. But this is an illustration of a patient treated at one of the centers for this particular study, where the patient had triple negative breast cancer and previously received immune checkpoint therapy. And they were receiving injections to a lesion on their neck. And they had a very nice response, both at the injection site, but also surrounding structures, as well as in visceral organs such as the lungs. And so this is kind of like a catalog of some of the currently open protocols that we have in our department. Through our phase 1 program, we have many more, but I think the point is just that there are a number of oncolytic viral products with different payloads that we can use. And of course, depending on the tumor of interest, and I think in this case, cardiac sarcomas, whether it's in the metastatic setting or not, I think these are reasonable to consider, especially if these patients have already received the typical therapies that you would expect to provide for these patients. And so with that, I'll just open it up to questions. And thank you.
Thank you, Tony. So fantastic talk. I have a question in the chat line here asking about the role of TNF-alpha, if those could potentially be leveraged in this particular delivery.
Yeah, I mean, I don't see why not, right? I mean, there's already been a precedence for using TNF-alpha, like in Germany, right? And I think it's definitely possible. Of course, I mean, whether it's going to be something that would be, designed at an academic center or in conjunction with, with a pharma company, I think that's the only issue at hand. But I don't see why not. I mean, again, there have been a number of different cytokines and other types of molecules. And to be honest with you, there are even companies that are not even using viruses. They're using different linkers that will actually combine cytokines. And you still administer it locally because you're trying to force the reaction at the level of the tumor microenvironment.
The other question, Tony, while we wait for questions to populate, we found it somewhat challenging to, at least from a drug development standpoint, to put these sort of very high mortality, bad outcome kind of rich area like cardiac sarcomas on these novel agents, because at least from the industry standpoint, the ability for them to kind of tolerate bad outcomes, which are kind of universally there as a function of the disease site itself, has been quite limited. So working every single time we have put patients on, one of the challenges is if there is a disease-related death, even that is not particularly very palatable for industry. Do you have any advice on how to combat this and set expectations up front, or have a dedicated cardiac trial where the unmet need is well discussed with the regulatory body before proceeding down that path? Any thoughts there?
Yeah, I mean, I think if we're trying to establish efficacy, I suppose maybe the best way to do it up front would probably be looking at patients that already have metastatic disease from their cardiac sarcoma. Or I think if the patient has already exhausted their standard therapies and were never a candidate for resection, of course, in that scenario, you definitely need to have contact with your interventionalist and your thoracic team to determine if it's safe to administer, right? But as you've done, right, there have been instances where that can happen. I think patient selection is always very important, and it's tough, right? Because you want to help everybody, but at the same time, you also have to make sure you're not putting them at risk, right? If you're giving a cytokine that can cause, capillary leak syndrome, right? You could potentially cause them to have overload, right? Which could which could be bad, right, for their ability to breathe or circulate effectively. I think, to the point that was made earlier by Dr. Decker, I think, the amount of tumor bulk may have some significance as well. As I recall, with some, cardiac tumor patients, when they develop metastasis, sometimes it's predominantly bone. The metastasis itself may not always be bulky, heavy tumor, so that might actually be the better type of patient where you consider this, right? But I think if you wanted to treat somebody that was not a surgical candidate, I think it would be fair to at least make sure that they've had at least the typical things that you would decide upon. And I realize that there's some controversy, as we discussed earlier, about the different types of chemotherapies we would use, or whether you would use immune checkpoint first and such. I think at this time it still should probably be more of a phase 1 scenario. That would be my thought.
Very useful, Tony. Thank you so much for such a brilliant talk, and for all the work that you do in underserved asset class, and really bringing them to the forefront really is making a huge difference for our patient population. So really thankful for that. I think we're a bit over time, so I will move on to our next session, which is our last session on a case discussion, one where I'm glad to have Dr. Conley here as well, a patient who has been treated with this sort of an intratumoral approach. I'd like to introduce Aparna Subramaniam, an MD PhD working with our group, really committed to growth of vascular tumors and developing this particular area forwards. We're very lucky to have her continue to work with us in a physician scientist capacity. So looking forward to having you go over the case with us. RJ, I don't know if Dr. Radin is going to be joining for the discussion. So if the operative component, if you could weigh in on that, that would be spectacular. I think I do see Dr. Bishop on, so glad to have him here as well in discussing the case. So you're on mute, Aparna.
Thank you. Thank you for the introduction, and thank you for the opportunity to present this case. I will go ahead and share my screen. Is everyone able to see my screen?
Yes.
Okay, perfect. So this is a patient, a 62-year-old male who initially presented with multiple episodes of palpitations and lightheadedness on exertion with occasional shortness of breath. He presented to the ER, I think, with 4 episodes of these symptoms, and he was initially diagnosed with an atrial flutter, and he was started on metoprolol, but the symptoms continued to persist. At which point a transesophageal echo was performed as part of the cardiac workup, and a 2.5 centimeter mass in the right atrium was seen. His left ventricular ejection fraction was 59% at that time. He had good renal function with a serum creatinine of 1. Post that, he was advised to get a cardiac MRI, which showed a 3.5 centimeter mass at the root of the right atrium. And it was suspected to be an atrial myxoma. But a PET-CT performed at the same time showed that it was an intensely FDG-avid right atrial mass. And the surgeon who reviewed the images at that time suspected that it was either a metastatic or primary cardiac malignancy, and most likely a sarcoma. So instead of going in for the resection of the atrial myxoma, they decided to do a biopsy at that time. So the endomyocardial biopsy was performed under the echo guidance, and a large mass measuring 5.7 centimeters was found adherent to the right atrial wall. near the right atrium inferior vena cava junction. And it was partially obstructing the SVC-RA junction as well. The histopathological diagnosis at that time with the biopsy was that it was a malignant vascular neoplasm favoring angiosarcoma, and the IHC markers were positive for vascular markers CD31 and ERG. Dr. Ravi, do you want to discuss?
Yeah. So I wanted to ask RJ let's just assume a pre-TEE, the size was around 3.5 centimeters. Is this something that you would still consider for some neoadjuvant therapy? If on a subsequent TEE, a higher size of around 5 centimeter was observed, would you consider that as a relatively rapidly growing and therefore consider additional therapy? How do you see this?
I always say that myxoma in an unusual place may not be a myxoma. So that should be your first warning sign that you have to be careful. Anytime it's not in the typical place of a myxoma, which is the left side of the intraatrial septum, you have to be careful. The fact that it grew a lot in that time is really, really, really dangerous. And the fact that it's near the IVC, again, with respect to resectability that we spoke about this morning, I would want to biopsy it and give it neoadjuvant chemotherapy. I don't see anything wrong with giving a person neoadjuvant chemotherapy. I think it's a fantastic way of doing things that you guys pioneered, because it lets you see who's going to respond and who's going to spring up mets everywhere else. So A, it's in an abnormal location. B, it grows really fast. Obviously, it's lighting up here, but giving it neoadjuvant chemotherapy allows you to have a better chance of getting an R0 resection. And it also allows you to determine which patient is going to respond to the therapy and which is going to just grow despite therapy. So I think the right thing is giving neoadjuvant chemo.
Back to you, Bruna. If you want to move forward with the neoadjuvant therapy,
Yeah, at this point, the patient was seen at MD Anderson, and he was started on neoadjuvant therapy with the first line of adriamycin and ifosfamide over 5 days, and he received 4 cycles of this therapy. The treatment response was stable disease, but the patient did have significant toxicity with this regimen. He also complained of rectal abscesses, and the left ventricular ejection fraction dropped to 48%. So at that time, the patient was switched from AI, and he received gemcitabine and docetaxel as the second line of neoadjuvant therapy. He received 2 cycles of this therapy, and there was a positive response with reduction in tumor size. There was some toxicity with shortness of breath and pedal edema, but otherwise the patient tolerated this regimen well. So if you look at the CT imaging prior to start of neoadjuvant therapy with AI, the tumor was about 3.7. This is post biopsy. So the tumor was about 3.8 centimeters, the longest diameter. And the pre-op, you see that it is just about 2.4 centimeters in longest diameter. And that was when, this is post 2 cycles of gemcitabine. This was when the patient was referred to surgery for resection of the tumor because the tumor had considerably reduced in size.
So Tony, I was wondering, would you be comfortable at this particular point escalating the patient to, a surgical resection? What do you think, considering the response that the patient has had, or would you still want to maximize more?
That's a great question. I mean, I think, personally, anytime I'm treating a patient with neoadjuvant, I think most of us do this. I mean, I always try to make sure that the surgical team is intimately aware of what's going on to make sure we're not sending them too late or too early. I would say, though, given the level of response, it certainly would be tempting. This is one where I probably would email or reach out or present the case with letting the patient know that they're probably going to continue treatment, but making sure that the surgical team's aware. But yeah, I mean, I think having this good of a response early on is exciting. On the other hand, I suppose sometimes if you respond too quickly, it makes you wonder if you know, if there's any level of resistance that could set in quickly as well. But so I would probably be tempted to continue, but I would definitely make sure the surgeons were aware of it, so that way they could, you know, give their okay.
I think Dr. Reardon is on. I think he's trying to get the audio connected. I've just texted Josh to provide access. So I'm hoping he can also kind of weigh in.
When you give a person chemotherapy and the thing disappears completely, what do you think the best treatment is? A little bit of thickening of that heart. Just a little thickening, not like this. Hi, Mike.
Hey, okay, sorry I'm late.
No worries.
No,
I
it
know what
snowed and you
life
could
is
take
like.
4 inches and it shut down the city and the hospital.
What's that? Did you say snow? Did you say snow?
Before I go to STS.
I didn't hear. Did you say snow? Is that what you said?
No, it snowed 4 inches. We were pretty sure the world was almost over.
Well, we are talking about rare things, so good.
It's very rare. It literally shut down the city. It shut down all my elective cases, and I've got an early flight to STS tomorrow, so we're catching up today. So I apologize for being a little late.
No worries.
But yeah, I mean, you know, the story will play out, but I thought this is something we can get an RO resection on. And if I think I can get an RO resection on sarcoma, I treat it as long as I can with neoadjuvant therapy. You know, Vin and I have become very aggressive with how long we'll treat. And then if we think we can get an RO resection, then I still think sarcomas that you can get a complete resection on, it's the best thing to do. So that's my thoughts as you play. And if you look at this from a surgical, RJ will tell you, this is not a hard area for us. If this is an atrium, we can take out all the atrium without any real trouble.
I think our goal really has always been to kind of get to an R0 resection, because anything that's got margin positivity, the survival has been so dismal. It's always been, you know, front load therapy, and that's basically how we've done this in the past. Back to you, Perna.
So yeah, the surgical resection, the patient went for surgical resection. He had a right atrial sarcoma resection and a repair with the bovine pericardium. He also had the left atrial appendage clipping with the MACE procedure and did not have any intraoperative or postoperative complications. And in the surgical pathology, it was angiosarcoma with treatment effect involving the myocardium. That was the diagnosis. The tumor was about 3.5 centimeters in size, and there was significant treatment effect of tumor necrosis, with about approximately 90% being necrosis. And the mitotic rate was very low, with 0 per 10 high power field. And the resection margin was negative for this patient in this tumor.
So, Dr. Bishop, do you think in this particular setting you'd want to do anything either pre or post-operatively? I know you talked about this earlier on our previous case. Quickly, very small tumor, good response to systemic chemotherapy.
Yeah, I mean, I think I would kind of bounce the question back to this group here. Given the favorable response, given the R0 resection, what does the group think the risk of local recurrence as the first site of failure is?
Oh,
well, we certainly see these come back occasionally locally, but you know, I tell you, it's the local recurrence has gone down fairly significantly with these RO resections as we become more and more aggressive. Most of the early recurrences we had where surgeons were inaccurately resecting these, particularly left atrial ones. They'd go in there and think it's a myxoma and just kind of whack it out. And it really was a sarcoma, and they got nothing in the way of margins because you can't. The right atrium is pretty easy to take everything out. I mean, you know, we can just take out the whole right atrium without any big deal, go around it pretty widely. When we take these out, we don't, it's not like doing colon cancer or lung cancer where you can check margins and come back. I just take a big whack of atrium, as much as I can take, more than I need to take, just to make sure I get around it. And then, you know, the question sometimes comes, well, do we treat it with radiation therapy locally? My view generally is no. I continue to treat it as a systemic disease. and only wait to see if it recurs locally. The problem is if you radiate it, at least my teaching, and RJ, I'll defer some to you too. So I teach my residents you can do a redo chest and you can do a radiated chest, but one should try to avoid doing a redo radiated chest. They tend to be bad. So it would complicate a local re-resection if we needed to do it. And I think, to me, angiosarcoma is just a systemic disease.
Yeah. Yeah, I mean, I agree with all of that you said. I mean, I think the discussion of postoperative radiation in an R0 resection, I think it comes down to this multidisciplinary discussion about what are the risks of recurrence, what are the risks of, or what are the possibilities of salvage in the future. You know, if there was a conversation between myself and Dr. Reardon that, hey, this was in a tough location, surgical salvage, if there was a local recurrence, would be near impossible, or you know, there was a margin that while negative, I'm particularly concerned about. Those are scenarios where I think maybe it would be worth considering kind of elective postoperative radiation therapy. But if from a surgical perspective, there is a salvage option, everyone's happy with the margins, everyone's happy with the surgery, I think reserving radiation for the time of recurrence, either to be combined with an additional surgery at that point or as a definitive option in the context that this is a more systemic disease, I think makes a lot of sense.
Yeah, I mean, a good example is we just did a young fellow from New Jersey that had a pulmonary artery sarcoma. We took out the whole root and both main pulmonary arteries all the way out. But on pathology, there were some malignant cells there. And clearly no gross disease, but that was as far as I could go. When they called me from New Jersey about radiation, said, absolutely. There's nothing else that I can do surgically for this guy outside take his whole lung out. In which case you're going to be operating in a kind of non-radiated field if you have to do that. But you know, I think that's, you know, Andrew, that's where the real discussion, where you need a doctor to doctor conversation to decide what are our options in the future, not just for now, but what does this do to our future options?
Thanks, Mike. Thanks, Andrew. So, Tony, the question is now, in this case where it's been completely resected with negative margins, and the path report is right here, would you entertain any additional adjuvant therapies further out? How do you, we had a discussion about our prior experience with checkpoint inhibitors being not so great. Patient was already exhausted and was showing quite a bit of side effects from systemic therapy as well. And that's the time point where that discussion was taking place. How do you feel about additional therapies, or do you think in this particular situation it may be reasonable to pause?
Well, I mean, obviously I agree with what everyone's mentioned. I mean, Dr. Reardon just talked about how this is a systemic disease. I don't doubt that either. I mean, I think if, for instance, if tolerance wasn't an issue, given that response, I would be thinking about Dr. Robert Benjamin's principles of treating sarcomas. And you know, usually if you have something that's working very, very well before surgery, chances are it's probably going to be a great adjuvant afterward. I realize that may not equate out to the types of trials that have been published in the adjuvant setting for sarcomas. But if I'm just personalizing it to this individual, given that response, I would be really tempted to continue. But I do realize that there are times where patients have, you know, they're just exhausted. They can't. Sometimes in that scenario, what I may do is ask the patient to come back maybe 6 weeks later and see if they still feel the same way. You know, sometimes if you just give them more time to heal, maybe they're going to be in a place where they're much more likely to reconsider. Whereas there are some that are just adamant they won't do it and would rather watch and wait. But I think if you only had stability on your imaging and surgery still took place, I think I'd be a little less enthusiastic about it. But that type of response would make me, it would at least make me want to consider it if the toxicities were not tremendous. Switching to another adjuvant, I mean, could certainly be done. It's just the usual sort of, you know, without knowing what it was doing to the patient before surgery, it just kind of leaves question marks as to whether it'll work. Although you could argue that with immunotherapy, having minimal residual disease of any sort, might be the easiest disease to knock out. But I would at least have a discussion with the patient. Maybe if it's more of a tolerance issue, maybe reappraise them 6 to 8 weeks later and see if they still feel the same way.
Thanks, Tony. Bernard, do you want to take us through the adjuvant approach?
Yeah, so the patient received, this was a month after surgical resection. So he was started on pembrolizumab 200 mg IV every 3 weeks, received 6 cycles of the pembro. It was initially stable, but went on to have mild progression at the end of 6 cycles. But the progression was actually with the development of metastasis in the lungs. So he had 2 new metastatic lesions in the lungs, but did not have, but tolerated the therapy well, did not have any toxicity to the pembrolizumab. So at this point, because of the metastatic disease, he was switched to additional therapy for the treatment of the Mets. So for the treatment of the metastasis, the first regimen was adding paclitaxel to the pembrolizumab that he was already receiving. So he just totally received another additional 4 cycles of the combination of pembro and paclitaxel. And there was initial response, but with subsequent progression, but no toxicities with that as well. At that time of progression, he was switched to gemcitabine and docetaxel because he had responded well to that prior to in the neoadjuvant setting. He had a positive response to that as well. He received 5 cycles of it, but after the 5 cycles, he developed gemcitabine-induced pneumonitis and had to be switched out from the Gemtax to a single-agent docetaxel, and he received 2 cycles of that. During the single-agent docetaxel regimen, he had multiple episodes of shortness of breath, and then he also was admitted twice for pneumonia and bilateral pulmonary emboli. And he eventually developed a multifocal metastatic disease progression in the lungs, pleura, lymph nodes, and the liver at the end of the 2 cycles of docetaxel.
Yeah, thanks, Pranav. So this is probably the second case we are discussing today where, in the adjuvant setting, the use of checkpoint inhibitors, perhaps there was a bit of slowing down of the disease, but no real market activity was observed. Perhaps that is not the approach to take as a monotherapy. We are currently now thinking more for about the case that Dr. Reardon was referring to earlier. The gentleman with the pulmonary artery sarcoma, we kind of combined radiation and checkpoint inhibitor because the combined activity in other histology has been an interesting phenomenon we've been trying to leverage for our histologic subtype as well. So my question was, Andrew, do you feel like that sort of an approach is something to kind of consider, especially in early development of metastases where the bulk of disease is not very high, to actually have a radiation step in, not with the goal of fully eliminating all disease, but to really potentiating an immune response?
Yeah, I think it's definitely a good question. We're kind of extrapolating that from other diseases where there's this kind of hope of abscopal, and that has been observed in laboratory experiments. It's been observed anecdotally in patients, but who benefits from that effect and how to predict for it is impossible. That's the magic bullet that we're all looking for. That being said, in patients like this that have limited disease, that we're doing immunotherapy, if there is a lesion that we can reasonably target, that we can say that we're going to provide some benefit by treating it, I think that makes the argument stronger. So if that tumor progresses, is it going to push on something that's bad, or is it imminently symptomatic? Yes, I think combining that therapy makes a lot of sense. If they have a lot of disease and we're just aiming at one spot to try to elicit that immune response, I get a little bit less excited about it. Not saying that we don't do it, But then you start worrying about adding toxicity without providing a benefit. And so I think it has to be done very selectively in a multidisciplinary fashion.
Yeah, it's a great point, Andrew. And I think even with the pneumonitis we observed with the gemcitabine-based therapy, I couldn't help but wonder if the pre-use of checkpoint inhibitors probably set the patient up for this pulmonary toxicity. We typically, the patient was exposed to gem before and really didn't show any such change. And then it was on the second use that we started to observe pneumonitis. The first use was before we gave any checkpoint inhibitor. So, toxicity associated with use of these IO agents is also something to kind of keep in mind as we move forward. Aparna, back to you.
So at this point, the patient was started on a clinical trial with the intratumoral therapy, which is the KB707. It is a HSV1 based vector that delivers human IL-2 and IL-12 directly to the patient's local tumor microenvironment. So the patient was consented on this study. He received 2 cycles of therapy with this and at a dose of 1 ml of the undiluted drug. That was the dose escalation phase, but developed progression at the end of 2 cycles. That was at the first restaging visit. He also had toxicity with the cytokine release syndrome, with the fever, chills, and also nausea.
Yeah, so I want to add some comments here because this was a really difficult thing to do. The site of injection was right there in the mediastinum. We had used interventional radiology to deliver the viral particles in. And we knew, and Tony can attest to this as well, in most patients we have treated, during the first 6 weeks, there is always progression. I can't think of a single patient, even the panel that Dr. Connolly had up earlier, where the patient had a spectacular response. The second picture is always worse than the baseline picture. So I don't know if we switched out way too early. And there are several reasons why I think maybe this was not a true disease progression sort of a situation, but rather a initial worsening, and we didn't really wait around to see if there was a response that follows it. The fundamental reason why it becomes hard to do it in these mediastinal tumors is even with minimal worsening, there's complaints, there are exercise tolerance, everything is changing. It's very hard to keep the patient still on the same treatment when that sort of progression is actually happening. I did notice that after the first cycle, there was some improvement in his exercise tolerance. He used to be doing laps in the sarcoma center. I think Tony joined us for one of those walks as well with the patient as well. So just wanted to ask Dr. Connolly if there are other patients where he's been seeing this as well.
Yeah, so I think Dr. Cusimano had asked that question too. See, cytokines like IL-2, IL-12, I think help with promoting inflammation, right? And it's just like the classic signs of inflammation. So I do think that you end up getting like capillary leak into the tumor. I think that you're recruiting enormous loads of white cells of different types. I think that you're seeing an enlargement of the overall circulating volume of fluids within the tumor. So I think it engorges it. So, and I don't feel like this happens to the same degree with just checkpoint alone. There's been several sarcoma studies that have, I think, shown about 10 to 15% may have this pseudo progression phenomena where it enlarges enough to be considered resist progression, like 30% or more growth, right? 20% or more growth, sorry. But then if you continue them, they start to see reduction. With the oncolytic viruses, most of the time you'll see enlargement within the first, I think, maybe anywhere from 4 weeks out to as far as maybe 8 weeks. There were some patients that Vinod treated with angiosarcoma that either had that prompt and of course with the cutaneous, you have the ability to visually see what's going on, right? So they would get worse within that first month, even though they felt well, right? If you injected the tumor, it certainly was much softer. And then usually by the second month, third month at most, you would begin to see that some of those signs had changed. The issue is, how much can you do before you consider it a failure or not? And I think that's always the difficulty, right? And in the case of using agents that can induce IL-2, IL-12, you've got to worry about some of the systemic side effects, the cytokine release, not cytokine release syndrome, more like capillary leak. So making them volume overloaded, right, in a patient that may already have issues with managing circulation. But I agree with you, Vinod. I think with a lot of these patients, you're seeing just a massive amount of inflammatory induction. And just so you know, it's not just this product. There are other IL-12-based therapies that are in development right now that I think also kind of exhibit some of the same sort of symptoms and clinical pictures. And from a drug development standpoint, how much do we allow for this change to occur before we say enough's enough, or to recognize that response will occur? So I think that's always a challenge.
So I'm going to steal Aparna's thunder a little bit. And the reality is this patient, after this patient develops disease progression, and we took the patient off study, he went back up north to receive checkpoint inhibition as dual agent checkpoint inhibition with IPI and Nivo, was initiated on that particular therapy and never had progression after that initial uptick that we saw. The patient eventually went on to develop some inflammation in the lung. The gem pneumonitis just reactivated in the presence of the checkpoint inhibitor, even close to a terminal state. Aparna, can you tell us how many cycles of Nivo, IPI and Nivo?
He received only one cycle, but developed pneumonitis immediately after, 2 weeks after the cycle ended, he developed pneumonitis. So he did not receive the second cycle. The disease never progressed, but he went into respiratory failure because of the pneumonitis.
And that's basically how the patient sort of passed away. Again, very humbling experience. The toxicity associated with some of these agents is not trivial, even when there is activity. I truly believe that this patient actually had some anti-tumor effect for sure, because the lesions that were there were just not growing, which was very surprising to me. I could have taken growth of those lesions and the pneumonitis, and I could have seen it and kind of ruled that it really just didn't work. It wasn't really that disease progression what killed the patient. I think it was more to do with the inflammation in the lungs. The family has been very, very kind to actually proceed forwards with an autopsy. So all the tissues were sent to MD Anderson. So waiting for the final autopsy report before further examining the lung to see what might have actually happened there that resulted in the terminal event. So we are investigating this a bit more in detail. But that was the evolution of events in this particular case.
Can you teach us more about the you were going to do two cycles of this injection? Can you teach us more about the timing, how you decided on that timing, how many cycles you plan to give, and what causes you to give one versus another, and things like that?
Tony, do you want to take this one?
Yeah, sure. Yeah, so I would say that in general, it may depend on the product. And the reason I say that is like I mentioned earlier, when you're using viruses that are common to humans, because of the fact that most humans have had some exposure to like HSV1 or adenoviruses, immunity, antiviral immunity sets in quickly. And so the idea is that you probably have to dose them repeatedly. And so sometimes the schemas are born out of like these phase 1 dosing trials. So with the trial that this particular patient was on, the early part of the study required patients to get weekly injections And then after the first 3 doses, they would then go on to get biweekly. But what we learned is that after you reached a certain dose, it got a little bit toxic doing that. And so then the schedules had to be modified. And that happens with a lot of different drugs and products. With other oncolytic viruses, the same sort of thing. There's some that you give every 2 weeks, others that you give once every 3 weeks. Some of these trials are looking at pharmacodynamic changes. So they're looking at blood levels of the virus to see when they peak out and move on. And so that honestly is what drives a lot of it. In terms of the site of injection, that ultimately will depend on the clinicians, the med oncs speaking with the thoracic folks, right, or other relevant stakeholders, depending on where the target lesion of interest is for the injection. I will say this, I did have the opportunity to see that particular patient when they were on the study, and it was kind of remarkable because despite some of the radiographic changes, clinically the patient felt much, much better. In fact, I recall the patient talking about how they hadn't felt that well in a long time. And I don't think it's placebo effect because it was like issues like they were having to take Lasix repeatedly in the past. They were not having to take Lasix anymore. His functional status improved. It's just, again, at what point is it appropriate to take a patient off or not? Sometimes that'll be dictated by the parameters of the study. Some studies are very strict, no, you cannot continue treatment beyond progression. Others may allow it under certain circumstances. But, it is what it is. And then to Ravi's point about, the issue of gemcitabine toxicity, that's a hard one to gauge because it does happen rarely. But when you treat enough sarcoma patients, you do unfortunately see it happen enough, right? And so it's always hard to gauge when it'll happen. I mean, I've certainly seen it in the absence of having any immune checkpoint therapy. And when that type of inflammatory response occurs, it's difficult. It's really difficult to manage just because it's not just a matter of being volume overloaded. It's just like a qualitative change in the way they breathe, right? And so you're stuck having to give COPD-like treatments that may not effectively treat this type of reaction.
And you inject it into the same tumor each time? In other words, do you expect it to act just in that one met, or do the other met recede as well? Just like the face, do you have to put it into the whole face, or you can just do the top and the bottom recedes?
Yeah, I will say that's something that we learned over time. And again, I think whether it's truly an abscopal effect where the virus is only at the site that you're injecting and yet immune responses are elicited elsewhere, or whether it's that because these tumors have a blood supply, virus does actually leak out and circulate throughout the body. But we have seen patients where you inject the target lesion and you see other areas of the body respond. For one of the studies that we've been conducting, we actually case reported some of these findings in Molecular Cancer Therapeutics and also in Journal of Immunotherapy and Cancer, the GITC. So we did show that this is something that can occur. And we've had, depending on the sponsor, depending on, again, whether it's homegrown trial that you develop or in conjunction with the company you're working with, we've had some where the trial, the leadership allow us to inject new lesions or to add on lesions, I guess, that were already present at the start that maybe were not injected initially. We've had situations where, I know Vinod's had some patients where he's injecting maybe in 2 or 3 places, but there's complete regression of 2 of those places, so he can only do 1 area now. And in that particular study, there's a fixed volume that you give. And, in that particular study, it was like, I think 1.8 milliliters. And, when you're giving a 5 centimeter tumor 1.8 milliliters, it's not a big deal. But once it shrinks down to 1 centimeter, it's really hard to get 1.8 mLs into that space because it just blows up. So there's ways to do it. And I don't think it has to be limited to being done in clinic. I mean, like I said, our interventionalists work with this closely. Technically, it could be an interventional pulmonologist. It could be a cardiothoracic surgeon under the right circumstances. I know neurosurgery folks in our group are thinking about doing this type of administration to either spinal metastases or spinal primaries or in certain skull-based lesions. So it's definitely an area of interest that's not just limited to, med onc by any means.
Yeah, RJ. I mean, we even the location site, we do move it a little bit. Sometimes there are certain portions of the tumor that'll show, especially with cutaneous disease, where there is some increase in size, where we would just reshift. So it's very different from the traditional way in which we have used chemo, where we give chemo of any tumor anywhere, substantially increases in size, patient comes off. This, we can actually rotate the site sometimes, and we reinduce a beautiful response even distally. So just understanding how to use these assets more effectively, how to rotate the sites, and with the frequent administration, it's very labor intensive, but it's certainly something that we need more data and more experience in trying to do it. It does matter where you actually get the initial process developed, so that you're getting the best bang for the buck. The patient with the disease in the face that we originally showed stuck around with that therapy for over a year, and then went on the same asset, KB707, which is the herpes virus. So switched from the adenovirus to the herpes virus, and is still and is able to sustain ongoing responses on that to date. So, and that's the next year that followed that the patient has been on that particular therapy. So clearly, even progression on one type of asset does not predict that additional assets in the same class are going to be ineffective. One was a TGF-beta binding target approach. The second was a IL-12, IL-2 based approach, and it was inducing a response again. So it's really intriguing how response on one doesn't necessarily need exclusion, which is very interesting because most of our other pharmaceutical pharmacological agents, if they failed in one particular drug, they're automatically often excluded from additional trials that pursue the same target class. Really a whole lot to learn, and trying to acquire that experience so that we can put together our dedicated trials more intelligently and set them up for success. RJ, you're on mute.
So then do you envision then that the viral therapy is going to be something you have to continue on for the rest of the person's life?
We don't know. The longest we've gone is about a year and 3 months, a year and a half.
But you've continuously given the
every 2 weeks, like clockwork. So they are kind of labor intensive because they do show up in clinic and we administer, or we set it up through IR. So the institutional bandwidth in many of our institutions, just to get an IR biopsy, we're usually booked out 4 weeks. So in situations like that, it's very difficult to operate with these. Would love to see our surgeons also participate more in these administrations. How would that look like? And would that be done under fluoro? What would be the approach to park this asset for deeper tumors? At least the ones that I'm injecting are all cutaneous and surface disease, which is a little easier for us to tackle. But for the deeper tumors, we certainly need interventional radiology and our surgical colleagues to be helping out. So the exact workflow is not fully worked out. We're just trying to understand if we can make this work and if it is worth developing a protocol around this.
Well, so just to your point, though, there's a patient that we treated, again, different disease called a chordoma, who was on one of these studies, had a response, and then eventually started to have slow progression, was on the product for about 16 months, and then met criteria for progression. So true progression, greater than 20% growth after 16 months. So we took the patient off. They wanted to break. They didn't really have any side effects, but they were just tired of having to come and get injections every 2 weeks. So we brought the patient back about 2 months later, and funny enough, most of the lesions that she had actually regressed. So even after they progressed, some of these patients had, and she had nothing in between, remains off therapy, still has disease, but no longer active. Again, different disease, but the point being that sometimes I think once you let off the amount of sort of, because a lot of these payloads, again, are involved with limiting autoimmunity. And maybe there's just persistent inflammation that takes place for some of these patients, right? And so it's hard to know what the optimal duration would be. I mean, obviously, first we have to prove that it's safe and effective on a scalable level. And I think once you do that, then it becomes easier to look at things like duration. But it is hard to imagine injecting somebody in a difficult to reach spot, consecutively for many months or years. And so it might be, for some of these trials, they're actually developed to give up to a certain number of doses. But if the patient is clearly benefiting, oftentimes some of these studies will allow you to continue beyond that point. So it may be the type of issue where you just have to program how much is sufficient and safe to do.
I just want to thank the panel, and Prerna, thank you for presenting the case, and the panel for weighing in. It's really been a riveting discussion. Lots of unknowns in this area, so appreciate everyone's wisdom and patience as we work through administration of some of these drugs. Always investigationally moving forwards, and this area is fraught with all kinds of toxicity-related problems. I cannot thank our patient population for being so patient with us and working together to move this field forwards. Sometimes even at a point where they're enduring fatal consequences for this therapy. So we're really grateful for their contribution as well. RJ, I'll hand it off back to you. I think we're on time.
All right, this is the closing remarks. Let me see here. Because I have to share, right? All right, well, it seems like we just started, but it's time to finish. So I'm just going to make a few closing remarks. I think it's been a fantastic meeting, and I'm just going to go over, if I can get this thing to work. Here we go. The goals in 2025 were to learn about immunotherapy for cardiac tumors, including the use of vaccines and viruses, and to know about the progress in the International Registry to assess cardiac tumors. The objectives were to explain the role of checkpoint inhibitors in sarcoma, both in targeted and combination therapy, describe CAR T therapy, and we went beyond that. Explain the uses of cellular vaccine therapies have been great. And again, to describe the INTERACT project and its benefits. What did I learn? I learned the importance of testing theoretical hypotheses clinically. Theoretically, these things I thought would be amazing things, but obviously you have to test it theoretically to see whether hypotheses really do work. The heterogeneity, even in the immune system, is quite interesting to me. And I was really impressed with the potential of both T-cell related therapy and vaccine therapies, although I was in the dark about some of the limitations in terms of having to inject it locally. I thought it was quite interesting that it resides locally. It may have long-lasting effects. And I was really also intrigued at how long viral treatments have been used in cancer. I thought it was something new. What I do know, though, is the importance of international collaboration, both in terms of moving things forward, as well as in the treatment of patients, and both diagnosis and treatment. And obviously, everybody can use some help. I've used a lot of help through these last 10 years in asking friends and new acquaintances and everybody to help me to put these things together. And it's really important that we help each other, because together we can make a difference, both in terms of friendships, collaborations, but also in terms of patient care. Let us know, though, I'm talking to the audience now, what you thought of the conference. I thought it was great, but what you've thought and what you'd like to see in the future. I have some ideas, but as I said, we all need some help. And if you can help me to determine what kind of things you'd like to see, that would be helpful. Feel free to explore the website. It's free. It always has been free. I want it to be free because there are people in parts of the world that can't afford anything, but a website is free, and that anybody can who has a computer can afford that. Please review this lecture and past lectures. Use the website as a catalyst for discussion. I've had people in different parts of the world use it as a discussion catalyst, or to learn if you have a particular tumor you want to learn about. And always not just here, not just with me, but with anybody. Always reach out for help, no matter what help you need. The location of the past presentations, again, if you go into the Toronto Cardiac Tumour website, look over there in the past presentations. This one, I think, will be from past experience a few months before you can review all these lectures again, but it's there. Once again, I'd like to thank the Peter Monk Cardiac Center, place where I work. Ontario Health is involved with cancer care in my province. They've given us a nod on this for many, many years, as has the Society of Thoracic Surgeons. I have to really thank my co-chairs, especially Vinod and the planning committee. The speakers, thank you very much for everybody to attend. I really do mean that. The attendees, thank you. A lot of you have come on and stayed on for the whole meeting. Is very, very good. And again, my secretary, Edith Dingle, has done a lot of work in this, and thank you very much. And finally, to Henry and Barbara Bank, who without their collaboration with me would not have made any of this stuff possible from day one. I also want to give a special shout out to this young woman who's only 15 years of age, and she made this poster. I think she's got a bright future, and she's very talented. I want to say officially how much I thank her for doing this and how talented she really is. The Toronto Cardiac Tumour Conference next year is going to be on January 28th, 2026 for the surgeons in the audience. It's on the Wednesday before the STS starts. It'll be the 11th one. And the topic, well, for that, we'll have to stay tuned for that until next year. With that, I'm going to thank everybody once again for coming and bid you all farewell. And Mike, I hope you get out of Houston. The snow will eventually melt. It may not be tomorrow, but it will.
Yeah, it's this strange white covering on the ground, RJ. We're very confused here.
Anyway, I look at the weather in Houston a lot because I like, I have a number of friends there obviously now, but I was surprised the other day when it said -1 Celsius.
Yeah,
And I was more
my
surprised.
wife's family's from Winnipeg, so we look up there and feel good.
Yeah, that's right. Anyway, farewell to everybody, and I hope to see you all next year. Take care.
Thank you, RJ.
Bye-bye.